Good morning, everyone. So I'm very thankful that on a cold Sunday morning at 9 we are about to start the conference. So it is a day-long program as Conundrums 2.0. So the basic theme is a little different this time. We will not be discussing the normal panel discussions. What we have decided today is we'll be discussing only abstracts presented in 2024 which has been practice changing. So we have so many abstracts, so many research papers which come in and go out, but today we'll be discussing which are a game changer or which we'll be using in our day-to-day practice. So who better than Dr. Kunal to start the morning, one of the most jet-setting pathologists in India. And thank you, Kunal. I welcome you.
So, a very good morning to all of you. Thank you, Suman bhai, for setting the tone for the day so well. And I know we are, this is one of the best times to be in Delhi, especially for someone who's from Mumbai, because we don't get to see a lot of seasons. So it's always been a pleasure to be here and a part of Metro group, either as OncoCon or Conundrums. So without much ado, I think we will start with our panel discussion. I would like to invite all my panelists to kindly come on stage. Dr. Aparna Dhar, Dr. Amit Verma, yeah, I have it with me here also. Dr. Charu Dabral, Dr. Charu Bahl, Dr. Srinidhi Nathani, Dr. Shilpi Dutt, this one? Page down, all right. All set. I hope you had your morning tea and coffee. So let's start with the discussions. It's not happening. Shivam? पेज डाउन ही दबा रहा हूँ यार, क्या दबाया? This one? Yeah. Okay. Okay, so lung cancer, as we all know, is one of the leading causes of cancer-related deaths in most countries. About 11.6% and 18.4% is the global cancer morbidity and mortality. 57% of lung cancer is present in clinical stage 4, that is less than 8% survival. And the overall poor survival of advanced stage lung cancer patients is due to mainly two factors. One is that it does not have an effective screening test, unlike cancers like cervical cancer, and also because of relative ineffectiveness of systemic therapies. We know that most but not all lung cancers are associated with tobacco smoking. Squamous cell carcinomas being associated with high tar content tobacco, and adenocarcinomas associated with low to moderate tar content tobacco. And we know that smoking actually causes cancer by accumulation of oncogenic driver mutations, and these are the ones against which targeted therapies are based. So just a brief epidemiology, that it ranks number 1 and number 2 in women for incidence and mortality. It is the most commonly diagnosed form of cancer and is the leading cause of morbidity and mortality. It is also one of the highest proportions in Indian population, and it ranks number 2 in men for lung cancer incidence in India. We know that it is also prevalent in younger patients and never smokers due to rise of oncogenic driver mutations like EGFR and ALK. A brief about breast cancer. We know that it is the most common cancer in women globally. 22% of all female cancers and 26% of cancers in affluent countries. Also, the prevalence in Asian countries is rising. It has superseded cervical cancer, which used to be the top in India, and now it is the leading cancer in women in India. As of today, there are nearly 8 million women suffering from breast cancer. We know that there is a genetic inheritance associated with breast cancer. Genes like BRCA1, BRCA2 and PALB2, they greatly greatly increase the risk and also show high penetrance. About 50% of breast cancer cases occur in women with no identifiable prior cause. And we know that breast cancer is a molecular disease with different genetic signatures, and so the individual risk of recurrence differs from patient to patient. Now let's set the ball rolling. So our first case is of a 40 years old female patient with mass in right breast, which was diagnosed as invasive ductal carcinoma, no special type, grade 2, MBR score 7. It was ER positive, PR positive, HER2 was negative, score 1+. Ki-67 was 12%, and it was a T3N2 disease. Dr. Charul, I would like to ask you first that is there any further investigation at the outset that you would like to do in this patient? And also if you could tell us a little bit about the molecular classification of breast cancer.
So the molecular classifications are luminal A, luminal B type, and triple negative breast cancers.
Right.
Luminal A is which is hormone positive, that is ER/PR positive and HER2 negative.
Right.
Lumen B are ER/PR and HER2 positive, and the triple negative are hormone negative and HER2 negative cancers.
Right.
And then there is other subtype also, HER2 enriched type, which we
Right.
are talking about.
Right.
And the other investigations in this case, maybe some mutations like BRCA and all BRCA mutations can be done.
Okay. Dr. Aparna, I would like to ask you if there is anything else that you would like to do in this patient at this stage.
So she's a 40-year-old female. She's young. Obviously, I'd want to know she has a family history, but even irrespective of that, she would be a good candidate for hereditary testing.
Right.
We have evolved. We don't just do BRCA1, BRCA2. So we go in for a slightly more comprehensive panel where we look at some 20, 25 odd genes that are associated with hereditary breast and ovarian cancer. So we do NGS and MLPA, so germline testing for sure.
Right. So that's exactly what we would go ahead with. Dr. Charul has already outlined the molecular subtypes of breast cancer. There is also a Claudin low subtype, which is triple negative, but it lacks CK5/6 and EGFR. So this patient was, as I told you, ER/PR strongly positive. The patient progressed in 6 months and showed bony metastasis. So what do you think we would like to do next? Dr. Srinidhi?
Even if you do repeat, so because I'm from the molecular background, if it's a bony metastasis, that tissue is not going to be good for me to do an NGS.
Right.
So probably a liquid biopsy just to look at the clonal evolution, if at all.
Okay.
And the other thing maybe clinically important in this case, since she's hormone positive and young, would be an oncotype DX, because that would also give you a risk and also a hint that whether a chemotherapy can be whether you should initiate chemo or what you should do. So at the outset, an oncotype DX would also not be.
Sure, I think relevant points made. Oncotype DX also helps these days in staging. It is a part of the CAP staging, so that is something that can be done. Now, so this patient, we did NGS in this patient. Yeah, Dr. Amit?
So I would like to know what was the adjuvant treatment given to the patient. Can I have the answer? Before 6 months, it's too early for any early.
So this was a hormone positive. So it was hormonal treatment that was started for this patient.
CDK4/6 inhibitor given as
so NGS wasn't done at that time. So
now the guidelines says the abemaciclib can be given for the node positive disease as a.
I'm coming to that. I'm coming to that.
Clinical standard of care. I mean, I completely appreciate and understand that we have a panel which is path overloaded or loaded, whatever you call it. But I mean, how can you, recommend oncotype DX for a case like this? This is a high-risk hormone receptor positive patient. And I would, if you take a poll on the clinicians, nobody would ask for an oncotype DX.
Anybody has any thoughts to that?
Based on the T3 and 2 disease, oncotype DX is not better recommended. But K of 12%, there may be some ambiguity. But with a younger age, I don't think oncotype DX is recommended in this juncture.
No, I agree. The thing is, this was initially to start off with, it was a potentially curative, no? If you say although it's a locally advanced So again, the point raised was how come a locally advanced, so some potentially curative treatment would have been given, including some hormone factors essentially. And for such a disease to fail within 6 months is unusual. Yes, it did. And as Hemant sir also said, I think we generally reserve these Oncotype DX for the early stage patients, T1, T2, N0 or N1, in which I think you can do these tests also for other reasons.
to assess risk of recurrence or staging.
So, but in clinical practice, what we do is we advise these tests to choose whether we need to add chemotherapy over and above hormonal therapy by sort of triaging these patients into, say, a low risk or intermediate or high risk. That's
valid point.
Yeah.
So NGS was done on this patient and it showed ESR1 mutations along with CDK4 amplification. So Dr. Shilpi, would you like to outline a little bit about ESR1 mutations and what it would mean in this patient? Acha, I don't know, ma'am, I didn't get your name, sir. Dr. Imusha, would you like to? All right.
So usually NGS is done to see for the point mutations, and MLPA is done to see for the duplications and deletions.
Right.
So in many cases in which the point mutation is negative, you can get deletion duplication. So customized MLPA will help in identifying this. So multiple abnormalities can also be found, especially in the patients with a hereditary or a susceptibility. And so in these cases, actually combined therapy would be better, but oncologist would be more wiser in the approach in these cases.
Dr. Amit, any thoughts on this?
So no, usually ESR1 mutation, which is the androgen receptor mutation, where the hormone does not work further, usually happens in the acquired kind of a pattern, post-hormonal therapy. But what we also know that it can be pre-existing, it can be de novo, and it can enhance, or you can say select under the pressure of hormonal treatment. So you may have underlying ESR mutations where you will see early failures on hormonal treatment, but it is not a usual norm for us to do all the ESR mutation upfront to find out who are de novo hormonal resistance to begin with. So, but once we have the explanation ESR1 mutation present, then yes, the hormonal therapy is not going to work the standard one. We have to go something different actually.
Yeah. So it is an inhibitor to the response to a hormonal treatment, and so the patient was then further given abemaciclib and fulvestrant. And so the point I would, I was trying to bring out here was, why NGS testing is important besides the usual ERP or HER2 Ki67 in such cases, and what we can do. This is just another case which we encountered at a similar setting. This was a 50-year-old female patient, mass in left breast, IDC NST grade 2, MBR source 6, ER was positive, PR was positive, HER2 was negative, score 1+. This again, the patient presented with metastatic bony lesions, was started on letrozole and palbociclib and progressed after 2 years. So Dr. Charu, what would you like to do in this patient now?
Started on letrozole. Okay. So I think doing next generation sequencing on the new meds.
On the new meds?
Yes, that is important to look at the profile, genomic profile.
Yeah.
And
that's a good thought, but
look at the ERPR status again, because that might have also changed in the progression. So
HER2 also, would you like to do?
ERPR HER2 status, that is very important, because on basis of that the whole treatment direction might change, because we have seen a lot of cases where patient do become hormone HER2 positive or transition from HER2 negative. So and in addition to that, the NGS will.
But I wanted to know from you, since these are bony lesions, how comfortable are you to do NGS from metastatic lesion?
With the bony, sometimes they do have some regions where there is soft bony tissue, because we do a lot of testing with sarcoma patients where we get bony soft bone. And we are trying to do it. If we fail it, we can do a liquid biopsy. But for ERPR and HER2, I think bony lesion you can do an IHC. Once you've done an IHC with liquid biopsy, you can definitely do the complete profiling along with MSI-TMB. That is available now.
Dr. Aparna, liquid biopsies, yeah, I got that point, yeah. Since we are running little short on time, I'll be a little quick. Your thoughts on liquid biopsy at this stage in this patient?
So I do see bony mets, yes, while if we can get a biopsy, I'd love to do an ER/PR HER2 again.
Right.
But I do know from a good laboratory, a good liquid biopsy at this junction would be very beneficial for this patient for picking up resistance mechanisms.
Right. So then fulvestrant was added and the patient again progressed after 6 months. Patli was added but the patient couldn't tolerate. So do you see any option now in this patient?
Was BRCA testing done for this patient?
No.
So maybe germline BRCA would also be an option here.
Right. Anything based on the ER/PR status or something else that you can do at this stage?
So I think because it's a second case, PIK3CA mutation is a must in this particular case. It has not been done. We have not discussed at least.
Right.
And the patient is progressing on the palbociclib and letrozole and then fulvestrant with, I hope that was given with palbociclib.
Yeah.
So definitely we have to look for other explanation of why the patient is not responding, and PIK3CA seems to be the most probable alteration.
Correct.
More than 1/3 of the patient will show these alterations actually.
Absolutely. So that is one point that I wanted to bring out, that PIK3CA is something that should be done for this patient. And anything else, if the patient is progressing still, that's something that you can do based on the patient profile. Dr. Charu, you were saying something?
So depending from the HER2 profile, like she was HER2 positive, which is I
Right.
think low HER2 is a lot newer concept which is come
Right.
up. So
if you could just define what is low HER2 for everyone.
Basically low HER2 is when you have one positive on IHC, that is called low HER2, and
So-
there is a
right.
category where they can administer HER2 inhibitors for those kind of
Yeah,
patients.
so HER2 low is something which is 1+ on IHC or 2+ on IHC but FISH negative.
Fish neck.
Yeah, and I mean we also have a HER2 ultra low these days. So these are patients, as we know, that these are patients who have been shown to do very well with trastuzumab deruxtecan or Enhertu. So now let's just quickly touch upon lung cancer, couple of cases of lung cancer as well. So we know that in lung cancer we've got a lot of driver mutations. Lung cancer has been the poster child for molecular mutations, and this chart just shows in a snippet that what are the major mutations that we encounter in our day-to-day practice. So let's see one case. This is a 75-year-old male patient presented in year 2020 with dyspnea, cough, chest pain and episodes of hemopsis. Ex-smoker, stopped 22 years back, has smoked approximately 30 pack years. On PET-CT we saw a 4 × 3 centimeter mass in the left lobe along with mediastinal nodes and isolated brain metastasis. This is how the tumor looked. It was mainly present in, it was in islands, and these were larger cells. So this was non-small cell lung cancer, and TTF1 was diffusely positive, and so was napsin. So, I mean, what would you like to do next, Dr. Anusha?
So depending on what, actually now since NGS is available and we are able to do NGS in 10 to 12,000.
Right.
So one can do a panel testing initially.
Right.
And if it gives some positivity, according to that, some targeted therapy can be given to the patient.
So I'm not going to ask that question that whether we should go for a single gene or an NGS panel, because that's becoming irrelevant as we move with time. So I'll just tell you what happened with this patient, and we did go for NGS, and we encountered something very special. So NGS first showed EGFR exon 19 deletion. The patient was started on erlotinib, given SBR, PFS was 11 months. 2021 patient progressed with another lung lesion, was started on dacometinib. PFS 4 months. 2022 progressed, developed new lung lesion, was started on osimertinib. PFS 9 months. Progressed and now presented with liver, bone and brain metastasis. Liver biopsy showed metastatic adenocarcinoma, again positive for TTF1 and napsin. PDL1 was positive with a TPS of 5%. The patient was continued on chemo with PEM-carbo, and a repeat NGS was done, which showed exon 19 and ROS1 fusion with GOPC. So, Dr. Amit, I would like to ask you that how often have you encountered mutations which are usually considered to be mutually exclusive? And have you seen something like this?
So compound mutations are reported as the technology is getting better day by day, and approximately less than 5% times we see these kind of compound mutations.
Right.
But rare things can happen because of the heterogeneity, and because of the selection pressure of the previous treatment can also bring all these compound mutations very clearly.
Right.
As we can see that the patient have a standard ROS1 fusion with exon 19 deletion still going on, with absence of the classical T790M mutation or other MET amplification which can explain the resistance to osimertinib was not present.
Right.
It clearly tells me that the ROS1 was present from the day one, because that can explain why the patient failed on the first line and second line and the third line TKI, and that can explain. So while we are giving the patient ALK inhibitor alone, the patient may still progress because the patient still have the EGFR del19 mutation actually. So how to deal with these situations is a difficult discussion, and the molecular team board can give the answer in the best way. But these compound mutations are possible.
Right.
For some explanation which we do not have actually. Why?
Actually, what is done is a panel, and in that the read depth may not be high. When we are looking for somatic mutations, you have to do a better with a panel with a greater read depth.
Right.
If the read depth is higher, then you will get the other variants also which are low in frequency in that sample. So, so if you do a panel for especially for this targeting somatic mutations, then only you can get all types of abnormalities with these.
So, Dr. Charu, your thoughts on this? Like, have you encountered something like this, and do you agree with Dr. Amit's thoughts that it would have been ROS1 to begin with?
That's what I was also thinking.
Okay.
On the similar lines actually, because it's very, not very common to see 11 months of PFS with exon 19 alone. Mostly there will be a secondary mutation which will be there. So I just wanted to know whether only, or like, was there a limited panel which was done, or it was that information?
So this patient had come to Fortis Gurgaon. The primary report was somewhere else, and then the repeat NGS was done it was an in-house test which showed the ROS1 fusion, and the ROS1 fusion, if you see, is not with a very commonly encountered partner.
Oh yeah, it will be, so that's what I'm saying. So
Yeah.
the panel would not have a complete coverage for the all
Absolutely.
ROS1 partners.
Absolutely.
So you need to have an RNA fusion based panel where
Absolutely.
you can pick up all fusion partners and all possible.
So that's also one of the messages that is important, that we have a lot of panels in the market. So it's important that we see that what kind of a panel it is and whether it is covering everything that we need.
And to add to specifically for lung, we need a panel which is combustive in terms of DNA and RNA, because that is what is going to give you the complete picture. With a EGFR exon 19, you can have a EGFR amplification. You can also have a ROS1 fusion. You can also have a MET amplification, which we see sometimes now, which completely changes the.
Right. So I mean, this was an interesting case, and we did find some literature around the same. And what we also saw was that the fusion partner, which is usually CD74, was not the one that we saw here. It was GOPC, which is usually seen in glioblastomas, brain tumors. So I mean, this case was pretty rare, and it was quite interesting. Let's see one more case of lung cancer. This is a 60 years old male patient. History. Also, I just wanted to ask your thoughts on on NGS in early stage lung cancers. Like, how often do you do it?
Yeah, we're getting it for now, stage 2 and stage 3 patients. We are getting in basic panel NGS. Even for those patients, they are okay to do a 12 gene and 18 gene panel, because they want to look at EGFR, ALK, and ROS and PDL1. These are 4 markers which they, for EGFR and ALK, they do a target therapy, I think, these days.
Yeah, so they have the ADURA and the ALINA trial. So
So for stage 3 patients, we are definitely getting NGS. Like, we are getting biopsies, and we are doing.
And another very important thing to note, that in these kind of settings, you will get the PDL1 report probably in 1 or 2 days, but your NGS report will take time. So for all the, for the treating clinicians, the younger ones who are more eager, you should wait for your NGS report to come before, we start with because we know that the push for immunotherapy is very high these days. So this is another case of a 60 years old male patient, history of smoking 50 pack years, stopped 1 year back, cough since 3 months, weight loss and hemopsis. PET CT showed right-sided lung lesion involving the pleura and mediastinal nodes were positive. Dr. Charul, if you could just briefly tell about the histopathology. I'll quickly wrap it up.
Yeah, so it is like, it's a tumor which is arranged in sheets and nests, basically with large cells and hyperchromatic nuclei. So basically it's a non-small cell carcinoma.
Right, right. Dr. Srinidhi, what would you like to do further? Any role of IHC you see here, or would you want to go ahead with?
Yeah, you should do an IHC, at least a basic TTF1 and
Right. And why do you think that would be important?
Just to tell us adeno or squamous.
Right. So even if you see, just give me 2 minutes, I'll wrap this up since we started a little late. So it's important to see that, something that even if overtly looks squamous, it might have an adeno component. So it's important for us to know that that is present or not. So we did a P40 in this case, which was diffusely positive. So this was actually a case of squamous cell carcinoma. So what next? Would you like to do molecular testing in this, Dr. Aparna?
Absolutely. I think in squamous too, we have started, and it's recommended.
Absolutely, absolutely. So Dr. Srinidhi, you were saying something on this?
I mean, we did close to 2,000 cases, and we did find EGFR and 2% of met exon 14 skipping. So we should do it.
So even in cases of squamous cell carcinomas, and especially the ones where you suspect an oncogenic driver mutation, it is very important to do this testing. PDL1 was high positive, 22C3 was about 90% TPS. We did do the lung cancer panel, and EGFR was negative, all other markers were negative, but ALK came as imbalance. Dr. Amit, how often do you see something like this? Are you aware of something?
Is it that 3', 5' imbalance? Is it that which was reported, or what?
No, I mean, we did the regular NGS panel, and we did not pick up, ALK didn't come as positive. We even did FISH testing in that. ALK came negative, but it was showing some imbalance, exonic imbalance.
So nowadays we do give some reports which say 3', 5' imbalance in a gene, which are involved in fusions. So that is a indirect hint that there might be a fusion for which the partner is not present in the panel.
Correct. So what would you like to do? Would you consider this as ALK positive?
So did you do an ALK IHC?
That is the message that I wanted to drive home. So what we usually do in these cases is that we do a supplementary testing, which can be very easily done in cases of ALK with just an IHC test. We did an ALK IHC and it was negative. So primarily this was treated as an ALK negative case.
So actually, nowadays we have RNA sequencing. In RNA sequencing, you can detect gene expression of all the target genes. So if you do RNA sequencing and you see the expression of particular target which you like ALK or EGFR, so that you can find out on the RNA sequencing with ease. So combination of RNA sequencing and DNA sequencing and a method for the detection of deletion duplications. If all three are done, then you are more wiser in finding out what is the likely
for ALK, I would say we did a study where we compared IHC FISH and NGS. I would say IHC is still the winner in ALK at least.
That's true. I think IHC is accepted as a gold standard as far as. Sometimes you can even after RNA fusion you can get ambiguous results in cases of ALK. So the driver message in this case was that a supplementary testing can probably take us home in this case. Because of paucity of time, I will not discuss the final case. It was just basically a case of enteric adenocarcinoma where all the lung cancer IHC markers were negative. We had 7 and 20 positive, TTF1 and napsin were negative, CDX2 and SADB2 were positive. The patient had come as a second opinion because they thought that it is Mets of colorectal origin, and TTF1 and napsin being negative, they didn't realize it could be pulmonary enteric adenocarcinoma. And also in molecular profile, we saw EGFR was wild type, but HER2, KRAS and BRAF were mutated. So I think with that, I come to the end of this panel. I would like to thank all my panelists, for their very valuable contribution, and for everybody in the audience for their patient listening. Thank you. A warm good morning to everyone. Now I invite stalwarts in oncology for the inauguration and lamp lighting ceremony with Dr. G.K. Rasser, founder of National Cancer Institute, and so many institutes he has given birth to. Dr. Rath, Dr. Hemant Malhotra sir, President-elect Indian Society of Oncology, current President Indian Oncology Society, Immuno-Oncology Society of India, Dr. Arvind Krishnamurthy sir, Honorary Secretary Indian Society of Oncology, Dr. J.D. Patel sir, former professor at GCRI, Dr. C. Sairam sir from Hyderabad, Honorary Secretary elect IMA from Hyderabad, and Dr. Saman Gupta. And Dr. Toprani sir. Shivam, can you call Dr. Toprani sir immediately? I request all dignitaries for a group photograph this side, on the stage. On the stage, it will be good, sir. Sir, इस तरफ से आ जाइए, sir. This will be good, sir. We welcome Dr. Toprani sir, President Indian Society of Oncology and Director SCG Cancer Center, Ahmedabad. I would invite the next faculty, Dr. Hemant Malhotra sir. Sir is Director Shri Ram Cancer Center, Professor and Head Department of Medical Oncology, Mahatma Gandhi Medical College, Jaipur, to moderate the discussion on early TNBC.
Thank you very much, Rajesh. Good morning to everybody. And my topic was early breast cancer, and I've taken the liberty of changing that to early breast cancer, triple negative. We had some discussions yesterday evening on triple negative breast cancer, so we'd like to continue that. I'd like to invite my panel. Dr. Tejinder Singh, I think, is not there. Dr. Samir Kaul. Okay, Dr. Samir is a well-known surgical oncologist from Delhi. Dr. Sairam. Dr. Sairam is a very senior radiation oncologist working in Hyderabad. A pleasure for me to inform you that he is also the National Secretary of the Indian Medical Association. So if you ever get stuck in some sticky situation, he is the man to approach. Take his phone number today only. Dr. Aditi Chaturvedi from Delhi. Are you there, Aditi? Aditi is again a dedicated breast surgical oncologist. Dr. Ishu Gupta, I am told, is on the way. He is a medical oncologist from Delhi. Dr. Puneet Nagpal is a radiation oncologist, a well-known radiation oncologist from Faridabad, and he is one of the hosts for this meeting. Dr. Mansi Chauhan. Mansi is a surgical oncologist again. Is Mansi there? I'm told that she's on the way and she will join us in the middle. Also, we have induced Dr. Pankaj. So we were, a little short of medical oncologists, and obviously I have an inclination towards medical oncologists. So Samir, welcome. There is the big man. Samir, you're just on time. Come straight to the panel. You've lost a lot of weight. You're looking really trim and slim and smart. Wonderful, wonderful. So without much ado, let's start the panel discussion. And sad to tell you that my slides are not moving. Okay, so my sincere thanks to the organizers of this meeting for this opportunity, particularly my very dear friend Dr. Sumant. Thank you. I bring you greetings from the Shri Ram Cancer Center, Mahatma Gandhi Medical College Hospital. We've just got the NAC A+ recommendation. We're very happy and proud about that. So this is, let's start with the case. So is my panel ready? We have a 41-year-old premenopausal lady, 6-month history of a lump in the left breast. On examination, there's a 5x4 centimeter lump, upper outer quadrant, left breast, with palpable mobile ipsilateral axillary lymph nodes. Good general condition, general examination, systemic examination normal, no known medical comorbidities, no family history. CBC, blood sugars, RFT, LFT, X-ray chest ultrasound, all normal. Bilateral mammogram, other than the lesion in the left breast and the left axilla, no satellite lesions, and contralateral breast is normal. Core biopsy is being done, IDC grade 3, ER negative, PR negative, HER2 by IHC is 1+, so HER2 negative. So we have a working diagnosis of clinical T2N1 M0 triple negative breast cancer. So my first question is to Dr. Samir. Samir, this patient first comes to you because you are a well-known oncologist. How would you proceed? Any further investigations you would want to do, or you would straight away start specific treatment?
So what is basically now you presented is basically a triple negative cancer, which is HER2 new low, and at the same time it's a large size tumor. So although it's early breast cancer, I still feel that it is a locally advanced because the size, the T size that you told me is fairly large. I do not know about the overall size of the breast, but am I assuming it to be a moderate sized breast? So this is something that would qualify for not for upfront surgery at the present moment. Now, as per what's now evolving, I think one is not completely. One would like to know a few other things in a triple negative cancer today, and one of them would definitely be the molecular assessment for markers. So biomarkers, as per the last ASCO also that was done, is moving up the grade, and so therefore knowing that whether immune therapy and its biomarkers would definitely like to be investigated. And there is consensus today that possibly, as far as the breast is concerned, PD1, PD-L1 would be more relevant than a tumor mutation burden or MSI assessment, although the other two are also important. And if you get a concordance of all three, that would have a higher yield than PD1, PD-L1 alone. This would qualify for upfront therapy.
We'll come to that. We're just talking about further workup just now. Pankaj, would you want to add anything to that?
So I think since I think maybe sir should have said this, MRI will be good. That if I'm planning to offer this patient a BCS, a young patient, usually we go for that. Not essential, but usually in this TNBC with lymph nodes involvement, I do prefer to get PET scan, though not essential. So metastatic workup, it can be either X-ray ultrasound or a bone scan, which can be sufficient, or get a PET scan done. PD-L1, not essential to offer immunotherapy, but it's better that I have it so that if I analyze later on my data, I have few things right in my hand. Then BRCA test. These are the things which I will ask.
Okay, anybody wants to add anything, the panel or the audience? Anything more needs to be done in this patient? So Aditi, Dr. Sairam, Puneet? Okay.
Metastatic workup, yeah. I would prefer a PET scan in this case, a metastatic workup definitely. And FNA axilla also, I would generally want, an FNA axilla has been done, I would want an FNA to be done.
Right.
So that even if a node is clinically palpable, we have a pathological diagnosis up front, because she will probably be going for neoadjuvant therapy and BRCA, all these three.
Yeah, so PET scan has been, yes, Sairam, please.
As per guidelines, PET CT is not advised, but
PET CT is not mandated, but most
CT
of
scan
us
chest
would.
is advised, but if CT scan chest is done, I would better do bone cancer.
Yeah, like if you don't do a PET scan, then you have to do a CT of the chest and the abdomen and a bone scan. So ultimately, if you look at costs, the PET scan turns out to be a little cheaper. So most of us, at least in my practice, in a patient like this, I would do a PET scan. But anyway, I do understand and agree that it is not mandated. So PET scan has been done. It is we have a non-metastatic disease. And as been mentioned by Aditi, FNAC of the left axillary node has been done. It is positive. Peripheral blood for BRCA germline has been sent. So we have a final diagnosis of IDC left breast, clinically stage 2 N1 M0. So let me go to Dr. Aditi again. So triple negative breast cancers, about 1/5 to a quarter of the patients are TNBCs, little more common in India. So we have a lot of oncopathologists here in the audience. Aparna, can you just concentrate over here and you can have your chat maybe after. Do you think that TNBC is more common in India as compared to the West? Right, so incidence probably as per Indian literature is that about 1/3 of the patients will turn out to be it. And of course these patients have present at younger age. Many times they are BRCA mutation carriers. The hallmark of the disease is that they develop drug resistance quickly, and TNBC connotes a whole bunch of different diseases. It's not one single disease, usually more aggressive than other subtypes. 5-year mortality is about 40%. And they carry a high risk of recurrence. Usually the recurrence happens to visceral organs or the brain, less commonly to bone. And this is the heterogeneity of the triple negative breast cancers. You have these 5, 6 or 7 types, the basal-like 1, basal-like 2, luminal androgen receptor type, immunomodulatory type, mesenchymal type. But most of us actually don't look for this very carefully, because as of just now, there are no treatment implications if you identify any one of these 6 or 7 types. So now, Aditi, you have the mic in your hand. This patient first comes to you. Would you ask for a PD-L1 testing? And if you do ask for it, what assay would you use? Is it essential for you to know PD-L1 before starting treatment?
For metastatic triple negative, not for the for non-metastatic I would not have
Wonderful.
asked, but for metastatic, yes. Which assay, I would ask Dr. Aparna to come in as far as which assay is concerned. But yes, I would ask.
Pankaj, agreed? Would you ask for a PD-L1 at diagnosis for a patient like this?
It's not essential, but it's always better to know so that we analyze later on the data, we have things, because both are valid if it is positive or negative. But then we know the prognosis that.
Yes, so you may or may not get it done, but it is not mandated to start treatment. And I don't know whether my oncopathologist would agree or not. PD-L1 testing is all over the place. I wish that you guys would get together at the national level and at the international level and sort out this confusion, which I don't think is going to happen in the near future. And yeah, take a mic, sir. Mike, can you make a comment on the mic?
At the last ASCO, December 23, I think now there are enough randomized trials which have sort of clearly proven that PD1, PD-L1 needs to be part of the armamentarium of TNBC treatment today.
In the metastatic setting, as Aditi mentioned, it is mandated because that will change the choice of your treatment, but upfront it is not mandated. And you know, yeah. Yeah, and we know about the CPS, TPS, and immune scores, and I mean, I still have trouble in understanding all this, but maybe that's just my age. Okay, so who is left? You take the mic. This patient first comes to you, this much of workup has been done, how would you treat?
Sir, I'll refer the patient to medical oncologist for chemotherapy first and then followed by surgery.
Okay, you would first send the patient to the medical oncologist. And what about you, Samir? This patient first comes to you.
I would go clearly today, this patient with a 4 to 5 centimeters tumor should go first to a medical oncologist.
Wonderful. If we've been able to convince our surgeons and our radiation oncologists that if the patient comes to them, CAR-T though, that's a huge achievement in the past 10 years. So Pankaj, the ball is in your court. You're the only medical oncologist on board, so how would you treat?
So first I'll thank the surgeon.
I've already done that.
I'll be offering pembrolizumab to this patient in combination with AC and that weekly package. And before that, I'll do whatever necessary workup has to be done. Usually we ask for the thyroid function test, the cortisol, the hepatitis serology, and ruling out any, though there is no evident contraindication, and all the routine workups. And then I'll offer ACT and pembrolizumab based therapy to these patients.
Wonderful. Any discordance of opinion amongst the panel or amongst the audience?
So it will be carboplatin. As per the study, it has to be carboplatin. AUC 1.5. Sir, sorry, I have probably missed out. It's AC and Paclicarb. So carboplatin, I missed it. So Paclicarb, carboplatin is AUC 1.5 weekly, or you give it AUC 5 3 weekly. So routinely I use it AUC 1.5 weekly.
Why would you?
Vaccine is also weekly.
Why would you use in this young fit patient weekly? I would be happy to use
the
it.
standard regime which has been used, it has been, the taxane has been used weekly. And the tolerance is not that good. Let me tell you that when we give this pembrolizumab, especially with AC, neutropenias are severe. So I don't know whether anyone else has experienced this, but really when I start complete Paclicarb with Keytruda, when I introduce AC, I keep the dose 10% less in the first cycle because I'm always afraid that patient will have severe neutropenia.
So I don't reduce the dose in the first cycle. If there is grade 4 neutropenia, then only I reduce, and I give them primary prophylaxis with long-acting growth factors.
Still that,
so how many medical oncologists in the audience? Show of hands, please. Yeah, so Dr. Chopra, do you feel that you need to give, in a curative setting, lesser than optimal dose of chemotherapy drugs? But it's a matter of choice, I do understand.
Just a word. I mean, I have been practicing paclitaxel prior to the AC. And the reason is that Dr. Buzdar and MD Anderson came out with primary studies to show that taxane prior to the AC is superior to the AC followed by the taxane.
So there has been a meta-analysis on this, and that turned out that it doesn't matter. Though there were, as rightly said by you, there was few suggestions that you give taxane first. But then all these meta-analyzed, they said that it doesn't matter what you give first.
You know, they had basic science studies to prove that taxane prior to AC has...
Yeah, there was a study from our own country, from Tata Hospital, Sudeep and his group, which did do Paclitaxel 4 cycles first, followed by AC, and that is a recommendation for Keynote 522 also. So but it's a matter of choice. I personally feel that it doesn't make a huge difference. And if you have a more than 2 centimeter triple negative breast cancer patient who is keen for breast conservation, then like one more kind of a reinforcement to our surgical oncologist that this patient is likely to have a systemic disease to start with, likely to have micrometastasis to start with, even though the tumor is not very big. So the best treatment for this patient, not only keeping local response rates in mind, but also taking care of these micrometastases and preventing metastasis later on, best is systemic treatment first, followed by local treatment. Agreed, Samir?
Absolutely. So, and the choice of the immunotherapeutic agent, I think there are enough studies now with
we come to that in a minute.
Atezolizumab.
Yeah, there are a lot of studies for that. Yeah, we'll come to that in a minute.
Just a question. What endocrine workup do you do before you consider an IO?
We usually ask for the cortisol thyroid function test and the insulin levels. So that is the standard one, and along with that hepatitis serology and all that.
So the treatment options, here are the first line treatment options for you. Level 1 evidence preferred is Pembro plus chemo, and you could use Nab-Pacli or Pacli or Gem and Carbo. So that is the level 1 recommendation in the latest version of the NCCN. And we have this study which we discussed a little bit yesterday evening, presented at Barcelona this year, a couple of months back, the Keynote 522 study. Also a simultaneous publication in the NEJM last month. This was the schema of the study. I think all of you know this, 2:1 randomization. And you could, just for your information, Pankaj, you could use the carboplatin either 3 weekly or weekly. You had, 5 AUC, and it turned out to be a positive study on our holy grail, significant improvement in overall survival at the 5-year endpoint, hazard ratios of 0.66 and a highly statistically significant p-value.
How many of your patients do complete all these cycles, like 8 cycles of chemotherapy before they go in for surgery? Or
so about 80 to 90% of my patients do complete.
Yeah, that's what I feel, that around 20-25% of the patients I have to miss the last cycle. The tolerance goes so down because of these neutropenia.
That has not been my experience, at least with the younger group of patients. So my question to Dr. Aditi, yes.
But this is my personal experience. When I stick with the AC and Pembro, neutropenias are severe, and at times in 15 to 20% of the patients, I have to leave the last cycle. And this happened in the trial also. Not all the patients were able to complete all the therapies.
So my question to our 2 surgeons on the panel, Aditi and Samir, post-neoadjuvant chemo and post-neoadjuvant chemo immunotherapy, when the patient comes to you for surgery, do you have any specific issues? Is the surgery more complicated, difficult, more bleeding, late healing? Or it's just like if you were operating de novo on a fresh case? Both of you, one by one.
So, one thing, so I'll just come to your question. The other thing is that before we start neoadjuvant therapy, clipping of the tumor bed, I would recommend strongly at presentation. If it's a small tumor, if it's a big 5 centimeter, we can probably do it after 2 cycles.
My apologies, I missed that. I did want to bring that up, but you're absolutely right. You have a complete clinical and pathological response rates in these patients of in excess of 50%. In more than half of your patients, there will be nothing there. Dhoonte reh jaoge. So you must clip it for the surgeon, right? So that is my apologies to you, and thank you for pointing that out. Now my question.
Yes, sir. And as far as complications or introp issues are concerned, I think post-neoadjuvant therapy, we are quite well versed with doing that. And the only thing is, in some cases, very few cases, you will have perilesional edema, but it really doesn't bother a breast surgeon. I think we are quite comfortable with breast conservation or mastectomy, whatever the case might require, and I don't see any increased complication rate.
Samir?
The only thing is
Yeah.
sorry.
Yeah, go
The
ahead.
only thing is margin assessment for the pathologist may become challenging. If you're using frozen section routinely, which we do, then telling the pathologist that this is a post-chemo setting case, so they need to be more careful in grossing and in microscopically examining is mandatory, nothing else.
So our oncopathologists agree? Yeah, so you have to know upfront that this patient has received neoadjuvant chemo or neoadjuvant chemo immuno, and you have to keep that in mind, right?
Just a word.
So I think
Timing of the surgery post-immuno.
So Pankaj, when will you send the patient to the surgeon?
Sir, there is no contradiction or we don't have
so-
to delay.
so
We
usually
can go
3 to
as
4
per our
weeks,
schedule. They go by their schedule. One thing to add, thyroid function test is notoriously, deranged in most of these patients. So previously we were taking it lightly, but now on 7th cycle or alternate cycle, we do test for thyroid function test.
Yeah, I do it every cycle. I do it.
I have a comment to
Samir,
make
please,
and
go
a
ahead.
question to ask. In such a patient, will be asked for preoperative examinations and monitoring. Would the estimation of minimal residual disease today make some sense? And if it does, and would that have an impact on what is going to happen thereafter? Number two, the comment that I'm going to make is that the innovation is only in axilla. Innovative treatment of the axilla, which is sort of been de-escalating over a period for the last 30 years now. We've mostly come to the sentinel lymph node biopsy and its pitfalls. Now I'm sure a patient like this would qualify for, as on today, enough indications. One needs to think more and more in terms of mapping. Axillary reverse mapping of the axilla and whatever you can, and of course, doing as less of axillary surgery as possible today makes sense according to whatever randomized control trials in the phase 3 have been reported even in December 23 at the San Antonio symposium. So due consideration needs to be given, first of all, to choose people who can omit axillary surgery today, because there have been some practice changing findings in this. One of them, for instance, omitting of axillary surgery in particular age groups. In a patient like that, if at the end of neoadjuvant chemotherapy, your sentinel lymph node biopsy shows you a negative axilla, or up to 2 nodes, not more than 2 nodes.
Okay, so a question to the two radiation oncologists on the panel. This particular patient has had a clinical and a path CR, and she's opted for MRM. She said, निकाल दो, मेरे को conservation नहीं चाहिए, which happens in a few patients. So would you radiate or would you not radiate, and what would you, adjuvant radiotherapy, adjuvant in this setting, what would be your yardsticks and indications for radiation and no radiation? Puneet, you start and then we'll go to Dr. Sairam.
Sir, initially it was 5 centimeter tumor, young lady, and 41 year age, along with that TNBC. These are soft indications to give radiation.
Even if the patient has had a PET CR, right? You would go by the initial disease burden.
Yes.
Fair enough. You agree, Dr. Sairam?
Yeah, BRCA1 also I would test triple negative breast cancer.
So we've already sent the BRCA1 and we're not talking about that today in our panel.
Yes.
Samir, you have?
Triple negative breast cancer is aggressive cancer, but we didn't know about immunotherapy, post-immunotherapy things, but as such as a triple negative breast cancer, node positive is an indication for radiations.
So if initial
Yes, yeah, Amit.
initial lymph is positive, do we still go for sentinel in any case?
Let the surgeon answer that. Yeah, maybe Mansi can
So
start.
we can,
Aditi.
if the initial lymph node was positive, we can still offer post-chemo sentinel, provided it was N1 disease at presentation. That means it wasn't a very bulky positive axilla at presentation, firstly. Secondly, the patient should be clinically and radiologically node negative. So basically you need a thorough ultrasound of the axilla up front, FNA of the axilla up front. Be sure, if possible, if you've clipped one axillary node, that's even...
So do you clip the axillary nodes?
So we are not doing it, to be honest. We've we tried doing it, but there are a lot of technical issues with clipping because the clip in the breast stays, the clip in the axilla migrates, and putting a wire in the axilla is also quite tricky. But we did a study as a part of our DNP thesis about post-chemo axilla, and we saw that in triple negative and HER2 positive patients, this is consistent with world literature. If you are doing a post-chemo sentinel, if the patient was N1, now N0, and you're taking out at least 3 nodes using dual dye, you get a false negative rate of around 9%, which is acceptable. So in those cases, yes, you can, but you have to be very sure that it wasn't an N2 axillary presentation.
Samit, quick comment?
Axillary lymph, ALND, axillary lymph node dissection is actually a no-no today. So a targeted surgery for the axilla makes more sense. Apart from an ALND, a targeted surgery of the axilla, more and more it's going that way, and we are slowly going that way, there's no doubt about it. De-escalating the axillary surgery by choosing wisely, like for postmenopausal women, small luminal cancer, N0, you wouldn't even think. So surgical staging of the axilla is not making sense anymore. And of course, in such a setting, and if the radiation is envisaged, then another objection against ALND today, although I hate to admit it, being a surgeon, is that axillary radiation therapy, lymph node radial therapy, is by the RCTs equivalent to an axillary lymph node dissection.
So final comments on this from, yes sir. Can somebody give Dr. Rath a mic, please? We want your words of wisdom to be recorded, sir. 1 second. Yeah, there you go.
I think to make the things clear as a consensus, clipping in breast is a must, and axillary clipping is not required. It should be clear.
Clear. Comment from you, Arvind? Yeah. Take a mic, please. So, working mic to Dr. Arvind, please.
Yeah, I agree that, a lot of axillary de-escalation surgeries has been the norm. And of course, as said, in elderly people more than 70 and luminal positive, there is a fair degree of consensus that we can avoid an axillary surgery. But by and large, for all the other patients, and in fact, in these triple negatives also, of course, in this case, it was N1 to start with, so I agree with Aditi. I think you may choose, I think the guidelines say that you clip the axilla as well. But I guess, there are certain sort of, technical issues. But at least in UK and majority of the other countries, they sort of, document clipping both the breast and the axilla, and you have to document the removal of the clip also. So that's mandatory medical legally also essentially. So that is something that they take it with a lot of thing. And of course, axillary de-escalation as targeted axillary surgery, as you said, is something that is very feasible, and most of the centers now are trying to go that way.
So I can second that, Arvind, seen surgical MCH residents running hither and thither with that specimen to the ultrasound room and all that, looking for that clip, no? Amit, you had a question or a comment? Yeah, please go ahead. Mike, please. Mike over here.
So very interesting discussion. So I wanted to ask the experts here, what if there's a progression on neoadjuvant therapy, how you handle it?
No, we're not talking about that. We have to wind up, we're done.
Okay, never mind then.
So like, pardon me for that.
But
so
it's a discussion that needs to happen.
We will do it post, when you're off panel.
Absolutely.
So this is an aggressive disease, heterogeneous disease, difficult to make one guideline for all. BRCA mutation testing is important, not only for counseling, but also there might be a therapeutic implication to that. Standard of care treatment today is a combination of immunotherapy with platinum-containing chemotherapy in the neoadjuvant setting, and continued the immunotherapy in the adjuvant setting. Again, this is my personal take to you. NCCN and other guidelines are not gospel truths. Every patient needs to be assessed and treated individually. Choice of treatment depends upon several factors, and at least in our country and in non-NCR regions. NCR region, every single cancer patient gets NGS, and I mean, you don't know what to do with it. That is besides the point. Every single patient gets checkpoint inhibitors and stuff, but there is a world beyond NCR also. You have to very carefully assess the economic needs of the patient, and detailed discussion with the patient and the family as to the, as accurate as you can make it, the expenses involved is extremely important. And again, data and good data is the need of the hour, and I would, urge all of you to collect, compile, and publish your data. With that, I'd like to thank you very much. Any final 5-second comments from my panel?
Sir, blacks and browns are supposed to have 40% of triple negative breast cancers when compared to normal 20-25% in the
I did mention that in my first slide. We have more TNBC in our country. Very quick comment. No question. If you have a comment, then otherwise off panel. I don't want to delay the.
Just wanted to ask, in such cases, wherever you're giving immune checkpoint inhibitors, the clone for PD-L1 testing, do you, as clinicians, you give, or do you let the pathologist decide?
So, as the panel did point out to you, if the patient comes to you de novo, newly diagnosed, not metastatic, you don't need to do PD-L1. Metastatic, yes, you need to do, because that changes the treatment. Even if the PD-L1 is negative and you get it done at diagnosis, the treatment remains the same. So, ladies and gentlemen, we will do all our additional questions and comments off panel. Please give my panel a big hand. Thank you very much. Really appreciate this opportunity.
The members are Dr. Aditya Sarin, who will be moderating. Dr. Aditya. Panelist Dr. Surbhi Gupta from Agra, Dr. Shivam Vassal, Dr. Siddharth Sood, Dr. Kapil Goyal, Dr. Babul Bansal, and Dr. Piyush Pashpai. Over to you, sir.
So good morning to everyone, and we have Dr. Surbhi Gupta, right? Dr. Surbhi, you are a radiation oncologist? Okay. Dr. Shivam Vatsal, surgical oncologist. Yeah. Siddharth Sood, medical oncologist. Okay. Dr. Kapil, we have medical oncologist. Dr. Babul Bansal, surgical oncologist. So we have 2 surgical oncologists, 2 medical oncologists, and 1 radiation oncologist. Okay. So the thought which was given to me that in this panel discussion, you are supposed to discuss the whole year's recent advances in breast cancer. And I was completely flabbergasted. How to cover 1 year of recent advances in 30 minutes of a panel discussion? So let me just be very honest. We'll be discussing few select subgroup of the slides, and obviously most role will definitely come to medical oncologists. And I'll try to, keep my surgical oncologist and radiation oncologist pumped up during this. So let us just start with the discussion. So Cleopatra trial. Straight away, we are going to discuss with the HER2 positive scenarios. Dr. Kapil, what is your practice at your center? How is your interaction with your surgical oncologist in this particular subgroup? And from there on, I want to shift to the metastatic setting before we shift to this.
Yeah, so I think this has become sort of like standard practice. So in the neoadjuvant and adjuvant setting, we are using FESCO or pertuzumab now that we have Indian generic also available. In the metastatic setting also, like this is the standard of therapy now, pertuzumab plus trastuzumab. It's only that financial burden that is the most troublesome. So I think the adoption percent in my practice may be 25 to 30% patients are actually able to afford that. But now that Indian generics have come, and so I feel in future like many other patients will be able to take it. Regarding the efficacy, I've seen like very good results. So
Okay. Dr. Sood, what's your thought about using this kind of a combination in patients who are not affording? How do you navigate? Do you still, try to pump them up, or you are just happy to take away the pertuzumab and you are just happy with the trastuzumab in neoadjuvant setting? We'll come to the metastatic later on.
So definitely this is on the table for every patient, and it's part of the discussions obviously. And finances do play a very important role, of course. And just to shy away a patient who is not able to afford pertuzumab, just not to make the patient feel worse about not choosing this, going ahead with trastuzumab is reasonably fine as well.
Okay. So, Dr. Babul, for any patient presenting to a surgical oncologist first, what's your cutoff point where you will send the patient to a medical oncologist for a neoadjuvant intent? Or take away, I'm talking about HER2 positive breast cancer. It's a very simple question. An early stage breast cancer, HER2 positive, where is the surgical oncologist perspective to send the patient to the medical oncologist or keep the patient with themselves and go and do the surgery first?
So in the practice, what we are doing is T1 N0, definitely we are operating.
Yeah.
Because if we can achieve a good cosmesis with that, we are going ahead. T2 N0 is the gray area. If the breast is large and we can still get a good outcome, we'll go for it. Otherwise, most of our T2 N0 patients go to the medical oncologist.
Okay. So, to radiation oncologists then obviously, which select subgroup of patients of HER2 3+ post neoadjuvant and surgery. So neoadjuvant chemo has been completed, surgery has been completed. Which select subgroup you will be opting for radiation? What are your gray areas in that particular subgroup?
Definitely one thing is regarding the lymph node status, whether it's 1 or 2, 3 lymph nodes positive or not.
Right.
Okay, so usually we take about 3 or above 3. We take the patient for the axillary lymph node radiation. The second thing, chest wall radiation. The common indication if the surgical margin is closed or it's a positivity, tumor is T3 or more than 3 centimeter, or if there's the incomplete dissection. So these are the basically common indication we take patient for the.
Right.
Or if early triple negative patient, in spite of the complete surgical, complete MRM, we take the patient for local-regional radiotherapy.
So I think panel agrees to it, or do you have?
I got a question in that. So there is always a gray area in patient who have 1 node or 2 node positive, because as per the ASTRO guidelines, they recommend only after 3 lymph node onward you give radiation. But institutional practices vary, I agree. And AIMS, we used to send for radiation for even the 1 lymph node positivity. So what's the other panelists can opine on their institutional practices?
Look.
Yes. If it is T2, like if it is T2 and
even it is T3 N0 or even if 1 node positive, you have to irradiate the chest wall.
Yeah. Regarding axillary lymph node radiation, you are
I'm
talking
saying,
about, no?
I'm suppose T2 N1. N1 is just single lymph node positive. Then
Single node, it means the disease has gone from chest wall to the node, so the intervening area is at a high risk.
Yeah.
So in that case, you should cover the chest wall, but you can leave the nodal radiation.
Yeah, actually, I was talking for the pathological T1 to T3. For clinical N1, you have to give axillary also.
Okay. So obviously, we have started with a heated discussion. So we'll be starting with the Cleopatra trial. We have this data in front of us. Dr. Sood, your take on the data of the Cleopatra trial?
It's quite, we are familiar with the Kaplan-Meier's pretty much. Hazard ratios of 0.69, clinically, statistically significant, and also clinically meaningful as well.
Yeah.
So this is one of the landmark practice changing.
So I think an 8-year landmark is good enough for us to, be pumped up about using this kind of a combination.
Yes. I think this should be the first good to go thing, if not the other.
Okay. So how about your response rate currently in your setting? Do you feel it's matching with the same, or you have some exceptional responders or, under responders?
So when I'm in my time in the government setup, when I was in ESI, I did see about 30% patients who had a PAT-CR, but I also saw progressors.
Yeah.
Even on this combination.
So were they young or old?
So I would say the age group which I was dealing with was about 40s and 50s.
40.
Yeah.
Dr. Kapil, your thought?
So response is actually very good. So sometimes it so happens that initially we have planned for chemotherapy for initial 6 cycles, and tolerability issues, I sometimes even cut off the chemotherapy just after 1 cycle or 2 cycles, just continue with pertuzumab, and the response just goes on. And I think more than a year, most of the patients are able to sustain for more than a year. Talking about outliers, so I have a patient who's on 110th cycle of pertuzumab.
Wonderful.
Another one on 60th cycle. So
yeah.
So outliers are plenty, I think.
Outliers are there, absolutely. So, so any exceptions for pertuzumab? Any subgroup where you accept other than the financial toxicity, because that's a common answer that everybody can say, and affordability obviously it's one of the major concern here. But now coming with the generics, I think the exceptions are coming less and less. So here I want to know, are we happy with the fixed dose dosing of the Phasgo injection, or do we still believe in the conventional, 840 mg followed by 420 mg, or that kind of a scenario? Or you are happy with 1200 mg of pertuzumab followed by 600 mg?
I'm happy.
You are happy, irrespective whether the BSA is 1.2 or whether the BSA is 2.5.
Because all kind of patients are there, and apart from the toxicity part, some patient may have diarrhea, so that's a common problem with pertuzumab. But most of that is actually manageable with Imodium capsules. But in few of them, I had to stop also pertuzumab because of the diarrhea. So that way, I think I'll just stop pertuzumab rather than just decreasing the dose. So I don't think decreasing the dose would mean like trastuzumab also. We don't decrease the dose per se if it is cardiotoxicity.
So I think the ball should be in the medical oncologist court to decide which formulation to use. So for example, I had a patient who was having a weight of 40 kgs, and we were not having any subcutaneous tissue left where to even insert that kind of a needle. So once you gradually build it up, and you can switch it from IV to subcutaneous formulation, but obviously that's a very individualistic approach. So coming to radiation oncologist, if you have a baseline brain mets, so we have 3 options here. What do you want medical oncologist to do? You want medical oncologist to wait, or you want to send them these patients straight away to you? Patients with HER2 3+ and MBC scenario, having, let's say, we were to discuss 2 scenarios. Let's say patient is having 3 brain mets, and vis-a-vis patient is having CSF positivity.
Okay. If the patient is symptomatic, having the signs symptoms of increased ICT, if there is the perilesional edema in the MRI brain, if lesion is less than 10, definitely I will go for the local radiotherapy to the patients, to this patient. The second thing is patient is HER2 positive. Now we know that this tantumab has some brain barrier crossing the property also, and as this patient is already brain mets, so brain barrier has already been decreased. So it has a good effect on this brain mets also. But for symptomatic patient less than 10, if the perilesional edema is there, then I will go for the local radiotherapy for this patient.
So what is your cutoff for going for an SBRT in patient with brain mets? Let's say they are 5, they are 6, they are 7.
10, actually 10. For 10 we accept, and if the big tumor is there, more than 4 centimeter, I will go for the radiotherapy first, for the local treatment. Or if there is some unusual site, like suppose the patient is having the mets in the cerebellum, like unusual sites, I will go for the local therapy.
So for you, 10 is a number?
10 is the number.
10. Dr. Sood, your thoughts? Any takers from the audience? SBRT, we are comfortable with going even if there are 10 brain mets. I think we all agree.
They do it up to 80 also. They do it up to 80 also.
80.
80.
Okay.
They do it up to 80. I have a photo of a conference which I attended in Kochi. They do it up to 80 also. But the point is, as rightly mentioned by him.
5?
To be very honest, 5.
5?
5. 5 is
The consensus is a 5.
Otherwise, it's a whole brain.
It's a whole brain. Okay.
Also depend the vicinity. 10 brain mets in which vicinity? It's a common vicinity. So you can give up to the 10. If it is dispersed, there's no use of giving that approach.
So obviously you will have to individualize. For 5, I think most of us are very comfortable. I think we can still stretch ourselves to 8 sometimes. But yeah, going beyond that for medical oncology, it becomes a difficult thing to even for swallow. But yeah, I think if you have a data of going for an 80 SBRT, spot burning, I think it's fantastic. What else you need? So the targeted therapy, we have trastuzumab, pertuzumab. And your take here, Dr. Kapil, do you think that this protocol is going to change in the near future? The first line setting of MBC?
Yeah, definitely, because the way that trastuzumab deruxtecan has shown promising activity coming from 4th line to 3rd line to now 2nd line standard of care. So I'm sure it may replace pertuzumab trastuzumab in the 1st line also. That time, if that happens, then probably we can escape radiation in the 1st line because that has good brain activity. But as of now, we need to depend on RT for brain metastasis, even for asymptomatic patients, because pertuzumab does not cross blood-brain barrier.
So obviously, this is the DB12 trial with TDXD, HER2-positive advanced breast cancer with or without brain mets. So this was presented in ESMO. And you have patients who were having baseline brain mets with the N number of 263. Just a second. Yeah. So you have some stable brain mets and you have active brain mets, the endpoint being the PFS. So patients were having pathologically documented HER2 positive metastatic breast cancer. Any subgroup where you will be comfortable in going for the neurosurgical intervention? Or we all are happy with the SBRT straight away? Any takers? Dr. Sood or Kapil?
Vital places like brainstem or somewhere, giving RT may produce additional edema, which may be life-threatening, so if we need some urgent decompression.
So that will be an organ at risk, something kind of a scenario where you are threatening a structure related to the radiation.
Maybe near pons or 4th ventricle.
But I think... Yeah, absolutely.
Just hypothetically speaking,
yeah.
That kind of situation comes.
There's a relapse in a frontal lobe, single lesion, 1.5 centimeter, so which is potentially curable. Would you opt for surgery in that situation followed by radiation or just SRS?
So if we were to go with the data, that data says that if you go with the surgery and if you give additional radiation to that particular area, that gives you the best amount of PFS and the benefit.
Once brain metastasis has happened, even if a single site, I don't think it's curative anymore. Even if probably, especially for the HER2 positive subgroup, even though the oligometastatic term basically we restrict for either bone lesion or liver lesion. So for brain.
But still for brain, we can still individualize our practice. You can say that, do you have any data to support it? Obviously, we don't have such kind of a data where I have to give you an answer that go for the surgery, then do the radiation, that's give you the best vis-a-vis the SBRT. I mean, you have to individualize.
Yeah, absolutely.
Sir.
If the lesion is 1, then the size and raised ICT features are very important.
Yeah.
If the size is more than 4 centimeter and the patient is having very frank symptoms, I think it's better to take a neurosurgical opinion, because when you give radiation, the pressure may further increase for some time. So that may
Dr. Surbi, your take?
Yeah, I agree with Dr. Kuldeep. If tumor is up to the 4 centimeter, then better to go for the surgical excision followed by the radiotherapy to that if oligometastatic lesion is present.
So obviously this trial was having stable brain mets, previously treated and no evidence of progression at the baseline, and there were some untreated and previously treated or progressing brain mets as well. So these patients where untreated or progressive brain mets was there, they were tagged as an active brain mets, and you had 106 patients of patients with active brain mets. And now if you were to see the PFS benefit in such subgroup, at 12 months it is 61.6%. This is the magic of ADC. And that's why the further discussion will move on to the more advanced ADCs that we are going to see. So TDXT has shown a consistent 12-month PFS benefit with stable and active brain mets. Dr. Sood, your take on it? Any? Sorry, come again? Yeah. So, in patients with active brain mets, vis-a-vis, let's say they are inactive, presenting to you upfront, let's say the disease bulk is not that much, you have 3 brain mets, which is your treatment of choice in that subgroup? Let's say the patient's age is 42. So 42, HER2-positive MBC patient presenting with 3 brain mets, upfront, which protocol you are comfortable to choose? Dr. Kapil?
So first line, I'll stick to pertuzumab, trastuzumab along with radiation therapy to the brain. I'll not switch to TDX1 in the first line despite having like brain mets.
So anybody from audience? Sir?
This type of cases used to go to neurosurgery where they had a gamma knife facility. So gamma knife used to give, they used to do surgery and followed by gamma knife treatment, which is most conformal treatment, and the results, I mean, the survival rates are very high when compared to surgery alone or radiation alone. Almost it was double. So since we don't have first line brain penetrating drugs for HER2-positive cases, probably that approach would be better.
So, you know, in Cleopatra, they included patients where there was no active brain mets in Cleopatra, which was an MBC setting. So if you have a patient of presenting to you with her brain mets and you are irradiating them, technically you are making them, you know, inert of those particular brain mets. So then Dr. Kapil's thought process of going with the THP protocol can kick in. Vis-a-vis, if Dr. Sood selects another protocol and going ahead with TDXT, nobody can challenge that as well.
But it is not approved in first line.
But then again, if you have active baseline brain mets, you have to be very careful when selecting your regime. And if the main thing is the symptoms, you need to control them, you need to control the intracranial disease, and if you think the bulk of the disease can be contained.
TB12 took previously treated ones.
Sorry?
The Destiny Breast
1-2
trial, which is trial that we are talking, this is also previously treated patients. Headline.
Yeah. So nobody pushes that.
Pertuzumab, with pertuzumab only.
Pertuzumab. In the upfront setting, well, I am yet to see a patient presenting to me in the upfront leptomeningeal involvement. But yeah, I think if we were to sit together and individualize, I think my choice will be to go with the TDXT. It is as simple as that. Because that is going to give us the best brain penetration that we have as per the current availability. Yeah. But then again, he is asking upfront. I know. So if we were to start, so let's again, Dr. Amit Verma's point is correct, and patient is coming to us in an upfront setting. Your heart is saying something, your brain is saying something. What should I follow? Brain? So brain says?
Definitely, sir. Evidence-based medicine has to be brain.
Yeah.
We are jumping the gun. The evidence is still maturing. I think so. The way forward right now, what Dr. Kapil is saying, THP for now, probably the evidence, these trials have taken most of time a heterogeneous population. They have taken a stable brain metastasis. They have irradiated and then taken. So it would be jumping the gun right now if we actually are going ahead. We have seen TDM1 coming into the forefront, pitched against the forefront regimen, and it has failed.
But I think another 2-3 years, the answer will come to this only. We have to wait till that time. We have to wait. Right now we can't. Okay. So yes, so there is a debate over here. Okay. So you have, confirmed CNS ORR of 71.7%, and you have 12-month OS of 90.3% with the baseline brain mets here. And there was only the regular ILD cases you have with the TDXD. So Dr. Sood, how comfortable are you using TDXD?
For now, it's difficult to provide patients with TDXD very often. But I would say we're just discussing about pertuzumab, trastuzumab, and straight away TDXD. There is also TDM1 in between somewhere, lost its way.
Yeah, it has definitely lost its shine.
It was a very beautiful drug, and I recall my training that the moment we saw brain mets, we would jump to TDM1 from pertuzumab, trastuzumab. So that should not be forgotten, I would say, clinically relevant till date. So my experience with TDXD is limited as of now.
Dr. Kapil, 5.4 mg per kg, comfortable?
So far I have not used, but I think it should be okay, 5.4, now that we are aggressively going toward with AstraZeneca actually issuing a patient information leaflet also, so that this, any symptoms, if your patient has any symptom, they immediately have to come to the doctor, and we are supposed to do all the scans and all the PFTs. So I think the kind of vigilance, if we are, the kind of vigilant we are for the pneumonitis, so I think it should be manageable, just like with cardiotoxicity now that every oncologist is so particular about getting a 2D echo. So I think if you become that
Let me be very blunt here that in my practice, I generally start, I'm very scared of these side effects. Everybody is, it's not about me. I generally start with 4.8 dose, mg per kg. In any patient where I have started, till today, I'm yet to get any success to tolerate even that particular dose. Because of one of my patient went with the low ejection fraction. The second patient went with, 2 patients of mine went with ILD. And I've not seen neutropenia. Generally, I don't think at 4.8 I'm going to encounter neutropenia. So, this 5.4 mg per kg, it's not easy thing for me to swallow. And obviously, Kapil is saying his patients are fantastic if they are tolerating. Mine is none of the patient is tolerating 5.4 mg.
I did not say my patient tolerating. I have no experience. I said I have not given, but I think we should.
Exactly, and even after that,
I think anyway we are
you are having side effects even after that.
So Dr. Sareen, I feel anyway we are rounding off because the cost of the vial we just rounded up to the next 100. So I don't think anyway patients are receiving 5.
So this is the treatment algorithm for us, THP in the first line, no or non-stable brain mets. You go with the TXD. This was before DB12, and I think you have tucatinib option. So with TDXD availability, what is the stand of TDM1? We have already discussed. Will its availability increase the confidence to use TDM1 first as TDXD can work even after TDM1? So Dr. Sood, your take on this?
Definitely TDM1 was able to work now.
So,
but after TDXD, just if anyone can, after TDXD.
So that's why. Which patients for HER2-CLIMB? How do you incorporate HER2-CLIMB now? Any select subgroup where you feel, I am not comfortable with TDXD, let's go to HER2-CLIMB in second line.
So I think when the generic tucatinib comes next year and TDXD still remains unaffordable.
So again, it boils down to cost in India. Huh? So yeah, if we were to see the head-to-head comparison of DB12 and HER2-CLIMB, you have a PFS of 25% at 12 months, that is 7.6%. And you can just see that in DB12, it is 66.7%. And OS is, at 12 months, OS is 90.3%. And the 12-month OS here is 70.1%. So here you are pretty much sure that if patients not tolerating TDXD, I think we'll switch to HER2-CLIMB. Okay. So now this is the consensus. I think we are in consensus here. Second line TDXD. Okay. So you have new ADCs. The more and more ADCs are going to come up. More and more new tongue twister names are going to be pronounced in the next upcoming years. So very quickly, Dr. Sood, your take on the second line hormone positive breast cancer. Obviously now we'll be shifting gears from HER2 negative, we'll be coming to hormone positive and HER2 new negative. In your experience, what do you feel?
So you're saying second line?
Second line. First line I think we are pretty much comfortable with, yeah.
I have some experience with alpelisib and everolimus being in the second line. Poorly tolerated.
So overall, do you think the figure quoted over here that the second line works for 16 months overall? Do you concur?
I don't think so.
It's
Patients
lesser
don't
than
end up
that.
being on that. Yes.
Kapil.
So Sometimes if the progression is not very fulminant, like just a mild increase in the disease, then burden, I just switched from AI to fulvestrant and continue with CDK4/6 inhibitor. If it is a frank progression, then of course now we have to test for ESR1 as well and for this PIK3CA. If either of that comes out, then
I need to ask this question to Dr. Shivam. So obviously I'm not going to talk about the metastatic. My question to you is, if a patient having 4 centimeter breast lesion, having hormone positive, ER/PR positive, which is the subgroup which you are going to send them to medical oncologist, and which is the subgroup where you are going for the surgery upfront?
4 centimeter, clinically there is no node
Yeah.
positive, then we can go for an upfront surgery, depending if the breast and tumor ratio is not adequate, then we can consider for a neoadjuvant chemotherapy and then go for a breast conservation surgery if the patient is willing for.
So now coming back to the metastatic scenario, you have this drug which has shown promising activity, HER3-DXd, across the breast cancer subtypes and across a range of HER3 membrane expression. This is patritumumab deruxtecan. This was presented in ESMO Icarus Breast 01 trial, again a phase 2 trial. And you can just see, again the dosing was 5.6 mg per kg. The confirmed ORR was to the tunes of 53.5%. And if you can just see HER2 expression, they have said that this drug is going to work in IHC 0, 1 plus or 2 plus Veligrad subgroup. So sooner the way that we were thinking that there is a subgroup of ultra low, HER2 low, coming off this drug, I think that will become irrelevant, and with the availability of this drug, because this drug has shown fantastic response rate in all of these subgroup, and it has shown a similar activity in fact. If we were to compare the ORR, you can just see with the patritumumab, it is 53.5%, with DB05 it was 52.6, with tropion it was 36.4. So yes, the next drug on the market will be patritumumab whenever it comes. And so you have another few drugs I wanted to just show you. In view of shortage of time, I will have to brush through some slides. Ivonescimab. Dr. Pankaj? No idea? I had even no idea. So when I was preparing, then I came to know it's an anti-PD-1, anti-VEGF. The trial in lung we have already seen. It has shown a fantastic result. But in breast they are on, and they are very promising. We are going to have an ORR of 74%. And coming back to again this particular subgroup, hormone positive second line patients who are one of the most aggressive patients, where patients have failed adjuvant endocrine therapy. So what they are doing is, you have to check for PIK3CA, then you combine PIK3CA with palbociclib. So this is Inavo 120 study design, and they have selected one of the most aggressive patients with poor prognosis, PIK3CA mutated, hormone positive, metastatic disease progression during or within 12 months of adjuvant endocrine completion. And what they have been able to produce a PFS of approximately, I think 15 months. And that is where the combination of this drug along with your CDK4/6 is coming up. And I think sooner we'll be also using whenever this drug comes to India. So this kind of a combination of 1 or 2 more drugs, I think it's on. We are happy to accept now. Oh yeah. So better tolerated. And obviously you have the approval in the latest NCCN as well. You can choose your weapon, but I think inavolisib is something which is going to be one of the practice-changing modules that we are going to see in another 5-6 months, and as per the availability of drug. So thank you. Thank you for such a...
Just last question from moderator itself. Regarding the HER2 positive and the HER2 low, ultra low, now after density 6 trial, now they have recommended TTXT. And so is there any head-to-head trials between these HER3 plus and this TTXT?
So you can compare the cross trial, but I don't think there is ever going to be a head-to-head trial. You can just take out the data and have a cross trial comparison, but there is never going to be head-to-head trial data.
So what will the take-home message for this?
So any HER2 low in the second line, the weapon of choice is TDXT. If finances are not an issue. Sir.
When you do your molecular profiling for metastatic hormone-positive breast cancer and PIK3CA is identified, will you go ahead with your CDK4 inhibitors first or alpelisib first?
Currently, as the availability of drug, I think I'll have to be happy with alpelisib. No. Upfront. Upfront is a tricky question, sir.
So actually we don't test.
Upfront is a tricky question.
We don't.
Generally, you get these mutations post CDK4/6.
PIK3CA is a. We don't test only because PIK3CA is an emerging resistance. It's seldom present upfront.
No. So it's a truncal mutation present at the baseline in 40% of.
That is for ESR1, and I think even for first line, we are not going to use it. We have to wait.
Change. Only 1% change down the line. So it can be tested at any point in time. So you will get the same result by and large.
So, but in that case, then
but then the alpelisib is such a
toxic
drug.
So first line still remains CDK4.
So if we get PIK3CA or let's say ESR1 mutation, are we ready to go away with palbociclib and use the target drugs over there in the? So today, as of now.
The point is that ESR1 mutation upfront is present in less than 1%. So therefore, there isn't much role. And our go-to molecule is fulvestrant when CDK4/6 and AI fails. So whether you do ESR1 or not, it is immaterial because your go-to molecule is fulvestrant. So it works for ESR1 mutants.
I'm not talking about ESR, only PIK3CA.
PIK3CA is a difficult drug at the moment, but things may change with this new molecule.
So now, another question. If you see PIK3CA mutation with HER2 positivity, can you predict responses with your trastuzumab or your ADCs? What do you choose in that case?
So I think, sir, you can enlighten us more on this topic. I generally don't combine 2 or 3 drugs without, So, if this patient comes out to be HER2 low as well, so you can combine all the 3 TDXT along with this as well, Yeah.
In those scenarios, when you have a downstream mutations available,
Right.
it is better to use ADCs than to target it.
Sir, you need to take our lecture as well. This is something beyond the realm of our NCCN guidelines, but yeah, that's a fair enough point. I mean, we can't discuss so much hypothetically. That's okay. Chalo. So thank you everyone, panelists and our fantastic audience as well. Yeah, thank you. Thank you so much.
And may I request Dr. G.K. Ras sir to give take-home message for both the panels.
Which has been highlighted is breast cancer incidence in this country is increasing. It's one cancer where the incidence is increasing. Many cancers are coming down, like tobacco-related cancer, cervical cancer. Triple negative in our country, as we discussed, is 1/3, which is again very high compared to other countries. They are heterogeneous and drug-resistant. Recurrence is early, and you have seen the drugs, new drugs which are coming up. Thank you.
Thank you very much, sir. I now invite Dr. Shyam Agarwal, sir, to moderate the panel on HER2-positive MBC. And the panelists are Dr. Chintamani, sir, Dr. Pankaj Goyal, Dr. Nikhil Hemtani, Dr. Raghav Kesri, Dr. Sudarshan Desar, Dr. Kajal Shah, and Dr. Kinjal Jali.
Good morning, everyone, and thanks to the organizers for inviting us here. I think a lot of things have already been covered because HER2-positive metastatic breast cancer was the subject of the previous discussion. But we'll try to, have some newer issues which possibly have not been discussed through a case-based discussion. The slide's moving. Okay. So I think that's the objective of this panel discussion, choosing the right therapy for a patient, HER2 testing in MBC. So I think we'll have the molecular biologists understanding on this because it is emerging, it's evolving, and it's become available. Managing brain metastasis has been actually discussed in fair amount of detail, but then the case which we have is similar. And treatment sequencing in the era of new targeted anti-HER2 new therapies. So this is a 55-year-old post-menopausal T2N1 ERPR negative HER2 new positive and treated with the standard of care TCHP and then surgery. You have residual disease in the post-mastectomy specimen, followed with radiation, and given the Catherine data-based TDM1 for 14 cycles. She has no comorbidities. 2 years after the completion of therapy of adjuvant treatment, she develops mild cough. So anybody wants to comment on the initial presentation of this patient and new adjuvant and the adjuvant? Anybody please has any different points?
No, she was treated perfectly fine.
Right.
Clinically T2N1 with the ERPR negative and HER2 positive, we would go ahead with TCHP if possible, or otherwise TCH if not affording for P. Then the surgery, as there was a residual disease, it was a pathologically T1N0.
Right.
So we shifted to TDM1, adjuvant RT was given. So the treatment initially done was perfect.
Right.
So no doubts about that.
So Himtani, you agree?
Yes, sir, I would agree. The treatment was given as per the standard protocols. Pertuzumab must be added in the neoadjuvant setting given the impressive pathological complete response rate. And unfortunately, this patient had a residual T1 disease. And as per the Catherine data, she was shifted to TDM1.
Dr. Kinjaljani, radiation? Okay, okay. So what about Dr. Sudarshan Day? Radiation based on T1N0 at the end of TCHP. Can that be omitted or it should still be given? Use the mic. Yeah.
She was only 55 years old. So
right. So Pankaj, radiation is on?
Sir, I totally agree. We will not mess up with that. Radiation is on.
Okay, radiation is on. So okay,
initially
so let's...
Initially N1, so...
Right, so based on the initial staging, node positivity, I think she needs to get radiation as well. So everybody agrees to the line of treatment which was offered to her. So she develops cough after a gap of 2 years. And then when she's investigated, she's found to be having lesions in the spine and pelvis and several pulmonary nodules. Rebiopsy. Pankaj? The nodule is easily accessible.
I don't understand because we are supposed to rebiopsy and whatever be the result, we are supposed to treat it as HER2 positive. So,
okay, so you're giving me the next answer as well. So rebiopsy is required basically for confirmation and perhaps not for looking at the immunohistochemistry or other parameters, right? Okay. So any difference of opinion from?
Change in the status of HER2
Right. So you want to answer, please? Can you speak a little louder, close to?
HER2 positive cancer, if pre-biopsy we treat as a HER2 positive, but if HR negative convert to HR positive, hormone positive, we can add the hormone positive treatment.
Okay, Dr. Sameer's question is that you do a lung biopsy, Dr. Himtani, and this patient becomes HER2 negative. Is that what your point, right? Okay, Hemtani, so does that impact your treatment management protocol?
And when you talk about a rebiopsy, what about a liquid biopsy?
We will come to that. Let's first talk about the tissue biopsy, which is what you want to address. So this patient, becomes HER2 negative, and although Pankaj has briefly answered, but then you can have a detailed.
So, sir, once it is HER2 positive baseline, we treat it as HER2 positive. I think HER2 negative, I have not seen in my practice as well.
Right. So even if it is HER2 negative, it will be treated like HER2 new. So does that satisfy you, Dr. Sameer? Yeah. Is there a difference of opinion amongst medical oncologists that when you do a repeat biopsy and HER2 new, I mean, chances are virtually remote though, but then if it turns out to be negative, maybe due to tumor heterogeneity, you just never know, So it can be a tumor negativity. So that could be the reason for the negative HER2. Pankaj, why should it be HER2 negative? I mean, even if we get HER2 negative.
So there are 5 to 10% cases which can turn out to be HER2 negative, but the present data says that even if they turn HER2 negative, they behave as HER2 positives, and you have to address.
No, behave means what? I mean, so what is the explanation for HER2 negativity?
So that is that heterogeneity what you are
Correct.
talking about.
So possibly you have hit an area which has become HER2 negative. So it so appears that majority of the tumor cells are still going to be HER2 positive. So which can be further documented by the liquid biopsy. Is that what you are saying?
So maybe if there is a recurrency after say 7 or 8 years, then also we are supposed to stick to this golden rule. HER2 positive is HER2 positive.
Well, that's the current way of looking at it. But technically speaking, a HER2 positive can become HER2 negative, which can become the dominant clone. So how do you determine that? I mean, we're talking futuristic, but then, how do you determine that? So is there a role for NGS, maybe by doing on the tissue or by doing it on the liquid biopsy? So what is the status for NGS for doing HER2 new testing? Is it on? Is it off? Is it should be done? Should not be done?
Futuristic, not on.
It is futuristic. Hemtani, you agree?
Sir, I don't do routinely in my practice if the patient has
No. Let's talk about the data as it exists on the efficacy or validation of the Dr. Chintamani, please join us. Yeah. So now you have 3 tests. You have IHC, you have FISH test, and you have next generation sequencing, which is so readily available today. I mean, when you're ordering a 300 gene test or whatever, so HER2 new you will get the copy numbers and all that. So if you get that information, is it valid?
So clinically, I think we do not have a data to practice on the basis of that now. Maybe after some time.
I'll tell you. For example, Hemtani, you want to say something before I speak?
Sir, I don't do routinely in NGS.
Let's not talk about doing or not doing it. So now you're doing Guardant, you're doing so many other testing in which HER2 amplification comes into play. Amit, you want to answer this, please? You take a mic, please, because this is an important question. No. We are not talking of ASCO. We are doing these tests. Come on, NGS, there is data available for HER2 new testing. No, I disagree.
So
Amit,
if you have amplification seen on NGS, whatever matter,
correct,
it will be taken as positive. You can treat it. That is one thing.
Which will be?
It will be your anti-HER2 treatment. If that
correct. So this patient will be eligible for anti-HER2 new therapy.
Exactly. But as you already have the biopsy with HER2.
No. We are talking not about this patient. We are talking of NGS now.
So this is
with the HER2 new data.
Is acceptable in terms of.
Absolutely. So I think that is the answer. So even if you get HER2 new positivity on the NGS in terms of copy number variation or copy number increase, you will find amplification, right? For example, if you look at the Guardant data, 2.5 to 4, they say is 2 plus. More than 4 is 3 plus. So NGS is an acceptable test for doing HER2 new testing for amplification and mutation both. So it's not that you brush away the HER2 new. There's a lot of concordance between HER2 new FISH and NGS for HER2 new. Okay, FISH and NGS are concordant. There are occasional cases where NGS scores over FISH. So actually NGS is the test. So NGS is the test. If you have any doubt on any given patient, NGS will pick up those copy number variations or amplification to confirm that, and there is a case report recently where FISH was negative, IHC was 0, copy number was more on the NGS.
patient got the benefit of anti-HER2 therapy and did well. Dr. Sai.
So if the patient comes as on rebiopsy HER2 negative,
right?
Should we continue giving HER2 alone or HER2 directed therapy with chemotherapy, sir?
So that will be as per the protocols. For example, Cleopatra has both. That will depend on the patient situation, at what line you are getting the HER2 negativity. But the protocol will be followed as per the HER2 positive guidelines. Piyush.
Sir, apart from Guardant, I'm not really aware. It's Guardant Omni which has come, which is 500 gene panel. And it's a upgradation of what Guardant was doing 77. Apart from that, I'm not really aware. Are we good enough to go and rely on NGS?
Foundation and all the 300. Amit, please.
Liquid biopsy,
irrespective of the source.
We're talking about NGS here.
Yeah.
So NGS is requires DNA, whether it is coming from the tissue or it is coming from the blood. It doesn't really matter.
So there are different labs have different cutoffs. Earlier, Foundation used to have the cutoff of copy number of 6. Now they have reduced to 5. Guardant may have at the copy number of 4 itself. So 2 is normally available in the cells, but if it is 4, it is positive. 5, it is as per some other labs, to be more stricter actually, or strict. But this is acceptable if it is.
Currently, TBXD is approved for HER2 low.
Look, that is
right. So even if your NGS is positive, you're eligible. It should not be 0. Period. So end of discussion. Right, Pankaj? You treat so much.
Sir, I'm not a very big fan of NGS, and why will I ask for NGS when I already
I'm sorry, Pankaj. You need to go back to the literature and review the data on NGS vis-a-vis FISH for HER2
So keeping in mind
yeah.
personalization, including the safety profiles that you want, these are all additions that will come out.
Yeah, so they become available, and if you get NGS positivity, you cannot ignore this. Simple. As simple as that.
So you do NGS in all the patients?
I don't do. So I'm asking you, but if, some people are doing NGS upfront. There are people who are, asking for NGS on the first line, second line, third line, looking for more and more targets. So if you get NGS positivity for HER2
I agree.
So kindly honor that. That's my point.
Has done that, it's okay.
Yeah, please.
So what I'm understanding is that if your IHC in FISH is negative,
IHC is positive?
No, I'm asking you, if IHC is negative,
Zero. Both are 0.
And FISH is negative if somebody has done it.
Right.
And in NGS you get a mutation positive. So would you?
No, there are two things. So mutation and copy number variation.
Okay, so if you get it positive, will you give?
Yeah, you should honor that. That's the data.
Okay.
Because, but as I said, the concordance between FISH and NGS is tremendous. So that will be a very isolated case where you will get FISH negativity and you will get NGS positivity.
So while, sir, I agree to that because there have been a lot of studies which
No, there are not a lot of studies. So as I said, the concordance between FISH and NGS is tremendous. But if you have NGS positivity, kindly honor that based on those case reports.
If someone has done it, it's okay. You take it as positive.
No, but you document in the file that there is limited literature.
Right.
So there are patients who have benefited with negative FISH and positive NGS. You need to document that.
Right, because, all right.
Yeah. Yes, sir. Yes, sir, please.
Let me give you the incidents of my own sister who was in the US.
Use the mic, sir, please, so that everybody can hear you. एक माइक देना यार नहीं एक माइक दे दो ना यहाँ पे कहाँ गए इनके हेलो मिस्टर सो रहे यार माइक तो दे दो
I'll give you the incidents of my own sister.
Yes, sir.
She had a T2N1 disease. She was proven to have ER/PR positive, HER2-2+,
yes,
FISH negative. And we treated her with standard protocol. And 2 years later, she comes up with bony metastases and brain metastases.
Yes, sir.
And when we got at that time, Foundation was just coming, and I'm talking about 6-7 years back.
Correct.
Foundation Medicine said that it is HER2 positive.
On the copy number variation.
Yes, everything.
Amplification.
Yes.
So there's a difference between mutation and copy number variation.
No, it was confirmed HER2 positivity.
Amplification.
Yes. and she was treated with anti-HER therapy.
Yes, sir.
But it was maybe too late or whatever, we lost her. She did respond to anti-Herceptin therapy for about 12 months, 18 months, but then we lost her.
Correct.
What I mean to say is, yes, you know, FISH, for many years we were treating patients with FISH 2 plus positive, IHC 2 plus positive but HER2 negative as negative disease. Am I
Correct.
right? Am I right? But this entity of low HER2 was not known at that
Correct.
time.
I wish we had TDXD for your sister.
Yes. Yes.
That could have changed the whole scenario.
Yes, this is what I'm saying. Okay, look, if you can get any more information from an investigation, if there's no other financial problems with the patient, I don't see any reason why you should not do NGS. Somebody says, I don't believe in NGS. Well, you can keep on believing in this thing, but the data says that if you don't do NGS and you could have picked up something more, you could have directed your therapy accordingly.
Correct.
So I don't think you can go.
Correct. No. For example, you know, I mean, it could be futile. For example, in this scenario where HER2/neu is the predominant marker, you get PIK3C. So are you going to do something for that PIK3C for HER2 positive patient?
So again, we are having these drugs which will come into picture, like just discussed. But at present, if there is PIK3 with HER2, I don't think I'll be adding HER2.
Correct. So it is a little futile in a HER2/neu positive setting. Even if you get another, you know, gene marker which is identified and which possibly has a drug, are you going to target that? So here, for example, you're going to give chemo plus, you know, HER2 targeted. Amit, what do you think, since you are the, you know, molecular oncologist? You get the mic, don't worry. Mics are plenty.
So the choice of the therapy may change in the first line itself. If you already have PIK3C alteration with HER2, the Cleopatra will change to Destiny 12 in this case. That is a very simple answer to me from my side. The sequence of your choice of TCHP and TDXT.
First line.
So I'm saying molecular based, there is no guidelines, but if you see an alteration,
so is there data to say that the pertuzumab and Herceptin does not work in the presence of PIK3C mutation?
So this is what we have learned over years with other indications.
No, but is there a paper to that effect? So is there a guideline to that effect? So there is none.
No,
so then you can't, you know, anecdotally, you know, change the guideline or treatment for a given patient. So I think that's what I said. But yes, the future is doing liquid biopsies, perhaps periodically, serial levels depending upon, you know, how long the patient responds and so on, because you get that information which may be incorporated at some point in time, you know, during the, down the lane.
Like lung cancer has changed to this NGS liquid biopsies. Breast cancer will also probably evolve, but we have to wait for the results and the...
Correct. So in a, but you know, I think the liquid biopsies are sort of coming up very rapidly. But at the moment, in the first line, very little role, but second, third, and fourth lines, especially in ER/PR positive, HER2/neu negative, I think there'll be a bigger role, but HER2/neu positive, I'm sure there's going to be a role as well. So I think we are running, you know, short on time. So this patient is HER2 positive, ER/PR, and has lung metastasis. So what is it? 2 years down the line, the patient develops mets.
So I'll treat it as first line, the top one.
The drugs, name the drugs.
Trastuzumab, pertuzumab, and taxane.
Okay, so the Cleopatra study. So this patient, you know, I think this was shown, at the end of, 6 cycles, there is a complete response, right? And so I think that so what do you do then?
Is there maintenance?
With single drug or 2 drugs?
2 drugs, pertuzumab plus trastuzumab.
So I think that has become the standard of care today. So since we have the surgeon, Dr. Chintamani here, so perhaps it is not relevant. It's pertinent to raise a question of, mastectomy in a patient who has responded extremely well to maybe hormonal therapy or to chemotherapy. So what are your thoughts today, sir? I mean, do you do mastectomy in a stage 4 patients after having achieved a complete remission after 6 months, 9 months?
Thank you. Actually, there is no evidence to suggest that it is beneficial. And now there is enough data to say that it is not something that is going to be making any huge amount of impact. But yes, in some select cases where you had a good response, and you're expecting that in future it might fungate or it might bleed or it may cause problems, or whenever it happens, we will.
So the patient
take
has
care of it.
responded, sir, and on a PET CT scan.
It's a case for doing it. So I would like to do it to reduce the burden, and but I have no evidence to support it, frankly.
Samir,
Day after San Antonio.
Yes.
To
I
suggest
was coming there.
that you go ahead with the mastectomy,
mastectomy.
even in oligometastatic situation.
In
Oligomets is no
that's a
issue.
different
I think the issue is bone disease versus visceral disease. Himtani, what do you think? You will send your patient, who has responded to, say, chemo or even hormonal therapy to a surgeon for mastectomy?
Sir, if patient is having visceral metastasis, probably not. If oligometastatic bony mets, then might consider.
Right. So I think there are studies from Turkey, and I think, but
Turkey,
they also had
if
data.
I may, Turkey
Yes.
study showed some benefits also.
Right.
And you were referring to the San Antonio consensus. It was primarily focused on oligometastasis and mostly predominantly bony, and the kind of response. I mean, I had a couple of patients from Dr. Sham where we went ahead and did a mastectomy.
Right.
So it does help, but you will have to tailor it to that particular situation. So there is nothing like one answer to the entire thing.
So I think we just complete this case. I think patient progresses in a couple of years. Then what next? So more lung nodules. Do you do another biopsy? Do you, or without biopsy you will,
Again do a biopsy and treat it as HER positive. TDXD is the...
So TDXD would be the treatment of choice. So I think we're running short of time. Rajesh is sitting here.
So just one question.
Yeah.
After completing the adjuvant therapy, at what duration do you think we are justified to use TDXD? If patient has, this sequence was at 2 years. At what?
Okay, so the question is, you've completed the TDM1 and the patient relapses at 6 months, at 1 year. So what is the treatment if the patient relapses at 6 months? Himtani? So would you go for Cleopatra or you go for...
Sir, after 6 months, I think we can re-challenge with the Cleopatra regimen if the...
After 6 months?
After 6 months.
So within 6 months?
Probably I would be comfortable more with 1 year duration. After 6 months, I would be comfortable with second line TDXD.
No, so 6 months, so we are confusing now. So patient has relapsed at 6 months. So would you do the TDM1 or TDXD, or you do Cleopatra? So there are 3 options, right?
TDXD.
At 6 months, TDXD. TDM1? I think, or Cleopatra?
We are finding reasons to use TDXD.
Okay.
So we can.
So it seems that there is little consensus here. So 1 year, of course, is the time period where there is no confusion to use the Cleopatra again after having failed TDM1. But then within 1 year or 6 months, I think there can be a debate here. And so I think we can stop here unless somebody wants to make a comment, and then I'll share a case with you based on the previous discussion. So we have a patient who came to us with ER/PR positive metastatic disease in the bones. So we gave her, the AI and the CDK4/6, 1.5 years, complete remission. We referred to Professor Chintamani, and he did the mastectomy. But unfortunately, within 3 months of surgery, very uncommon, she developed extensive meningeal disease. And she was HER2-neu 1 and 2 plus. So, but we stood with the standard treatment of radiation and intrathecal chemo. She didn't do well. She was paraplegic. She had lack of control on urine. And that's when TDXD got the approval. And within 2 cycles of TDXD, she started walking. The urinary incontinence was gone. She's had 8 cycles of TDXD, and she's doing wonderfully well. So I think that's the magic of TDXD for brain and meningeal metastatic disease. So she was quite frail. We gave her 200 milligrams. So she was about 40 kilos. And now she's gained weight, actually. Now she's become 50 kilos. I mean, it is amazing to see her progress because she's completely confined to bed.
I have given 1 dose of TDXD 4 days back. The patient is having bone marrow involvement and meningeal involvement.
Right.
So I'm yet to see those.
Right, but then it's too early days. I think within 2 cycles, maybe you'll see that effect. But this lady is doing extremely well, and we're wanting to write it up. So I think with this, we thank the esteemed panelists and everybody in the audience.
Can I make a comment?
Yeah, can do.
So what happens is, earlier we used to get this kind of patients for craniospinal irradiation.
Yes, sir.
Raj sir will agree with me. We used to get this kind of patient with a leptomeningeal spread for craniospinal irradiation. and it was very toxic.
We are still doing it.
No.
We are still referring to our radiation.
We are not doing
oncologists.
it. I am not doing it, honestly.
Well, I am referring.
I am not doing it. Honestly, I am not doing it because it is too toxic for patients. And you know.
No, but I think, Angel, I think what they do is they do the cranial part first, or you do the cranial part first, and subsequently do the spinal part.
So the thing is, you know, having a drug like this helps a bit.
No. You see, no modality is an absolute treatment, as you know. There's a 70%, 60% response rate with my drug. So radiation will have a role to play. So you just can't, you know, rule out these.
But CSI is too toxic compared to TX.
Correct. I agree with you.
I would go with drugs.
Okay, fine. Thank you. So thank you. So I think for realizing the. Yeah. For residual disease, this patient had residual disease and she was operated upon. I mean, after. We gave TDM1, right? That, as per the Catherine study. So I think thank you very much, all the panelists and audience. Thank you.
Thank you very much, Dr. Agrawal and esteemed panelists. I request Dr. Kataria sir to give a take-home message for this session as an expert faculty.
Yes. Good morning, ladies and gentlemen. This is Sunday morning. I think we all agree that HER2 new disease, which was earlier considered an aggressive tumor, I think we have sufficient armamentarium now that we are almost made it into a chronic disease. Most of our patients are going beyond even 5 years. And of course, now we have TXD, which is actually a game changer. And it's really improved our prognosis for overall, not even HER2 positive, but even HER2 low disease also. And NGS, earlier it used to be the fish and IC, but NGS is coming in a big way, especially in second line and third line setting. But one more thing I want to see is actually brain mets. I've seen, one case who has been irradiated and we gave TXD and he's suffered serious gliosis. Right? And there is an interaction between radiation and TXD, so we have to be slightly more careful when we are going to use it. I think thank you very much. Best of luck, everybody.
Thank you very much, sir. There is a slight change in sequence because of the flight schedules. I will invite I will invite Dr. Nirali later. First, I am inviting Dr. Arvind Krishnamurthy sir for early stage lung cancer review, Dr. Ruchi Tandon, Dr. Sanjay Rai, Dr. Abhay Kapoor, Dr. Kanuj Malik, Dr. Jeevan Ram Bishnoi sir. I hope he is reached. Yeah, I have not seen. He was on the way. Then Dr. Kajal Shah once again, Dr. Kuldeep Sharma, Dr. Sachin Khurana, and Dr. Bhushan Tombre.
I think a lot of them are outside. Yeah, Bhushan, please come and just. Kanuj is also outside, I guess. I saw him. Yeah. Right. So we have about 4 surgical oncologists, 4 thoracic surgeons, I think. Bhushan is there. Who else is the surgeon here? I think Kanuj was there. Who is the radiation person? You're the radiation person, right? Thank you. Thank you. Okay, I think must say that of course we had a wonderful session last evening also, and we are now saying that early stage lung cancers is becoming much more and more complicated nowadays. Earlier when I used to train, it was pretty much very simple. Like we used to operate, and then subsequently every other thing used to happen. So now the things are changing, and so these are my panelists. Again, now the latest data says that lung cancer has actually overtaken breast cancer, both in terms of incidence and in terms of mortality. So we are seeing a number one killer, and 75% advanced and 75% non-small cell. Traditionally, or to a large extent, it's known as a smoker's disease, and initially we felt at the start of the decade we had more of squamous histologies. Just wanted to talk through the panel. Are you all seeing the same phenomenon, or is there change in the pattern of presentation of lung cancer patients to you? Smokers, squamous. This is something that was sort of, that has been taught to us traditionally decades over decades, so how is the patterns now? Yeah.
We are seeing more of adenocarcinoma now,
Right.
non-small cell actually.
So everybody seeing more of adenos? Madam, you had...
woman non-smoker we see adenocarcinoma. In the male smoker we see both.
yeah, I think the mic needs to work for her. Yeah, but I got your larger point. Yeah.
And the age has also shifted.
Yeah.
More younger patients we are seeing.
Great.
Especially
I think
even now we are seeing more early stage.
More early
Used to be
stage?
before.
Okay. Bhushan, how is it in your practice?
Yes, same adenocarcinomas are now predominantly seen.
Right.
Maybe advanced also.
Sure. Yeah, I think the panel is seeing the same thing. This was a phenomenon that we saw very early in 2012 itself. In fact, when we published the series of adenocarcinomas being more than squamous, people really questioned us whether it was true or not at that particular point of time. But then we had publications in other centers from India, in Mumbai, Kolkata as well. And now, of course, we are clearly seeing that adenocarcinomas clearly outnumbering the squamous cell carcinoma. So at least 55 to 60% of the patients are adenos. And of course, the numbers of non-smokers, as Madam, you really correctly pointed out, also seems to be slightly higher. Of course, there could be various other reasons for it. I'm not really going into that at this point of time. But this is an important thing that we need to know, that our trends are matching the global trends of increasing adenocarcinomas and increasing never smoker population. Now, I think the most important thing, again, in the early stage cancer is resectability. Until what stages we consider it under the purview and what proportion. And you really made a mention that the numbers are slightly higher. Any takers? Or Bhushan, you want to take the call of... how do we sort of define resectability?
So I removed last year whole data of our institute.
Right.
I saw one of our students is doing publication. He found out almost 150 lung cancer patients were treated in our hospital. But I removed out how many were operated.
Right.
The figures we have to laugh. Maybe 5-10 only.
Okay. Fine. Any other thoughts on this? And the criteria of resectability, Bhushan, I think that is something that you'll have to sort of enlighten
criteria
on.
of resectability, whenever a lung cancer patient comes to a MDT or a oncology setup, the surgeon has to see and define him resectable or unresectable. So resectable is that whether the surgeon can resect it 100% with R0.
Okay. Got it. Yeah, I think.
So peripheral based tumors, or tumors not attached to the vital structures, smaller tumors, it's like within the lung parenchyma, those tumors. Hilar and peribronchial nodes, and nodes also no perinodal extension should be.
Right. Any other
resectable but medically inoperable.
Exactly. I actually had that, but then I thought I'll possibly come to it a little later. Operability, of course, it depends on the medical fitness of these patients. Of course, the other thing in lung cancer, we do have a specific prehabilitation protocol in which we try to get them better and then do the lung function. So that's possibly talk for another time, but a very important consideration in a disease of lung cancer where inoperability also matters. But by and large, as was said by the panel, anywhere between stages 1 and 2 for sure, I think you want to consider at some point of time for these patients. A large proportion of stages 3A also can be considered, can be brought under the purview of resectability at some point of time. Maybe a very, very small percentage of the 3Bs also. Again, it's the N2 disease. I think that is where the major issue is there. Any takers? How are you maybe for a radiation oncologist? If you are seeing an N2 disease, what do you feel like, is there a role for surgery at all or not in these patients, or how is your thought process in an MDT?
So you are asking a radiation oncologist
whether you would, if supposing the patient comes to you upfront, like, I don't know, because the patterns of presentation for patients in various institutions may differ, because 80% of them are metastatic or stage 3 or stage 4. Sometimes the medical oncologist may be the first person of contact, but in many other centers it could be slightly different. I don't really know the practices, and a lot of the practices seems to be different, and that's the reason why an MDT approach is really the need of the hour. But I just wanted to ask, if a patient is presented in an MDT with an N2 disease, would you sort of, feel that this patient would benefit from surgery at all, or you feel that, these patients should go the Pacific way, like, give definitive chemotherapy and radiation and maybe consolidated durvalumab? Is that your thought process? Any takers for a non-Pacific route for these patients? Or?
Yeah, if a patient comes with N2 disease, then
N2
course,
disease.
as per the literature, they are potentially the potentially resectable cases.
Right.
But if you look at the practical scenario in India, especially the N2 cases, generally I don't see much surgery in those cases. So a strong consideration should be taken for CTRT in such cases.
Right.
And if you have a good surgeon, and if he thinks that it will be resectable in future, then again a neoadjuvant approach should be considered, because directly going for surgery in N2 is...
No, we don't. I'm just saying at surgery at some point of time. You're right. I think it's easier to find N2 disease, difficult to find a good experienced thoracic surgeon who can actually address these issues. But by and large, let me put a second point, is that, N2 disease is pretty heterogeneous. Now, I guess we have an EORTC consensus in which they divide the N2 disease into a single non-bulky. Most of them come into the resectable purview. Sometimes N2 invasive, they are never. And there are sometimes two other category of patients. N2 non-bulky but multiple stations. Some of them can come under the purview of surgery. And N2, which is a bulky and multiple, again, it's a toss. Like, it depends on individual scenario. So I think the N2 conundrum is an important consideration, and some of them do come to surgery. So my message is, just because it's an N2, don't rule out a potentially surgical option for these patients. Of course, if it's an invasive N2, if it's a bulky multiple station N2, they go the Pacific route. That is, you clearly say that possibly they are unresectable, and you give definitive chemotherapy, radiation, and consolidate with the durvalumab based on your practices. But otherwise, surgery should be a consideration. But I also contend that with Bhushan, less than 15% of our patients fall under the purview of 1, 2, or 3A. And globally, I think it's around 25%. So by and large, globally 75%, and India maybe slightly more, 80% fall under the purview of not coming to surgery. So let me go directly to a case scenario. I think that's where a lot of these discussions come. 53-year-old lady, PS1, never smoker, cough with expectoration. She went to a physician, CT chest with contrast, left lower lung mass, referred, PET CT. Everybody does PET CT. Is it Kanuj, please come. We're looking for you. Come, Kanuj. PET CT, everybody does. Is there any difference at all? Everybody does a PET CT in the management. Oh, great. I think, of course, the guidelines say that PET CT is preferably done 30% of times. Changes in management happens. But even if you don't have, some of the guidelines say that you can do it. But by and large, with the greater availability of PET CT, most of us tend to sort of do this. And this was the finding. I've just put the most representative image, 6.5 centimeters, the largest dimension. It was just in work, abutting the parietal pleura, no mediastinal nodes, no uptake elsewhere. Yep. And this was the finding. So now further tissue diagnosis, molecular. So how do we sort of proceed? Like, how do you achieve the tissue diagnosis? Any of the
I think this is abutting the pleura, so it should be very easily done under ultrasound guidance.
Yeah, perfect.
The important thing to understand, a lot of times we get referrals for biopsy from such lung masses. And after the biopsy, PET CT is blind.
I think that's a wrong way to go. If you are planning a PET-CT, it should be done before the biopsy, because a lot of times there are a lot of necrotic areas. You end up with a negative sampling, and then you go on to repeat. So PET-CT should be done before the biopsy, ideally if it is scheduled.
Yeah, perfect. And of course, nowadays you have a different technology called Maxios. All these things, they guide to take the biopsy, as you rightly pointed out, in the non-necrotic areas so that the yield is there.
Maxio is something, as an interventional radiologist, we totally want to be away from it. It will take you anyway. It might take you needle into the heart also. So in India, we are very used to freehand practice, which is far better than Maxio.
Oh, great, fantastic. We respect our individual skills, and that's better. But at the end of the day, yes, I think this was an easy pass. And again, molecular testing. So how is it that we go about this?
We do generally in stage 1B, 2, and stage 3.
Yeah, I think the mic, madam's mic needs to be adjusted. I think I can hear, but just for the benefit of the entire hall. Yeah, maybe just keep it a little closer. Yeah.
In this patient, we do molecular testing, PDN1, EGFR, ALK testing. And routinely we do in stage 1B, stage 2, and stage 3 lung cancer and all metastatic.
Right. I think you've given a textbook answer. I just want to know from the entire panel, is it your real world? And that is what we are trying to sort of discuss here.
So we are going for a comprehensive
comprehensive genomic profile. So everybody comprehensive genomic profile? Kanuj?
No, not at all.
My medical oncologist is sitting there only,
yeah,
so I have to agree with them.
Now you can come. Yeah.
No, but we prefer, if it is affordable, then yes.
Right. No, but what are you doing in real world?
This case only EGFR ALK is sufficient.
Right. Fine. I think we had a discussion again on this yesterday. It's mandatory or important to get an EGFR or ALK. I think that may have a treatment implication. PDL1 you may choose to do, but I'm not really sure, because was discussed in the breast by Hemant sir, I think irrespective of the PDL1, you do have a lot of the trials, or majority of the trials, the consensus is you can sort of give chemo-immuno in case you choose to go that option. But EGFR or ALK is mandatory because most of the patients who come the chemo-immuno route should be wild type for both these driver mutations.
One thing about the real world practice, as sir said, that biopsy should be done after the PET-CT.
Right.
Most of these patients are first encountered by pulmonologists and not by us.
Right.
So when the pulmonologist gets a CT scan, they would most of the times would have done a biopsy, and when it is confirmed to be a cancer, then they would send it to us.
Right.
And after that, we do the staging investigation.
And 50% of the time, the biopsy turns negative, and then the patient sent us for per occurrence biopsy.
No, but I'll tell you, I think to talk in favor of the pulmonologist, sometimes they use EBAs to guide the biopsies, and in some of the central lesions, they not only biopsy, and they also take enough tissue. And we have got a good intervention pulmonologist. I'm sure a lot of good people are there across the country. They are able to do good cryobiopsies so that you get a good yield, and molecular analysis also can be done. Sometimes they can target the node also, so in which staging is also done for these patients, and as well as you get a tissue for molecular diagnosis.
Central lesions are definitely better to sample by EBAs, but like a left upper lobe or right upper lobe lesion, if somebody tries to sample those, I think that becomes an overkill.
Yeah, by and large, I think majority of the biopsies are done by the IR guys, I think, and especially for central lesions, as I said, and some of the nodal things, we rely on our interventional pulmonology.
Actually, since we are years, we have taught as an oncologist to pulmonologists that catch the disease early and do CT and do biopsy when PET was not rampant. So they are in that practice. Now you have to teach them do PET scan.
No, but
from first time you see.
Yeah. No, but I'll tell you, practices vary. In the UK, I'm not sure, but this is what I heard. A lot of these patients would actually go to the pulmonologist, and the pulmonologist would refer the case into them. So the pulmonologist in many other countries are the first point of contact for all these lung masses, essentially. So again, in our country, practices are so heterogeneous. Sometimes they go to pulmonologists, sometimes they come to us, and all those things. So, but I guess I think we'll have to do it the right way. Whoever is doing it, pulmonologists or us, we have to sort of follow the routes. Again, MRI brain, I think most of us do it for all these. It's pretty much standard in the guidelines, and this is what it was, a driver mutation negative. And mediastinal staging. Now I'm coming to these. Kanuj, your take on it, of course we have this. I'm just putting this off because we have very short time, and Sumant has given me a very short time. So this is the mandate. Like they say that EUS, EBAS combined is every station, you can actually sample with a combined EUS-EBUS approach. And these are some of the numbers or color shadings that I've given. And where does mediastinoscopy fit in the entire gamut at this point of time? And I want your real world, what you do in your practice. And maybe each of you all can also have your take on that. Because this patient is a 6 centimeters tumor, but of course the PET is saying negative. So if your EBUS is negative in this particular case, would you start that, or how is your practice?
If the clinical suspicion is too high,
right,
and then a mediastinoscopy is indicated.
Perfect, perfect. I agree. Like, no, Kanuj, what is it like? No?
Honestly, I've not done a mediastinoscopy after, since my pulmonologist is doing EBUS.
Right.
I saw mediastinoscopy in a workshop in Tata.
Right.
Just to keep myself updated that has been done, but I have not done in my last 1.5 years.
Perfect. I agree to you. Bhushan, what is your take on it?
I will say 3 mediastinoscopy in last 5 years.
Perfect. Okay, you had a take, sir.
In this patient, it was a uptake. There was a good uptake in the primary, but there was no uptake in mediastinal nodes. So in such scenario, when EBUS has come negative, so I think once the PET has been done and EBUS has come negative, I think we should go ahead with the treatment.
Okay.
Because many times these things.
So it's an important consideration. Initially, some of the trials and a lot of the guidelines actually said that even if your EBUS is negative, you'll have to do sometimes a confirmatory mediastinoscopy in these cases. But now, I think the technology is getting so much better. Now the concordance between the EBUS and the mediastinoscopy seems to be pretty high. And so in a real world, a lot of people tend to sort of avoid, and this is what we had, I think, had just written an editorial in the CRST, maybe this was many years back. Of course, there are multiple other issues, availability of equipment, more importantly, availability of expertise, and this is true. Jeevan, come. We were waiting for you. This is true both for EBUS also. It's difficult to find a good pulmonologist to do a good EBUS also. Equally more difficult to find a good surgeon to do a good mediastinoscopy also. But again, it is important that you have one of the two facilities available with you if you want to sort of, practice lung cancer management in an evidence-based manner. Again, functional evaluation, let me sort of, in the interest of time, let me proceed by saying that, of course, there are two ways of going about it. The American protocol, European protocol, as is that there were always not two groups of thoughts are always there, in which the CPET is something that people, you all do CPET in your practice for functional evaluation, Bhushan? Or?
I think so, in
rare
humoral only, because those rare cases we really screen them out when we have different modalities of treatment nowadays.
Right. Okay. So I think the Europeans rely more on the CPET for early sort of segregation of your risk categorization of the patients, but Americans, they sort of do it the conventional way. They use the PFT, DLCO, and based on the cutoffs, less than 30 to 60, more than 60, and based on that. So it's a very complicated algorithm, but so much to say, but this patient, the lady is fit. 53, PS1, never smoker, absolutely fit, left lower lobe lesion, T3N0, the EBUS was negative, mediastinoscopy not done. Now, I think this is a prehabilitation protocol, I just had this slide, but I guess the crux of the thing is how do you go about the management in real world? This is a stage 2B cancer. Each of you all can take, I think, and this is the main thing as to how do you sort of want to go. Upfront surgery followed by adjuvant chemoimmuno. Do you use the perioperative or the neoadjuvant approach, or only chemotherapy, or addition of radiation therapy also,
Actually, neoadjuvant chemoimmunotherapy is advised if tumor size is more than 4 centimeter and node are positive.
Right. No, I think I just want you to stick your neck out and choose one of these options.
Patient is ready for neoadjuvant chemoimmunotherapy.
So chemoimmuno, sir, any radiation?
We can avoid radiation.
Right. And where do you fit in radiation? I think a lot of times, we are finding that in lung cancer management, now somehow the radiation oncologist role seems to be slightly shrinking. Initially itself, it was slightly lesser. But now after chemoimmuno come, I think we are finding it hard to fit in the radiation in the protocol. So where do you sort of, use your radiation in specifically in the scenario of lung cancers? Leave aside the SBRT debate. The SBRT and surgery is a debate for another day. I think I deliberately didn't want to bring it out, because I think Suman said that we have to discuss more contemporary issues, and the more contemporary issue is now the chemoimmuno thing.
Yeah. Now, apart from the definitive radiation, the role of adjuvant radiation, of course, it is going down. But still, there are good, clear indications. For example, if there is a positive node, or if there is positive margin, or there is multiple stations, or extra nodal extension, or it is the means superior sulcus location. So these are some specific indications. So although few trials have shown that in early setting adjuvant radiation has not given us good results, but radiation should not be written off like that. So if there is a suspicion, a radiation oncologist opinion should be taken, because these indications, if present, we have to
very elegantly said. Just to sum up, I think positive margin is a major indication in which I think majority of the guidelines seem to say that you give. Another thing, as you said, superior sulcus tumors. Unfortunately, for all the chemoimmuno trials, these set of tumors were excluded for some reasons. They did not include the superior sulcus tumor. So that is why a majority of the times, even now, if you have a superior sulcus tumors, I think they go for the neoadjuvant chemo-RT ways. But I guess some of the trials now are trying to include superior sulcus in the chemo-immuno trials also. There is no reason to actually exclude those, but right now the guideline says. And as you said, like in a post-chemo setting, when you have multiple station nodes, extra nodal, maybe because of the lung art, you had a subgroup of some of these patients. You really have to tease out some of these patients too for the benefit of
one more indication is when patient is not able to take systemic therapy for some reason. So in that case, adjuvant radiation should be added, because sometimes that is on.
Yeah, perfect. Again, let's come to the what do you choose?
Perioperatic.
Let's keep finances aside for some time, because I think let's not go into that. We know it's true, but let's keep that aside. Let's talk purely on the merit of science.
Perioperative chemo.
Perioperative chemo.
Chemo-IO.
Yeah. Bhushan?
Perioperative chemo.
Yeah. Bhushan, Jeevan, I didn't, you came late. Yeah.
This was an N0 disease.
Correct.
Right. 20% of the patients in all the trials across for chemoimmuno, we would lose them to surgery. If the surgeon is saying, yes, please go ahead, it's a peripheral lesion, go ahead with the surgery. Why chemoimmuno over here? Are we looking at the translation into a PCR and get satisfied with, what we were talking earlier in breast, and there were debates in breast, why are you looking for the PCR? Eventually it would happen.
I wanted one of the panelists to bring it out. So, you brought out the controversy. But I guess so.
And also, all the trials are clearly showing it's the nodal positive subset which is actually benefiting the higher risk.
So I think good, Piyush, that you brought these points. I just want to make 2 points in this. There have been no head-to-head comparisons of neoadjuvant chemoimmuno versus, say, the adjuvant chemoimmuno. You have separate trials, but you should not do cross-trial comparisons. So we don't really know whether upfront surgery and adding chemoimmuno later vis-a-vis given neoadjuvant chemoimmuno is better. But for all practical purposes, majority of the experts across the world seem to sort of prefer the perioperative approaches for some reasons. The other thing is, again, you brought up a very important point, whether you use it in a stage 2 cancer versus a vis-a-vis stage 3 cancer, and your point is well taken that the benefit of the chemoimmuno seemed to be much more in the stage 3 patients. But the meta-analysis that Dr. Hemant sir also presented yesterday, and we had a brief discussion yesterday published in the JAMA earlier this year by Jonathan Spicer et al. They clearly showed a hazard ratio of 0.7 favoring the there were multiple meta-analysis, about 5 or 6 of them, and the hazards was published a little earlier, and subsequently their group also published one more editorial, and they say that even in stage 2 you can sort of go the chemoimmuno way, but again I want the surgeons, Jeevan, why don't you, again from Piyush's thing, why don't you operate? This is operable in the sense you just do a good left lower lobectomy. Maybe you may have to sort of open, because it's around 6 centimeters. Sometimes what we have done is some of these patients we started off robotically, we finished it robotically, but to retrieve the specimen we had to sort of put the incision a little bit because the tumor won't come out essentially.
So actually earlier we were doing like upfront surgery followed by adjuvant chemo in all those cases. But now this trend is shifting towards like perioperative, or because of I think because of additions of immuno also. So nowadays, like consensus in most of the tumor board cells also, our in tumor board is also shifting towards to give some sort of then consider for surgery.
So fantastic. I think last, because I think they are really pushing me. So as I said earlier, when I used to train, all these patients were operated exactly the Piyush, and now even there could be some hardcore thoracic surgeons who would sort of not send their patients. But I guess in a multidisciplinary clinic, which early lung cancers really mandate, a discussion has to be there for consideration of neoadjuvant chemoimmuno even in the stage 2. And believe me, this tumor is almost a stage T4 lesion. It's almost 6.5, about a 0.5 centimeters more. It would actually stage shift to again stage 3. So again, although theoretically it's a stage 2, it's a straddling around stage 3. So I think my personal preference would be to give the chemoimmuno approach for these patients. Any quick comments? Otherwise, we will sort
Only
of.
Only thing I will add: early PET in this situation to be satisfied with the things.
Early PET.
Early PET after 2 cycles, I would like to.
Okay, for
satisfaction that it is responding.
Okay, okay. No, let me tell you, I think the guidelines actually say that, even if you do a CT scan for evaluation of response, again, there is another debate whether you give 3 cycles or 4 cycles, because in the keynote 671, they gave 4 cycles and they got a survival advantage. So now everybody was sort of, but in the earlier trials of, maybe the Checkmate 816, they were giving only 3 cycles and operating. And that seemed to be the standard of care. But after the survival advantage of the keynote 671 with 4 cycles, I think the ball is again shifting whether you give 3 or 4 cycles. And the guidelines say CT scan should be reasonably good enough. But I take your point. In case you want to do a PET CT for response assessment, it's fine. Bhushan, quick point and we close.
I look into this case as like if I give chemoimmunotherapy, the tumor will shrink probability.
Right.
And chances of doing a minimal invasive surgery is very much high.
Right,
for
right.
that specimen retrieval, I need not open much.
Right.
No, and also the PAT-CR.
Yeah, right. PAT-CR is anywhere between 17% to 40% in some of the series. And of course, minimally invasive surgery, as Bhushan said, is eminently feasible in some of these patients. Although a lot of reports of fibrosis, inflammation, post-chemoimmuno are there. Technical challenges are there, but there is a higher chance of conversion to open surgery in some of these patients. You have to be very careful, judicious, because sometimes the nodes really shrink and the fibrosis is extremely difficult to sort of, handle intraoperatively. But by and large, I think more real-world evidences have come that that surgery is reasonably safe in these patients.
Okay, one comment regarding the etiology about the non-smoker. So in this time, modern time, in all the cities, is anyone non-smoker exists when there is a lot of pollution is there?
No, I agree.
We have to relook at from that point.
So your point is taken. Even in our publication, what we have said is they have been never smokers, but it is not that each one of us is exposed to environmental tobacco smoke, and I cannot make a more compelling point in Delhi, at least, where the air quality indexes are really pathetic. I think that is a reason why lung cancers are probably driven, apart from the driver mutations, in some of these never smoking population. Thank you for your points, and thank you all the panelists for your thing, and thank you once again.
Thank you very much, Dr. Krishnamurthy and esteemed panelists. I would request Dr. Shyam Agarwal sir to give take-home message for this session.
So, wonderful session. A few take-home messages. So these patients have to be resectable NSCLC judged upfront by imaging modalities. So they're not potentially resectable, they have to be resectable. So which are like, as they said, 3A. So that is number 1. You have to do MRI brain, you have to do EGFR and ALK, they must be negative before we subject them to chemoimmunotherapy. So, in the trials, the progression rate or not proceeding to surgery is about 20%. And 7% of those patients really progressed. But that was equal in both the arms, right? So 80% patients underwent the surgery. And they also have to be ready for converting to pneumonectomy. So 5 to 10% patients who are perhaps, amenable to upfront surgery or a VAT surgery may be converted to pneumonectomy because of that extreme fibrosis and the changes which happen due to the, chemoimmunotherapy. So I think these surgeons have to be prepared for those kind of open, and pneumonectomy as well. But I think more than 4 centimeter, node positive, resectable cancer, today you have very clear role for either neoadjuvant as per 816 or perioperative, which means neoadjuvant followed by adjuvant. So I think immunotherapy really is the in thing for resectable NSCLC. Thank you very much.
Thank you very much, sir. A role of expert is very important because in the due course of discussion, sometimes we get lost. So bringing back everything on track, what to take it out. Now, moving from early lung to metastatic lung, I would like to invite Dr. Shatish Domaria from SCG Hospital, Ahmedabad, along with the panelist, Dr. Siddharth Sood from Faridabad, Dr. Piyush Bajpai sir, Dr. Sonia Tiwari madam from Allahabad, Dr. Kinjal Jani, Dr. Ishu Gupta, Dr. Sajjan Rajpurohit. Is he around? I'll have to call. Shivam, please call Dr. Sajjan. Dr. Mohit Saxena.
Okay, so good afternoon, everyone. At the outset, I would like to thank the entire organizing team for giving me this wonderful opportunity. And thank you, Arvind sir. He has really set the stage up. And yeah, so moving from early lung cancer to, we have many radiation oncologists in the panel. So I have kept it a bit locally advanced sort of lung cancer management. So I won't be showing any clinical trials. It is just, informal sort of discussion, focusing on what actually the real world practice is, how we are actually doing about it, and whether we are doing right or wrong. Okay, so again, heartily welcome to all the panelists. I think it's not moving. Okay. Fine, so I will just start with a simple case. This is a case of a 62-year-old male smoker. He was evaluated by a well-known physician for cuff and right-sided chest pain for 2 months duration. CT chest was done on 5th of June 2024. This is a real case which we encountered, and that was suggestive of a 5 by 3 centimeter, maximum 5 centimeter dimension, right lung apex with cortical erosion of the right first rib, with enlarged right paratracheal hilar lymph nodes. Some emphysematous changes were seen, and this physician has referred it to you, so okay, you manage it. Okay, so I think this point was well covered in initial presentation by Dr. Arvind sir, but still, for the sake of discussion, what is the usual practice at your center? Lung mass which looks malignant on imaging, first biopsy or first PET-CT?
So the important thing is, if we have a very small lesion, we would prefer doing a PET-CT upfront,
right,
and then evaluate whether we want to do a biopsy or not if we are in a doubt. But if there is a large mass and it is a biopsyable, right, then we would go for a biopsy first, and then we go further.
Because so biopsy first followed by PET-CT?
Followed by PET-CT. That is a routine practice. That is a routine practice. But yes, for a very small lesion, which is a doubtful lesion, yeah, we might go for a PET-CT first, which happens for a head and neck malignancy also.
Right.
As we discussed in our MDT, like that happens for a small lesion where we do a PET-CT up front and then go for a biopsy. So we know where to do a biopsy from. It's a valid point to discuss because sometimes you do a biopsy from a lung mass and you get a biopsy from a place which comes out negative, and that patient is actually positive.
Right.
You get a biopsy from a necrotic place and it comes negative.
So I think for this very good reason, we generally tend to prefer doing a PET-CT followed by a biopsy in a lesion which seems quite malignant. Any difference of opinion?
Yeah. No, just to add another point, that sometimes with this sort of presentation you get a small adrenal lesion.
Right. You would also want to put on the table the patient again back for a biopsy. So better to have complete information sending,
Right, exactly. Fine, so moving ahead. Okay, so fine, a PET CT was done and the maximum dimension was 5 centimeters, pleural base lesion in a apical segment of the right upper lobe, marginally bulging into the adjacent lateral aspect of the first intercostal space without any obvious rib erosion or mediastinal infiltration. If you look into the lymph nodes, there were subcentimetric lymph nodes, bilateral supraclav, right upper and lower paratracheal, subcarinal, right hilar, subaortic, largest in the right lower paratracheal, 19 by 12 mm, SUV of 3. So this is what the PET CT findings were. Right, there were no any distant METs which was seen in PET CT. Okay. Biopsy was done and that was classical for adenocarcinoma. Okay, now this is what we have. Now what further evaluation one would like to do at your center? Anyone can take up this. Regarding, you have a supraclav, you have bilateral mediastinal nodes, not very much, FDG avid, but this is what you have, and a lung lesion. You have done biopsy from the lung lesion and that is adenocarcinoma. So the points to be discussed is supraclav sampling plus mediastinal sampling. You need both the things. You need only supraclav followed by mediastinal. What steps you will follow?
So this is a typical case to be discussed in MDT.
Correct.
The reason is, eventually, if you are going to operate this patient, we need to have a mediastinal staging done.
Okay.
Supraclav, yes, we need to do that.
Right.
Many a times what happens, we get a mixed picture of a lung malignancy with a tuberculosis or an infection.
Right.
So we need to prove it having a supraclav. To be very honest, it's an inoperable case. So it's going to be systemic treatment plus or minus radiotherapy eventually for this patient. MR brain, yes, has to be done. For any lung malignancy, MR brain has to be done.
Right.
So there is no question about that. But yes, for a mediastinal staging or a supraclav biopsy has to be done for this kind of patient if you are planning for a curative treatment.
Okay, fine, fantastic. So any other point of view?
I just want to add one point that I think it should be one by one. We should do supraclavicular node biopsy first.
Okay.
If it is positive, then it will favor radiation. I don't think that in the opposite supraclavicular we will going to do for surgery. So that's what my take. So first we would like to do supraclavicular node biopsy. Then if it is positive, then it will go in favor of CCRT. And of course, then we are planning for CCRT, then there is no point of doing mesenchymal staging. If the point is favoring surgery, then of course mesenchymal staging is required. And there is no doubt about MRI brain.
Right. So again, you just do a supraclavicular sampling, prove it. Okay, it's malignant. You can avoid the mediastinal. That's the second thought. Right. Anyone else wants to add anything to this? Fine. So what we actually did was we did a supraclavicular sampling. Oh, I think we all know, everyone knows when to do a mediastinal sampling. When one can avoid that, especially if you have a peripheral tumor less than 3 centimeter, there are no enlarged PET avid lymph nodes, you can probably avoid mediastinal staging. And I think in rest all scenario it is very, very necessary. Obviously you avoided doing an extensive mediastinal N2 infiltration. I think that's all fine. Okay, so what we did was a supraclavicular lymph node sampling that was positive. Mediastinal staging was not done. MRI brain was done and that was normal. Okay. So just in brief regarding what currently is the MDT status in your institute and how you are doing it, a brief for everyone. The real thing.
So I and Kshitip do it together. Okay. So we work together, so we do it for all our patients. But anybody can.
In person, most of the cases, I think so all cases I would put a tick over there, which specialties are included, so almost everybody is invited.
Okay.
And
so you discussed all the cases or all the interesting cases or only the locally advanced ones?
They become interesting once you discuss.
Once you discuss it. That's a nice point.
Yes, of course, we keep a record of it. We have Excel.
Yeah, obviously. So somehow it is very important to have those discussions. It is important for patient management as well as it is important to have a good bonding amongst your peer colleagues. So I think it's very important to understand what the radiation oncologists think, what surgical oncologists think. So medical legal purpose also perfect. Yeah. Okay, fine. So many studies they have proven this MDT approach gives the best outcomes for the patient, especially in locally advanced case. I think this is also has been covered, but just for the sake of discussion, what further molecular tests would you like to do on this specimen? You have got an adenocarcinoma. What further molecular tests would you like to do?
Yes, PDL1 definitely, and we would prefer doing an NGS.
Okay.
The thing is, better to do an NGS upfront rather than doing it when patient fails.
Right.
So better you do NGS upfront. Of course, EGFR and ALK are part of it.
Right.
Having an adenocarcinoma, if the patient is a non-smoker
right.
and a female patient, we would definitely be doubting that that patient would be EGFR or ALK positive. So
Right.
we do that upfront.
Right. So apart from stage 1A lung cancer, I think NGS should be sent in all stages, irrespective of the stage or irrespective of histology. I think, is this a comment which is fine with all of you? Apart from stage 1A, all stages, all histologies, send NGS. Limited panel, comprehensive panel, tissue plus liquid, whatever you want to send, but send NGS. And I think we all now, because initially we used to do that EGFR and ALK and reflex testing, I think now we have that panels and which can cover at least the common driver mutations which are there, at least 12 or 16, whatever they are. So I think this has been a standard practice now across institutes. So what we got was no any clinically relevant pathogenic mutation was detected. PDL1 was done by 22C3 DACO platform with a TPS score of 70%. So very high PDL1 expression was seen, right? So I think we can skip this, and this is the summary of the case. 62-year male, smoker, good performance status, lung non-small cell adenocarcinoma, it's N3 disease, supraclavicular lymph node is positive, there is no targetable mutation, and 22C3 DACO is having a very high PDL1 expression of 70%, right? So these I have listed all the further management options. And I would like to have opinion of everybody on what is their plan of anyone for surgery. First of all, anyone for surgery in this case. So I think that's very clear. You have a supraclavicular N3 disease and that's out. So no for surgery. Now the choice remains between chemo radiation upfront versus you want to try some systemic treatment first. So what's your gut feeling?
I would go for neoadjuvant chemoimmunotherapy followed by response evolution. Like that is my opinion.
Okay. Okay.
Neoadjuvant chemo IO.
So everybody, neoadjuvant chemo IO, no difference of opinion?
Chemo radiation followed by adjuvant durvalumab over here. That's what we have the data.
Okay.
Until unless the radiation oncologist is saying that the field is going to be too extensive, because whatever the response of chemo IO would be, you might not be able to shrink your fields.
Right. So one very important point.
Keep the same fields.
Right.
So I don't see a point of introducing early chemotherapy.
Right. Again, a very, very valid point.
I agree with sir. I think if the plan is the radiation, then it should be definitely chemo radiation followed by consolidation durvalumab. That's second point. Unless the radiation oncologist is not comfortable in giving radiation upfront, because neoadjuvant QIO data is for, of course, where we are planning for surgery. If the node is N3, then I think surgery is out. Then there is no point.
Absolutely valid point. If you
QIO.
just look into the evidence and data, I think we don't have a good quality evidence of giving a neoadjuvant chemoimmuno in N3 disease or T2 or T3 N3 disease, because all the perioperative trials were till resectable NSCLC, or either they are for resectable NSCLC or they are for metastatic NSCLC, but we don't have any evidence to give chemoimmuno in such a scenario, and that is absolutely true. Very valid point. Okay.
So the comment, I absolutely agree with them. the point of giving a neoadjuvant treatment for this kind of patient is having a peripheral lesion with supraclavian nodes and a mediastinal nodes.
Right.
As rightly mentioned by sir, that we are going to cover the same area in radiation field. If the patient is a good responder, because what happens, when you are covering a larger area, there is very high chance of a radiation pneumonitis. Because if you are covering a large area, very high chance. So if we knowing from the neoadjuvant treatment, so in any site of the body, the role of neoadjuvant is coming up in a big way. Like if you take it like cervix, internal trial has come, we give neoadjuvant chemo followed by chemo radiation.
Right.
Earlier we used to give chemo radiation for a cervix 3B, now we don't.
Right.
So similarly, giving a neoadjuvant treatment gives us an idea whether this patient is potentially curable or not.
Right.
Having a supraclavian node is a bad disease with a mediastinal node. So
So-
that was the reason, I would prefer, and you would also agree with me that in our tumor board,
Right.
what we would do, you would agree with me that we would go for either neoadjuvant chemo or neoadjuvant chemo immuno followed by response evaluation, because 70% PD-L1 positive.
Right.
So
70%
we will be
will
tempted to
positive.
go towards that.
Right. Right, so two thoughts, a definitive CTRT versus neoadjuvant treatment, neoadjuvant chemoimmuno. We have Dr. Hemant sir, Dr. Shyam sir with us. Sir, your gut feeling in this, what would you do, sir?
The question was, the N3 included in the Pacific study.
Yes.
If that was included, then I think Pacific followed by Durga would be the right.
Right, so if you look into the evidence, it is specific. It is specific. We don't have an evidence of neoadjuvant chemoimmuno as of now. So, yeah. Hemant sir?
So if you are, obsessed with data-driven treatment, then
that was important point.
But if you consider stage 2, stage 3 non-small cell lung cancers as systemic diseases with micrometastasis happening at diagnosis, even in stage 1. I mean, that is the evidence which we have. Survival, even in stage 1, 5-year survival is 60-70% only, and the cause of mortality is distant metastasis.
Right.
So we will get the data, there's no question about that. So, I mean,
Yeah,
it's
so
like
data is one thing, and your MDT discussion is one thing, and I think both things are important, but the important thing is to discuss the case with your colleagues and decide upon, because in some scenario you won't have a proper guidelines to guide you.
100%.
And I think most of the
guidelines, when you have a patient in front of you, you have to decide the best possible treatment for that
I
patient.
think most of the centers, they would prefer, I think, giving a systemic treatment first in this scenario. Okay, anyways. So what we decided was to start with chemotherapy, first cycle, pemetrexed, carboplatin. Then we had the reports of NGS and we added immunotherapy from the second cycle. I think this is a very common scenario. We just don't, is this the one being followed at your institute? You start away, wait for the NGS and then decide on chemoimmuno. So the practical thing is you can just look it into EGFR ALK, you get it in 3 days and then decide, or you wait for NGS 2 weeks and then decide your plan, or you give one cycle chemotherapy, wait for the NGS and then add immuno or from the second cycle. So anyways, what we did was we gave first cycle chemo, then second cycle we add immunotherapy. Post 2 cycles we generally tend to do some imaging, and that was done, and that was a stable disease. We continued for 2 more till 22nd of August 2024. So that was the comparative PET-CT, 11th June versus 9th of September, and what was shown was there's a decrease in metabolic activity in the primary, decrease in size and complete metabolic resolution of the bilateral supraclavicular lymph nodes. So overall, as per RECIST, it's a partial response to the treatment. So this is what we are having as of now. Okay. So now I don't think so. Any point in doing mediastinal staging now? Okay, fine. So you have given 4 cycles, 3 cycles chemo, 4 cycles chemo, 3 cycles chemo immuno, whatever, and you got a good response. Now what you are to do? Now choice would be to give chemoradiation, or you want to continue with the systemic treatment. What would you prefer?
think it is an N3 disease, and the initial intent that was decided upon was a neoadjuvant income induction intent.
Right.
So we would rather offer the patient the local therapy also.
Okay.
And then continue with the IO.
So you want to give local treatments. So any technical challenges regarding the fields, because the bilateral supraclavicular, a large node and mediastinal node. So I would like to have comments of radiation oncologist on this.
I would not make a comment because I know about this patient. Let her make a comment.
Right, right. Okay, yes, ma'am.
Yes, we can. Hello. Chemoradiation local therapy is a suitable option. In this case, if patient has response to the chemotherapy, neoadjuvant chemotherapy, then see how patient respond after radiation, and we can continue the chemotherapy and IO after as a maintenance. I think pembrolizumab and pemetrexed is a good option.
Okay, so you don't want to radiate, you just want to continue with the systemic treatment. Sir.
Since beginning, I am in favor of definitive chemoradiation followed by durvalumab.
So I that's fine. Okay.
Follow the same.
So, but any challenges in the fields, or you are fine? You will cover.
Sir,
it's okay.
So the neoadjuvant doesn't change the.
One more, you have given immunotherapy.
Of radiation.
Do you think any pneumonitis would be, worsened because of giving RT or anything like that?
But anyhow, it is still curative, so we don't want to lose that window.
Fine.
Of course, there will be challenges that patient might develop some sort of radiation pneumonitis, and of course, patient has received immunotherapy as well. So, but still, it is still curable patient, so we would like to offer.
Right. Okay, fine. So, what was finally decided was just to continue with the systemic treatment. Pembrolizumab plus pemetrexed for 3 more cycles, assess the biology, and then decide for some local treatment. So that was planned in the MDT.
I think so.
And sorry,
as at baseline only that this is a pretty extensive field,
right?
And the reduction in the field is not going to be there. If the patient is doing well, has got a PDL1 of 70% above, much above 50%. So these patients would 30 to 40% of them will be long-term survivors.
Right.
Why to actually pitch in with the local extensive radiation?
So that was exactly
for
the
oligoprogression.
point. Yeah, that was exactly the point.
That is what we had decided. That was the reason I did not give a comment. I and Kshitij discussed about this patient together in the MDT, and our final decision was not to go ahead with local treatment. As rightly, I would agree with ma'am. We did the same thing, that we continue, because giving a morbidity to the patient when a patient has a excellent response with immunochemo, why not to continue him on immuno only?
Right.
So eventually, the thing is, it should not be that, if I'm a surgeon, it's not that I want to operate, and if I'm a radiation oncologist, it's not that I want to radiate this patient. It is about what you do that for that particular patient. That is the most important thing, specifically for lung lesions, because these are the patients who will have a lot of morbidity.
Sir.
This is a potentially curable disease.
Right.
Look at the specific data, I think it's strong. Right. So I think that should be discussed in the MDT and should also be passed on to the patient and the family. So let them be a part of the decision making, because with the immuno alone, you have a 20% chance of a 5-year, survival, whereas with specific, the data is much better. So I think this is the side effects, of course, which is what you were stopping you to do the radiation.
Okay, so suppose we have decided on CTRT, given definitive chemoradiation, then what after that? Should we continue pembrolizumab or durvalumab? Right. So these are real world cases which we face, and these are.
Ask one thing in this situation. I am with government sector, so in my rate contract list, durvalumab doesn't exist, and I do face these situations. I am substituting with pembro. When patient goes to private for second opinion, he comes with a prescription durvalumab. So it's a difficult situation whether I am doing wrong, because those drugs are indicated in stage 4 and stage 3. There are no trials in stage 3B, but that doesn't mean that they will not work. So IO can be substituted.
So a thought, Me Too drug, you can use any IO.
For a residual disease, for a residual disease, even if the patient has given chemoradiation, if there is a residual disease and Durva is not available by any chance, continuing with the maintenance pemetrexed is also an option. You can continue with the maintenance pemetrexed.
Substitution.
Yeah, that can be done.
I don't think there is the data for adjuvant consolidation pembrolizumab after concomitant chemoradiation. That's what I know.
So as of now, we don't have that.
The specific replacement for pembro, I don't think there is any data.
Right. Okay, so just the systemic treatment was continued, and this is a 9 September versus 13 November scan, and yeah, there was further response.
Rajesh bhai is moving around.
Yeah. So I just sorry, I would just wrap it up. Our time is up. So it was continued, and further reduction was seen. There was a partial response, but the problem was just 2 minutes. Just post 2 cycles, he developed pneumonitis. This patient, and it was a grade 3 pneumonitis, and patient had to be admitted to ICU for about a couple of days. Luckily, he responded well to steroids, and he came out of that, shifted to ward, and about a week he was at home. So that was the thing which we had faced. So it was a grade 3 pneumonitis, and now the problem is, what should we do next? As a patient has faced a grade 3 pneumonitis, whether should we, re-challenge it? We just don't do anything. We just keep on follow-up. So just last comments, and I think we will wrap it up.
It is resolved to grade 1, less than grade 1. Then
Right.
Go ahead and re-challenge with the closer observation.
Closer observation. So one important point which I just came to know while reading is that if an objective response, complete or partial, to immune checkpoint inhibitor has been achieved, the resumption of immunotherapy may not be necessary. The risk of toxicity may outweigh the benefits. But again, this needs to be discussed in the tumor board, whether you want to take the risk of re-challenging that or you just want to observe it. So that is one more thing. So with that, what happens to this patient next? I think all are invited in our thoracic oncology update. That's in Ahmedabad, 18-19 January. We would love to have all of you over there. And once again, thanks a lot, all the esteemed panelists. Thanks a lot, organizers, for giving me this wonderful opportunity. Greetings from our institute, and thank you.
Thank you very much, Dr. Kshitij. And just to share with you that this meeting is broadcasted live, and we have about 280 delegates logged in since morning. And it is not just in India, but outside India also, around 15 countries. So since morning, because of maintaining the time, I have not addressed that. There are some questions also which have come. 3 questions I have handed over to respective faculty, which we will take up after this next panel and the talk. So this announcement is for the welcoming the online audience. Now I will request Dr. Dhar sir to give take-home message for this session.
Good afternoon, everybody. At the outset, I am thankful to the organizing committee to have given me opportunity for such a wonderful academic feast. My job is to give you take-home message, and I feel very excited that in the present era that we have got so many options for the treatment of lung cancer, as we have seen in this discussion, which the panelist and the moderator have done the wonderful job. So we have got systemic therapy, we have got immunotherapy, we have got targeted therapy, we have got radiation therapy, and so all kinds of facilities for treatment are available. But if I am given the opportunity to choose and decide to treat a patient of metastatic lung cancer, my endeavor will be to choose the initiation of chemotherapy after doing the biomarker studies, the driver mutations, the presence or absence of driver mutations. Second is to decide the subsequent therapy, which was also discussed here. Thirdly, we should come to know that in systemic diseases, we should formulate some systemic specific strategies, particularly when the patient gets brain metastasis. And finally, we should devise some protocol for those patients who have got uncommon EGFR mutations. Thank you very much.
Thank you very much, sir. I would like to invite Dr. Rajan Toprani, sir, for the head and neck session. Sir is President of Indian Society of Oncology and Director, SCG Cancer Center, and other panelists, Dr. Kshitiz Domadia, Dr. Saurabh Arora, Dr. Neeraj Jain, Amritsar, Dr. Samir Khatri is joining us in few minutes, Dr. Pramod Kumar Gupta from Lucknow, Dr. Sunny Jandial, and Dr. Samir Matham.
So thank you. So we have not met each other, most of us. I know them, but I don't know your name and your specialty. You're a radiation oncologist. Right. So yeah. Okay. So may I know the composition of the audience? How many are surgeons? One. Samir? Two. You forgot who you are. And any radiation oncologists? Okay. And medical oncologists? So quite a few of medical oncologists. Okay. So let me... Yeah, Arvind, you can join. Come. This is not moving. Slides. This one? Okay, paste. So I have selected couple of publications which were from India and which really applied to our practice in India, and thought of discussing about how do you apply this in your practice, in day-to-day practice. So the first publication that I chose was from TMS, the long-term outcomes of the NSCT on borderline resectable oral cavity cancers. And this was a data of more than 3,000 patients. And as we all know, oral cancers are so common in India. The challenges that we face is that 70% of them are locally advanced in our practice, and it induces a huge economic burden on our healthcare system. The standard management is surgery followed by adjuvant radiation or adjuvant radiochemotherapy. However, resectability remains a challenge, and that's a very subjective thing that as we will discuss further. The objective was to evaluate the long-term outcomes in borderline resectable oral cavity squamous cell cancers, and analyze the impact of the 2-drug versus the 3-drug, that is the TP versus the TPF, and assess the overall survival, resectability, toxicity, and pathological complete response, and the feasibility of this treatment in the Indian scenario. So the overall response that they found in this study was almost up 32%, upwards of 32%. And obviously there was a better response with a 3-drug regime, and surgical resectability was achieved in 32%. However, there is one caveat in this, that some of the patients who were given NSCT were termed as borderline. They did not have good response, still they were subjected to a resection. So we don't know how that has happened, but it still is a fact. And the long-term outcomes of this study was the overall survival, where patients were have undergone surgery, was 21% compared to 4% patients who did not undergo surgery. And the 3-drug overall survival was better than the 2-drug, and the survival of patients who had a pathological complete response was 45% versus 13%. So my discussion to this esteemed panel, I would start with the surgeons, Saurabh and Arvind. So how do you define borderline resectable oral cavity squamous cell cancer? So obviously the patient comes to the surgeon most of the times as a first visit. So when you see these patients, how do you define?
So borderline resectability.
Is there anything like borderline resectability?
Nothing. It is not like, it is a term which has been devised somehow. So there is nothing called borderline resectable. It is resectable or irresectable. We have to see if the resection will have any chance of cure. That's the more important thing rather than it is resectable or not resectable. What is the overall prognosis of that patient?
What do you mean by that? Whether you are able to achieve negative margins?
Negative margin also is overall prognosis of the patient. You do not have to see that the tumor is resectable. What is the neck nodal status? It's all other things you have to see in the totality. What is the age of the patient? Your patient factors are also very important. Rather than only you have to see the resectability.
So it's a good point that you are bringing. The overall stage of the patient is more important than just focusing on the T stage of the patient. Arvind, you want to add anything more to this? Anybody of you can chip in. Let us make it an interactive session.
Two, three things is one, of course, definitely as Saurabh said, R0 resection is mandatory. The other thing is that you should be able to functionally rehabilitate this patient and cosmetically. So that's also a very important consideration. Having said that, of course, there is a difference between the NCCN. It says T4A, T4B. It seems to sort of have some clear-cut distinctions, but somehow we don't really sort of believe that that's the gospel truth. I believe in the later editions of TNM, possibly you will have some sort of. So I believe that there is some truth to what this borderline resectability is, and the group at Tata's, as the paper you had put, sir, that they have tried to define it in 4 different terms. Essentially, soft tissue edema reaching up to the hyoid, or a soft tissue edema reaching up to the zygoma or the hyoid, your base of tongue going into the vallecula, and are very high ITS.
So they have divided the subsides. For buccal cancer, it is edema up to the zygoma. For the tongue cancer, it is extension to the vallecula or to the hyoid bone, which they think that it is, or extensive skin infiltration and edema around it. So these are the patients where surgeons would hesitate. And if you understand the term resectability, it's a fine balance between giving a meaningful reconstruction to the patient and a meaningful life to the patient. At the same time, we should be able to achieve a negative margin. Otherwise, it's a dignified biopsy. But anyway, let us discuss about this thing. How many of you in your hospitals, in your cancer centers, in your MDTs, where your surgeon tells me that it's a borderline resectable, do you use this term borderline resectable in your practice? Can you raise your hands? How many surgeons in your teams tell that this is a borderline resectable? Samir, what happens at Apollo?
I think all those factors that you just talked about and enumerated, you have to keep in mind, and I think there's absolutely, and a decision has, remember, guidelines, we were talking about guidelines for most of this morning. Guidelines are not the be-all and end-all of everything.
Correct.
An individual physician decision still matters and can overrule a guideline.
So, to our surprise,
rather than saying borderline resectable, we tell the patient exactly what is the tumor board decide that it is going up to zygoma, going to. We define that thing rather than saying it is a borderline resectable.
So for the NCCN guidelines, all the T4B lesions, there is no option given as surgery followed by radiation. Their option is only non-surgical option. So that is where we as Indians, we found out a jugaad and we've called them as a borderline resectable, because we know in our heart these cancers will not do well. Whatever you do for them, whatever this T4B supranotch diseases, whatever you do for them, and there was a good Chinese study from Liao et al., where they proved that the infranotch diseases, which we see on everyday basis, even though they are defined as T4B, but they are still straightforward resectable and we can achieve good negative margins. So there is a difference between an infranotch disease and a supranotch disease. So it's a supranotch disease probably that we are discussing here, where the surgeon is not very comfortable. So at one extreme there is a school of thought from the south, from Amrita, they think that nothing is unresectable and they would resect everything and anything in the face, and they give a good reconstruction also. On the other hand, there is a team of doctors from TMH who has found out this borderline resectable, and probably many of us are also following the same thing in our clinical practice.
Actually, there is a difference in opinion in the Western world to here is mainly in the buccal mucosa rather than in the tongue.
Correct.
Because they see less and less.
They don't see much of. So this is an Indian problem, and
T4B.
Yeah.
Dr. Prani, I feel with immunotherapy having come into the preoperative setting now with neoadjuvant therapies, I think the term that one would possibly feel more fitting would be locally advanced.
Yeah, so I'm coming to that also later. So as Saurabh said, most of the patients where they are resectable, you would go for an upfront surgery followed by adjuvant treatment. Arvind, you would do the same thing, right? So when do you use chemotherapy upfront in your practice? You do use it occasionally, right?
Yeah, definitely for what we consider I also am a believer of this concept of borderline resectability. Of course, you'll have to individualize to a large extent. And also the other place where we have started using it is for mandibular preservation also, essentially. After, of course, you have phase 2 data, the phase 3 study is ongoing, but
You're talking about the Licitra paper, and then subsequently there was a Devendra's paper.
Yeah, I think with that data, we have started the extensive paramandibular disease with no obvious mandibular invasion. We have sort of given neoadjuvant chemotherapy, and we have also been able to save mandibles. So this is something that we are doing more recently, but by and large for the discussion of I sort of endorse the concept of borderline resectability to a large extent, although I do contend that there is a fair degree of subjectivity in the whole thing.
Yeah. So when you say this is a borderline resectable in your clinical practice, you do it after your clinical evaluation as well as your imaging.
Yeah, absolutely.
Right?
Absolutely.
And then there has to be a balance between achieving negative margin, the patient's expectation, and your satisfaction whether you will be able to provide a good reconstruction or not. So now once you have decided to give neoadjuvant chemotherapy, our medical oncology colleagues, what do you use in your practice? Kshitij.
So the standard regimen would be to use a 3-drug regimen consisting of taxane, platinum and 5-FU. The issue is if we are not able to give 3 drugs, for example, the patient's performance status is compromised, or if he or she is a cardiac compromised patient, now then we cannot give 5-FU, we cannot give cisplatin. Now that's the real unmet need to address what to do if you are not able to give 3 drugs of treatment. There are some ongoing investigator-initiated trials from Tata Group which they are trying 2 drugs, taxane, platinum, along with OMCT plus nivolumab or something like that.
So these are different scenarios where you can substitute these drugs as per as the requirement of the patient, as per as the performance status of the patient, age of the patient, comorbidities and so on and so forth. Any other medical oncologist in the audience who wants to chip in at this time and share their experience about what they do, how easy it is to use the 3-drug regime TPF in your practice?
May I?
Yeah, Saurabh, go ahead. Anybody can chip in. Please raise your hand.
50% patient they take when we give neoadjuvant with the 3-drug, 50%, almost 50% they are not able to take the 3-drug. They are not fit for that criteria. Sometimes we give weekly also. We give weekly also 2 drugs. So it's not the 3 drugs, 3 weekly, sometimes give weekly for 8 or 9, 10 cycles. So the total dose is given. And we are happy with that at present.
You use cetuximab also along with chemotherapy as a combination.
Right.
What is your experience?
Right, so we have given cetuximab along with taxane and platinum in many patients, especially those who are not fit for 5-FU. Especially those who are not fit for 5-FU. And the outcomes are really encouraging. And what we have seen is first cycle TPF given, on evaluation, clinical evaluation, the patient is not responded well. We shifted to cetuximab based combinations and we are getting very good responses, and the patient is getting some local treatment later on. So I think this molecule, why we are not using it, because of lack of data. we don't have data of cetuximab in a neoadjuvant setting. But having said that, a drug which works well in a metastatic setting can work well in a neoadjuvant setting as well. So in a locally advanced case, I think this can be used as an off-label regimen because we don't have data to prove that. However, this is an unmet need which needs to be addressed. Recently, we have published our data on TPE-based regimen. In 1.5 years, 70 cases of TP were published, and we have seen about 85% response rate, very manageable toxicity profile, very fewer hematological toxicities because there is no 5FU into it. And even we split the chemo part because any day patient is coming weekly for cetuximab. So we split docetaxel cisplatin as well. So we are not seeing many admissions because of toxicities which is very common with TPF based.
So as Saurabh and Arvind told in the beginning that you don't only look at the T stage, you look at the nodal status also. We are not taking into consideration metastatic disease. These are all non-metastatic disease patients. So any patients with bulky diseases, N2 or borderline resectable nodal disease or N2B or N3 disease, would you consider them for a curative option or would you treat them with an intent of palliation?
Actually, the NSCT, in our experience, doesn't work very well for the nodes.
Correct.
It works very well for the primary disease.
So I think this is an important point to be discussed with your patient and the family, that if you have a borderline resectable, a huge node, lower level nodes, I think that curative intent should not be pursued aggressively, and probably that patient might go for a palliation. So this combination of factors, the T4B with an N3 disease, they don't do very well whatever you do for them. So how do you assess this patient, Kshitij? Like we practice together, and I know we assess this patient clinically after each cycle before considering for a second or a third cycle. And maximum 3 cycles we would give for these patients. That's what our current practice is. Is there anything different from anybody else does?
We always give 3 cycles.
Yeah. And then at the end of the 3 cycles, we would do imaging again along with your clinical examinations. So the second question
How many
is...
does for the both MRI and CT scan, PET scan after 3 cycles, or only one modality of the investigation? That's my question.
What is the question?
Both MRI or PET scan, or only PET scan for the
No, we do a PET-MR fusion.
Yeah. So since this was a locally advanced disease to begin with, high chances of...
You are a medical
local
oncologist?
failure, it is important.
Right. So do you do anything different in your practice? The TPF?
So for a neoadjuvant, if the patient is fit, then TPF.
Okay. So now the question to the surgeons again. So what are your margins after your NSCT? If you have got a good response to chemotherapy, what will be your margins?
So I think initially this was considered to be a controversial thing. But at this point of time, and even in the mandibular preservation protocols, I think a lot of us would sort of, see the patient clinically as well as critically review our scans again post chemotherapy, and we would stick to the newer margins. So we don't really sort of, chase for the bigger margins. Of course, the margins would be somewhere in between.
There is no level 1 evidence, and I don't think there will be ever a level 1 evidence for this.
We don't have a level 1, but we would definitely not chase to the original margin.
Otherwise, the purpose...
something in between it will be of sorts. Like that's a practical. And even in the randomized controlled trial of Chowkar, the thing was that they stuck to the newer margins, and essentially a large bit of.
So that organ preservation was a different ball game. So we are talking about this reason why we are giving this neoadjuvant chemotherapy because of the T4B lesion, not for organ preservation. But here also I think we will stick to the newer margins.
So I take more margins than usual, where it can be taken because you have given chemotherapy for some purpose to decrease the margin at somewhere.
Yeah.
So at that point, like in infratemporal fossa or in the towards vallicula, I take lower margin because you can't take. Otherwise, you could have done surgery first time. The other sides, I take more margin.
Correct.
So what really happens is the edema comes down, and then your tumor gets better delineated at that particular point of time.
You are confident of getting a better margin.
And you know exactly where to
So now, if to my radiation colleagues, if the patient got a complete clinical response, would you be happy to give radiation along with concurrent chemotherapy or something?
So again, it say for example, if it is about tongue
radiation, the other two radiation.
Yeah, yeah. This patient was locally advanced.
I know, Samir, what you are doing, so I am not going to ask anything.
So this patient was locally advanced, borderline resectable, received 3 cycles of all likely TPF.
So now the patient has achieved a complete clinical response.
Still,
there is no evidence of disease clinically or on PET CT.
Still, I would like to give adjuvant radiotherapy.
Now, would you ask your surgeon to operate or would you give?
I am asking, I am believing it is after surgery.
Yeah, so you would ask your surgeon to go ahead with the resection.
Yes.
You won't give a chemoradiation
No, if
upfront.
it is resectable, then upfront he should go for surgery.
Surgery has better survival than radiotherapy alone.
So thank God the surgeons are still in some, we have some job to do.
If
So
there is a complete response, very difficult to operate that patient actually.
yeah, so that is the challenge for the surgeons, particularly if it's a tongue cancer. You know, buccal cancer, we know what to do exactly. In tongue cancer, sometimes we get lost, and that is a fact. So now, after this resection is done, what adjuvant treatment would you give for these patients? For the radiation and the medical oncologists, the latecomers can also chime in.
Important to remember is that if the patient has a locally advanced disease, that does not change the biology of the disease. So it is an aggressive disease. So after surgery, if required.
So you have given 3 cycles of TPF.
Yeah.
You have done
So
a major resection, and now the question of.
There is no role of as such adjuvant chemotherapy, but maybe the radiation and concurrent chemotherapy may be required. But important thing is.
But you will give concurrent chemotherapy?
Yes, yes, definitely. So important thing to remember is I have seen so many patients now, even after pathological CR, they have a very bad disease. So pathological CR in head and neck does not mean that biology has changed and it will be a good.
What will our radiation colleagues do?
So adjuvant radiation.
Only radiation or radiation with concurrent?
Adjuvant radiation plus chemotherapy.
All patients?
All patients except those who cannot tolerate adjuvant chemotherapy.
How can you predict that?
Depending on their performance status,
Problem with concurrent chemotherapy after neoadjuvant chemotherapy is that the tolerance is a big issue, especially the renal failure rates. They are higher. So we have to modify accordingly. At times we give carboplatin only or carboplatin 5-FU and avoid cisplatin as a concurrent.
Yeah, so this is what we actually face. Once the patient has, especially if he has received 3 cycles full dose cisplatin, it is practically difficult to give the full course of concurrent chemotherapy, 6 cycles. Practically it is very difficult. We usually have to recheck everything and evaluate the patient after 3 cycles, and beyond 4, it is, I would say, less than 30% of the patients would be given more than 4
Arvind, what
doses.
do you do at Chennai?
So again, 2 things. First is the evidence, what it is. Even in the tax 323, I think they gave only radiation therapy. So only radiation therapy is a reasonable option, but in real world, if we find disease, so we add carboplatin to radiation therapy, and this is what we do in a vast majority of our patients. But in some patients, as sir said, that if we feel that there are issues, definitely only radiation is also is a reasonable option.
In my practice, what we do in a multidisciplinary tumor board setting, we see the patient's preoperative disease stage, the stage of the nodes, the nodal status, and what was the response, and what is the final histopathology report. So if there is an N0 report, probably adding chemotherapy with radiation in an adjuvant setting would be too much for that patient. But at the same time, if patient still has multiple nodes, probably would get along with, maybe we might not give cisplatinum, we might give carboplatinum instead of cisplatinum. That is what, but we don't know the real answer. But one of the trial at TMH, they have recommended to give adjuvant concurrent chemotherapy in all such patients who have received. Those patients only do well if they have received concurrent chemotherapy, correct? That was the recommendation. So it's a difficult scene to practice in the real world. So what about the future NSCD, what Samir was talking in the beginning to the medical oncology colleagues? What do you think the future NSCD, would that be a role in including immunotherapy?
So I think recently pembrolizumab in neoadjuvant head and neck cancer had got a positive readout. And I think over a period of time, definitely the role of immunotherapy in a neoadjuvant setting would definitely come up in a big way.
So would it be in a combination with chemotherapy or?
So in this trial it was 2 cycles of pembro followed by surgery, but I think still chemo-immuno followed by surgery would be a better option because that will increase the response rates.
Yeah. So I think what we can conclude from this is that NSCLC does improve resectability and the overall survival. This was the first study which showed improved in overall survival in the borderline resectable cases. So that is very important take-home message for us. And 3 drugs are obviously superior than 2 drugs. And the predictors of overall survival is what NSCLC regimen we use, what was the response to this chemotherapy, and if patient could undergo a surgical resection. So this was another paper that I thought we should discuss again from TMH, a real scenario that we face every day. And this was the OCAT study for the intensification of adjuvant treatment for oral cancer post-surgery. And the background was that even whatever we do for these patients, the overall survival has not improved too much. And this investigated the benefits of adjuvant radiation intensification. And there were 3 arms. The conventional radiation, weekly, arm B was radiation with weekly cisplatinum, and arm C was accelerated radiation, that is a 6 days week radiation. And the toxicity and the compliance were almost same. And surprisingly, the primary outcomes were absolutely similar in all the 3 arms. However, on post-hoc analysis, this was very significant. There was a combination, if you take the combination of the risk factors T3, T4, N2, N3 disease and the extra capsular extension, the loco-regional control for 10 years in arm B and C was significantly better than the arm A. So an acceleration in the intensification in the adjuvant treatment did help in this combination of adverse factors. Similarly, the DFS improved and the overall survival also improved. So what message do you get from this study for the medical and the radiation oncologists? How would you discuss in your tumor board, Samir? So like for example, we know that extracapsular extension and positive margins are strong indicators for giving adjuvant chemotherapy along with radiation. Does it really apply in all oral cancer patients that you see in your practice?
What we are doing is extracapsular extension and margin whenever they are positive. We are advocating and giving the concurrent chemotherapy to all of them.
So what works in other head and neck subsites may not work the similar way in the oral cavity subsites. So that is what the message that we are getting from here. What about the radiation colleagues? What is your practice like? Do you think that you blindly give, for example, positive margins and extracapsular extension? For example, at 1B there is a 2 centimeter node with 2 millimeter extension, extracapsular extension. Would you add chemotherapy to that patient along with radiation?
Yes, we will add, depending on the performance status and other comorbidities. If the patient cannot, if we think the patient cannot tolerate, we can omit also in this.
Yeah, so we do discuss in our practice, and only if it's a T1, T2 with a single node positive with an extracapsular extension, probably that is a patient we won't add chemotherapy in our practice, even though that's a recommendation by the NCCN. So this paper almost says the same thing, that you need to see a combination of risk factors for oral cavity, whether it's an advanced T stage, whether the patient has got multiple nodes, size of the nodes, what was the extent and the grade of the extracapsular extension. So that might help you to take a decision about adding chemotherapy. Yes, Saurabh.
So 2 points. One is minor EC is still is not a thing where you omit chemotherapy. Still the chemotherapy is standard of care, even if it is a minor EC. Only the classification you have to add that it is a minor or major EC. In our 40 patients which we have seen, there was around 20 patients with major and minor EC. There was no difference in
so even if it's an early T stage, single node positive with a minor extension of extracapsular extension, you would add chemotherapy?
We at present we do that. And the second thing, I think the study was negative, the Dr. Sabani's study was negative for the accelerated intensified radiotherapy. The subset of patient you are talking about, it was not powered for that subset of patient. That was a side comment.
Correct, correct. So that is point well taken. Arvind?
Yeah, I think I agree with Saurabh to a large extent, essentially. You know, I think it is important that our pathologists report the minor E&E and major E&E. A lot of evolving studies suggest that you could possibly omit your chemotherapy in the minor E&E subset. But I guess, you know, the T1, T2 with minor E&E is a subset that we will definitely discuss in the MDT. And a lot of us seem to be in the trend of, you know, giving chemotherapy for some of these patients. Because right now the therapeutic implications of a minor E&E to omit is not that robust.
Yes.
So we are until we await the data, maybe my feeling is we may be overtreating maybe this small cohort of patients.
So
then I guess it's.
So I mean there are a lot of grey areas still, and we don't know, particularly for young patients with T1, T2 and single node positive with a minor extracapsular extension. I am hesitant to give because I've been practicing for last 30 years. I have seen the long-term sequelae of radiation and chemoradiation, and it's miserable to see these patients living with this morbidity lifelong. So we must balance somewhere by whether to add chemotherapy or whether to omit chemotherapy. I think we don't have time, and
I think we should throw some light on targeted therapy in the concomitant setting. How does
any comments from Samir and Kshitij?
So target first immunotherapy role, it is evolving, but still there is no benefit of immunotherapy for concurrent. Biomap, nivolumab, I have used, but not very convincing. As
You used as in what setting?
Concurrent.
Okay.
Not for not with the chemotherapy or target neoadjuvant or.
Sometimes we have substituted cetuximab where patient has been treated with TPF.
I was coming.
NSCLC.
Cetuximab, I have much more experience, but never in a neoadjuvant setting or.
I'm talking about concomitant setting, and there is enough data there.
Yeah.
In fact, the toxicity may be lesser, and I think you need to give these options to your patient.
Definitely.
Because they have a cost.
I think there is data is there. Cetuximab is inferior to the cisplatin.
With cisplatin it was
it is inferior to cisplatin.
Nemo plus cisplatin, especially in the oropharyngeal cancers.
So we are talking about a subset of patients where you have treated with 3 full doses of TPF as NSCT, and then you want to add cetuximab to radiation for treatment intensification. So we don't know the real answer, but you want to add anything more?
Again, the toxicities are there. We should not think we are giving targeted therapy, so there will not be any toxicity.
Of course, yeah.
So toxicities are there. I have seen so many of hypomagnesemia and patient having lot of arrhythmias and all due to hypomagnesemia and lot of trouble also. So always monitor magnesium.
But patients do tolerate this cetuximab with radiation, and they do complete the radiation. That is also why I have seen
even carboplatin also they tolerate it fairly well.
Yeah, so I think once you have given full dose of cisplatinum, it is difficult to give another 4 or 6 cycles in a concurrent setting.
TPF full doses, how many of us are giving for full 3 days or 5 days? 1000 milligram for so many days.
Kshitij?
No, never full dose. The ones which is there in the guidelines, because we can't give it because of the toxicity constraints. It is always a modified version of TPF.
I think we had 2 more cases, but I don't think we can finish this today. So maybe Dr. JD can give his concluding remarks. Expert.
Thank you.
Yeah.
So Toprani said 30 years. I am 3 years senior to him. Cancer teaches us, you know. When I was young, I was very aggressive. I used to do an extensive resection. Then gradually, with experience, I started realizing what the hell I am doing. And the science grows every time. So lesson learned from this discussion is that first staging is most important. That is foundation on which we create a huge building of life. Secondly, what they talk about is borderline. When my brain says, I can do it, but my heart says, don't do. Now that is my gut feeling that this is going to fail. So that is for me a definition of borderline. Most important thing is, as a surgeon, we do 3D resection every time. For me, margins are always margins. Even after neoadjuvant chemotherapy, my margins are little liberal, you know, because I know cancer doesn't give us a chance of second time. And in head and neck, first is the best and probably the last chance. So I'll be very aggressive that way. And there is a definite role of frozen section. Whenever you have a doubt, unfortunately surgeons feel that I'll be sending a margin, which I feel that has to be negative. But I would always take a margin which I feel is always positive, you know. That is how I would do as a radical surgeon. I think there is a definite role of putting a tattoo margins, you know. So I would put a small color, a tattoo with a hot needle. So that would always guide me for a good margin on the table. Because all of us are not fortunate to have a lot of frozen section. Each frozen would cost you $2,000. And at the end of the day, they would say we would report at the paraffin blocks. I think CT and RT, if it is possible, always preferred an adjuvant setup. But because of the comorbid condition or because of the finances in India, we might avoid giving CT. But as an adjuvant, those who are having aggressive disease has to be given CT-RT as an adjuvant setup. Toprani was saying that extranodal spread 1 millimeter. I think it is bookish. I would always give adjuvant treatment. For us, it is a book and trial. For patient, it is life and death. So for me, extranodal spread becomes an indication for aggressive treatment, and there is no compromise. And what I have learned in 40 years is that selfishly we use statistic, you know, to say that it is good or bad. But in patient's perspective, I think I would prefer to treat little over than under. Thank you very much.
From head and neck, I thank all the esteemed faculty members for the head and neck session. And from head and neck, we switch gears to CAR-T cell therapy. And I would like to invite Dr. Nirali Chandan. She will speak on adoption of NextCAR-19 in real world.
Good afternoon, everyone. I see that we are already running short of time. So I will quickly walk you through the real-world experience of NextCAR-19. First of all, I thank you, Mice Ideas and Dr. Suman Gupta for providing me a platform where I can share the real-world experience of actellicaptagene autoleucel, which is an anti-CD19 CAR-T cell therapy that has been approved in October 2023 for relapsed and refractory cases of B-cell ALL and B-cell NHLs in patients above 15 years of age. So the trial data is already published in ASH last year, and the one-year follow-up will be published in Lancet soon. What I am going to do here is share with you our experience in the commercial settings, that is since October 2023 up until today. So far, 220 patients have been leukapheresed and more than 180 patients have been infused. This is as of date today. The data I'm presenting is of a data cutoff of 31st October 2024. So as you can see, that a total of 193 patients were leukapheresed, of which 35 were yet to be infused on 31st October. There were a few deaths before infusion that could have been because of progression of disease or because of cytotoxicity to the salvage therapies that they had received. Of which 146 patients, so we come to the number of 146 that were infused, and of which 27 were yet to reach the day 28 cutoff for reassessment. So I am providing here you the data of 119 efficacy evaluable patients, of which roughly 50% are from the B-cell ALL cohort and 50% are from B-cell NHL cohort. The manufacturing success rate has been 99%. There have been only two confounding factors which gave rise to a manufacturing failure, namely one, more number of prior lines of therapy in the numbers of 6 or 7. because the more the number of prior lines of therapy, we do not get a naive T cell subset in order to produce the CAR T cells. And second is a unique confounding factor was these patients had prior exposure to bendamustine. So this has been our experience. The manufacturing time, average manufacturing time has been 15 days, although 19 days is the vein to vein time, 9 days for manufacturing and the subsequent 10 days for the QC release. And in patients in whom, as per clinician discretion, it was decided to give some bridging therapy, or in case the patient has an intercurrent infection, in which case the infusion could have been postponed. So which is why the median vein to vein time that you see here is 28 days. So this is a snapshot of how our B-cell ALL patients are doing. As you can see here, the response rate, this have been divided into day 28 response assessment, month 3 and month 6. As this is an ongoing real world data, so the N is different for all these 3 subsets. So out of the 59 patients who have crossed the day 28 reassessment, the CR rate is as high as 88%. This is CR rate including CR and CRI, and based on MRD by flow cytometry. Although it would be ideal to check the MRD with NGS, but practically MRD by flow cytometry is what is being followed in majority of the centers. So these are the responses to that. If I compare this with our trial data, in the trial, the CR rate at 1 month and then at 3 months was close to 73%. But as you can see here, that in the real world, our responses are way higher, 88 at 1 month, 81 and 80% at 3 and 6 months. This is because in the real world, we have already burnt our fingers with the experience in the trial. So there has been a better patient selection. Patients, CAR-T is being intervened at an earlier line of therapy. Particularly in leukemia, we have a good subset of patients in whom CAR-T was intervened at the time the patient was declared to be primary refractory, in the sense persistence MRD positive or overt blast positive after induction 1A and 1B of the BFM or UKLL protocol. So because of a better patient selection, we are able to see that our graphs or responses in the real world have been better than the trial. So this is a very promising percentage. At 6 months, 80% patients of leukemia are remaining in remission. Also important to know that these patients who have maintained remission at 6 months, very few of them, I would say the numbers would be less than 5%, who actually underwent a consolidatory allogenic stem cell transplant. Most of these patients were relapsed post-transplant as well. So the point being, since the co-stimulatory domain in actellicapta gene is 41BB, it is associated with a longer persistence. So whether or not the CAR-T cell therapy has to be followed up with an allogenic transplant is still an unanswered question. But in the real world, our experiences, majority of these patients are not followed up with a transplant. So this is the next is the B NHL cohort. In the trial setting, the 1 month response rate as well as 3 month response CR rate has been close to 50%. We are seeing a similar picture in the real world as well. The CR rate at 1 month for majority of our patients, that is 60, is 51%. The ones at 3 months and then 6 months are in the range of 60%. So there is again a small cohort in these patients who were partially responsive at day 28 or were progressive at day 28, and these were followed up with some form of therapy. A common practice is being low dose nivolumab or BTK inhibitors in order to overcome the CAR-T resistance. And although the data is not statistically analyzed yet, but there may be a chance that they may have played a role to convert the PRs into CR at the subsequent follow-up. Coming to deaths among both the cohorts, so the deaths in the first 28 days were attributed to either progression of disease or to the toxicity. However, the subsequent deaths beyond day 28 at 3 months and 6 months have been because of the progression of disease or the toxicity of salvage therapy which were given post-progression. Coming to the adverse effects, so the incidence of adverse effects in the real world are similar to that what we found in our trial settings. The most common being CRS. Majority, so around 70 to 80%, 70% of patients will experience CRS. The first fever spike was commonly seen at the end of first week. The incidences of CRS will more correlate with the disease burden as opposed to any other factor, most commonly being age. So CRS is also seen, CRS will correspond to the tumor burden at the time of infusion. So it would be advisable to decrease the tumor burden to as low as possible before the patient is being infused. So in the B NHL cohort, you can see that 68% had grade 1 or 2 CRS and only 10% had grade 3-4 CRS. Similar percentage seen in leukemia cohort as well, around 72%. So majority having only grade 1 and 2 CRS. IC-HLH was seen in up to 16% of patients in both the cohorts. Timely use of anakinra and close monitoring of ferritin levels have been associated with better response rate and tackling the IC-HLH. Hypogammaglobulinemia is being seen in around 50% of patients. This can be to the CAR-T cell therapy and the subsequent B cell aplasia, and it will also depend on the prior B cell directed therapy that the patient may have received. So patient may have baseline hypogammaglobulinemia as well. These patients will need supportive IVIG monthly for at least 6 to 8 months till the immunoglobulin levels are at least above 500 IgG levels. ICANS, so in the trial settings, active CNS disease patients were an exclusion criteria. However, in the real world, we did get a few patients with active residual CNS disease, and these would not have been fit for transplant. So the efficacy has been, there is international data that the efficacy is very well established with CD19 CAR in the CNS disease. Only thing is there is a possibility that the incidences of ICANS may raise. So in the trial settings, we did not see a single ICANS. However, in the commercial settings, we saw up to 5% of ICANS in both the cohorts, NHL and BALL. This is the abstract of the real world poster that was presented in ASH last month. The data cutoff year was 1st October, hence the percentages are different from what I just showed. So that would be it. So this is the first indigenous humanized CD19 CAR-T. So this data is very promising, and the kind of numbers that we have not been seen in other US FDA approved CAR-T so far. Especially the adverse effect profile is extremely acceptable as compared to the other US FDA products. Yeah, that would be. It should be due, sir, in the coming 2 months probably. Yes, sir. Okay, that's it. Thank you.
Thank you very much, Dr. Nirali, for accommodating our request and switching up the sessions. She has to rush for another meeting and another lecture today. We are very thankful to you. And now lunch is open. On the right side, this gate is used for the lunch. So, and from the same gate we come back. Within 30 minutes sharp, we will start the next session.
sir. Professor Arvind Krishnamurthy sir is the head of surgical oncology at Adyar Cancer Institute. Sir has been my teacher, and it's a great honor to have him. So today, few people has helped us, and the number of people who helped through this conference are innumerable, including everyone sitting in the hall. On this, I'd like to invite Dr. Ashish Tiwari to please come on the stage. And thank you, Dr. Ashish. I'll also like to call Dr. Pushpendra to please come on the stage. Hi. Sami sir, lunch. Aap lunch kar. Sweet. Okay, thank you, sir. Thank you, sir. So we'll be changing the theme of the event, and now we'll be going through hematology for one session. It will be on CAR-T cells and beyond in hematology. The moderator for the session will be none other than Dr. Kundan Mishra. Colonel Mishra is from Lucknow Command, and it is an honor to have him here as the moderator for the session. May I also invite the panelists? Sir, I'll take this honor of yours to invite the panelists. Dr. J.M. Khungar, sir. Sir, bahar honge, bula len. Dr. Pradeep Kumar, Dr. Farhan Naeem, Dr. Garima Nirmal, Dr. Riaz could not make as he is not well today. So over to Dr. Mishra, sir. The other two panelists are coming from outside. Sir, please. And Dr. Bakshi will be giving the take-home message. He'll also join on the panel. Siddharth, sorry. Dr. Siddharth Sood.
So, good afternoon, everybody. At the outset, I'd like to thank the organizers, especially Dr. Sumant Gupta sir, for inviting me here. It is because of him that I am here in front of all of you. So, in this hematology oncology sessions, we'll be talking a little bit about the CAR-T cell therapy. To begin with, overall oversight of the topic, it is like that. So it was all in around, say, 2010 or so, when a 5-year-old girl developed fever and generalized weakness, and the evolution in her showed features suggestive of or confirmatory of B-cell acute lymphoblastic leukemia. So in next 2 years, from 2010 to 2012, this 5-year-old girl underwent various kinds of chemotherapy, whatever options were available. And within 2 years, doctors had already exhausted all the treatment options available for a B-cell ALL in a pediatric age group. That was the time when she was taken to the Children's Hospital, Philadelphia, where she was. So that was the time when she was taken to the Children's Hospital, Philadelphia in USA, where she was enrolled into an ongoing clinical trial. And rest is the history. She underwent. Sir, please. Longer, sir, please. So rest is the history. Rest is the history. We all know this girl, ABC, whoever she is, who underwent this CAR-T cell therapy, the first pediatric patient in the world to undergo CAR-T cell therapy and getting cured out of the refractory B-cell ALL. And now it's more than a decade since she has been disease-free. So to begin on that positive note, this is Mr. Carl June. Mr. Carl June was working in that Children's Hospital, Philadelphia, from where this CAR-T cell therapy came into limelight. He has been the pioneer of CAR-T cell therapy in the world. And with his continued effort, finally FDA approved the CAR-T cell therapy in the year 2017 on 30th of August. It was approved for the B-cell ALL in individuals who were either refractory to the chemotherapy or had relapsed after completing their chemotherapy, and in those who were aged 25 years or less. Since this 2017 breakthrough, where the Kymra, by the generic name of, if I'm right, TISA, was the first one to be approved and license was handed over to Novartis Pharmaceuticals, there has been many others CAR-T cell therapy which has come into the market, especially in the United States. If I have to summarize the CAR-T cell process in a minute or two, it is a three-step process. Broadly, it is a three-step process. The first step is something like an autologous stem cell transplant. Means though these days there are the allogenic CAR-T also, but mostly we talk about autologous CAR-T cell. So like we do in an autologous transplant, we take the patient and we do the apheresis right on day one. Similarly, here also the process starts with apheresis. Here the emphasis is on collecting T cells of the individual. It is followed by taking that sample to the GMP, or today we have this point of care GMP called mostly these Clinimax Prodigy and all, Prodigy and all. So there we take those samples, and over the next 2 to 3 weeks time, there is what we call genetic manipulation or cell manipulation is being done. It takes about 3 weeks or so. Then the final CAR-T cell product is ready. Usually it is about volume is around 100 ml plus minus few ml. And it takes about an hour or so for transfusion into the recipients. The one who was donor now is the recipient. So the issue is that, and before we transfuse this CAR-T cell into the individual, the patient undergoes what usually in transplant we call conditioning. Here we usually call lymphodepletion. So a course of fludarabine and cyclophosphamide is given to the individuals, and then the patient is ready for the receiving CAR-T cell therapy, and finally patient receives CAR-T cell. There are a number of complications which follows the infusion of CAR-T cell therapy into the individual, short-term, long-terms, and overall the most important thing later on is what was the response to the therapy. So those things will follow. That is what we will be discussing today. So if we talk about the list of CAR-T cell which have been approved by the FDA in United States, at least 6 of them are there in my knowledge, and they are being used for various lymphomas, DLBCL, follicular, mantle cell. They are being used widely for B cell acute lymphoblastic leukemia, the ALL, and also coming up in a big way is CAR-T cells for multiple myeloma. Well, so almost a decade later, this is when these Indian lions started roaring, and in October 2023, the CDSCO, the Central Drug Controller Standard Organization or so in India, actually authorized or approved the first indigenous CAR-T cell therapy. So the first indigenous CAR-T is available for over a year now in India. It is called NextCAR19. We had a small talk about this today morning only around 11 o'clock, and we'll again be discussing with our panelists regarding this CAR-T product, the indigenous CAR-T cell product, during the course of our panel discussion. If we talk about the future, what are the futures in the field of CAR-T therapy? Are we blocked somewhere, or there's something new coming up? How are we going to progress and all? So in recently, the 64th annual meeting of American Society of Hematology, I noticed a few very notable presentations over there. Few abstracts I have picked up for all of you. I'll just like to dwell upon a few minutes on those abstracts. So the first one is this CAR-ACT CAR-2 trial. So it is something kind of tandem transplants, or I'll say tandem CAR-T with sandwiched autologous transplant. So what they are doing is that they are doing one CAR-T cell therapy, then they are going for the autologous transplant, then again second CAR-T cell therapy. So in India, where we are struggling for our first approved multiple myeloma CAR-T, even in worldwide, even in US and all, they're finding it difficult to run through multiple myeloma CAR-T. The response and all are not that very good. In China, people have already come out with this double CAR-T cell protocols. So here they are including, the inclusion criteria was not just relapsed refractory cases, but even newly diagnosed myeloma patient also. Those who were having TP53 mutations by sequencing, or they had deletion 17p by RT-PCR. So these patients were taken up into the trial, and initially those patients, they received 4 cycles of VRD, followed by autologous transplant, followed by 3 cycles of VR consolidation, followed by second CAR-T cell therapy. So this was how they went about it. They have included about 10 patients so far in this study when they presented the abstract. And out of the 7 patients who received CAR-1, they noticed that all of them responded, but not in CR and MRD negativity. But by the time they finished off, it's completed the 1 patient into the trial, so almost 3 patients completed the requisite time limit of the trial, and they noticed all 3 of them were not just in CR but also MRD negative. So this is a promising thing, very novel kind of things coming up from China. We will wait for more longer follow-up and maybe some more real-world experience from other countries as well. But this is something I thought worth discussing with all of you. The next one was this WT7. So in our practice, we noticed that ALL is a big issue, and particularly that subgroup of ALL, what TALL, there I think that options are also limited, and the disease course is also not that very good. And theoretically, autologous T cell, CAR T cell is very difficult to be prepared for any case of T cell ALL. So the option was of allogenic. So people finally came out with this allogenic CAR T for T cell ALL, and it has been named as WT7. It has been prepared, means 2 years back in 2021 only they had presented the theoretical issues, phase 1 and all, in ASH meeting, and this year EHA also they had presented the update of this meeting. So again in ASH they presented, and here in this, here this was a subgroup analysis, and the data of adolescent patients around 14 to 17 years of age was presented. And what they noticed that out of the 5 patients who received a median of 4 different lines of therapy, including 2 patients had undergone allogenic stem cell transplant and had relapsed after that, all of them responded to WT7, and out of 4, rather out of 5, 4 had responded with CR or CRI, and 1 had PR. And so that's a good thing, but finally all these patients, they have to undergo, as per the protocol, they have to undergo allogenic stem cell transplantation. Some of them will be undergoing second allogenic transplant, and some of them will be undergoing first stem cell transplant. So CAR T cell followed by allogenic stem cell transplant, that is what is in future for TALL at present. One more was regarding AML. AML is also another disease where we are struggling even after allogenic transplant. The high risk, particularly high risk subgroup of AML, we are hardly getting any response, or the response rate is very minimal. So this was one CAR T which was presented. It was presented last year only. So out of 10 patients they had included, only 2 had shown some kind of response. This year they presented the biomarkers and all. I just want to show that this was presented earlier also, and here the response was not that very promising, hardly 20%. The last one I like to discuss is this abstract where they presented a 30 patient cohort who had underlying autoimmune diseases, SLE, systemic sclerosis, or idiopathic inflammatory myositis. And all of them, as per the result, had shown good response. Means 29 out of 30 after 1 year of CAR T cell therapy without any kind of immunosuppressant showed no sign of disease. So that is also a very promising result. So I thought, let me discuss not just what we have, but what we don't have, where we are struggling, and what we are not thinking about. So CAR T is going to get a very, I'll say, wide clientele, and in the future, perhaps we'll have more and more patients undergoing CAR T cell therapy, not in the world, but even in our country. With that, I come back to today's panel discussion. So some of my eminent panelists are not available, but those who are available, they are all very eminent faculties who have joined us from different parts of the country or the zone. Dr. Bhau Sahab, I believe, is not here. Dr. Ketan Nathani, he is also not here. Dr. Khungar sir is here, very eminent pathologist. Sir has been a role model for many of us, has helped us quite a lot in diagnosing so many complicated cases. So Dr. Khungar sir, welcome. Dr. Harshit was not well, he rang up in the morning, he is not coming. Dr. Pradeep from All India Institute of Medical Science, New Delhi, the most eminent institutes of our country and one of the best hematologists at present era. He is here with us. Dr. Farhan is there, a very old friend and a very eminent hematologist who has worked abroad also. So Dr. Farhan is here with us. Dr. Prashant again couldn't come. Dr. Garima is here with us, a very active, I'll say, hemato-oncologist in the field of CAR T cell therapy. And then we have Dr. Siddharth. So I came to know about him little later, so couldn't include his name, but Dr. Siddharth has worked quite a lot in UK, if I am right. He has worked quite a lot in UK, and now he's with Metro Group of Hospitals. And we have Dr. Sameer sir. So thank you, sir. Thank you all of you for joining us. So to begin with, I'll like to invite, call upon Dr. Khungar sir. Sir, what do you think about CAR T cell therapy? What is your opinion?
I will tell you basically what are CAR T cells.
Absolutely.
The CAR T cells, it's a immunotherapy in which the T cells of the patient's own T cells, they are genetically engineered and they are modified for production of chimeric antigen receptors on their surface. The immunotherapy is also just like surgery, chemotherapy, radiotherapy. Immunotherapy is also fastly developing this tool, support system for fight against cancer.
Thank you, sir. That's what we as laymen understand about it. So I'll go to, I think none of our panelists is there. So
just I want to tell some
please, sir, please. Continue.
With the production of these CAR-T cells, these T cells, they can recognize now the cancer cell. They bind with the cancer cell and they kill the cancer cell. This is basic of the...
Thank you, sir. Thank you. Thank you for enlightening with that. So, Dr. Garima, do you think that in your practice you need CAR-T cell therapy? Is there an unmet need of hematological oncology patients of CAR-T cell therapy?
Sir, I'm a pediatric hemato-oncologist, so definitely in pediatric, relapsed B-ALL is the fourth most common pediatric malignancies and is the leading cause of mortality. We can salvage the patient till first relapse, but beyond that, it is very difficult to salvage the pediatric B-ALL patient just with chemotherapy because they are chemo refractory. Definitely blinatumomab, inotuzumab, they can push the patient for transplant, but beyond one point, CAR-T is the choice for the patients who relapsed post-transplant or who cannot tolerate the chemotherapy or who are chemo refractory. So definitely in pediatric B-ALL, CAR-T is going to play a major role in the relapsed settings.
So you said it is the fourth, the relapsed refractory B-ALL is the fourth commonest one in your practice. That's a very important thing to know. So Dr. Naeem, so what about other, you are an adult, mostly you deal with adult hemato-oncology things. So do you think that for lymphoma, myeloma, or in adult practice also it is required?
So, yes, when I was doing my training, I remember that those patients of DLB cell who were refractory, we just counseling them that nothing is much is there. Even if we give some salvage, it will work, but it will not cure the disease. Then came some immunotherapies, targeted therapies, where with the help of them, we can bring them in remission. We started doing the allogenic transplants in those cases. But even then, these outcomes were not good. So the one group which is the refractory, both the refractory DLBCLs, refractory follicular lymphoma, especially, we had no options for them. But now we have a good number of patients are there. As we are treating more patients, there are more patients they're coming for the treatments, more advanced treatments. So we have a good number of patients who require CAR-T cell therapy. And next comes the myeloma. Myeloma, we have a huge bulk of patients which actually requires a CAR-T cell therapy. We have the trial, we got a trial for this CAR-T cell and for myeloma, BCMA. So for 2 slots, we till now receive around 20 applications that patients are coming that we needed CAR-T. So we can, from this you can know that what is the load of requirement of the CAR-T for the myeloma.
Dr. Pradeep, you are at the most eminent institute of our country. So what is your opinion? How much is the need of CAR-T cell in our practice?
As a tertiary care center, we used to face so many relapse refractory, at least for opinion. So if we have options like CAR-T cells, then we should offer them. Not for lymphoma or leukemias, other autoimmune diseases. Right now, this group of patient also need further cares because at some point they also don't have also any other options.
Absolutely. So 3 of our eminent panelists who are practicing right now in India, they all agree that there is an unmet need in the field of hematological oncology malignancies, and we need CAR-T cell therapy if available for betterment or for the better treatment of our patients. So that's great. Coming to the next one, which malignancy is the most affected by the unavailability of CAR-T cell in your practice? And if you think that there is any specific reason. Dr. Garima, we talked just about ALL because he's mainly dealing with that. But Dr. Pradeep, what do you think? If it was there in your institute, because you deal maximum number of patients, which malignancy will benefit most?
Yes, as ma'am has says, we have fourth malignancy in pediatric populations. There is a bulk in adults. Lymphoma and myeloma is the commonest in comparison to other malignancies. So these are and others. We have a unmet CAR-T cells therapy.
Any other malignancy you remember which will be used?
CLL. So
Different.
If you ask the numbers, I think myeloma is the one where we actually need it. The numbers are huge in the multiple myeloma.
I agree with you because myeloma being one of out of all these 3 or many more, I think myeloma is one which has been conventionally considered incurable, and I still feel that not even 10% of the patients of myeloma are getting cured with whatever treatment we are giving. To cure, I mean to say treatment-free remission for about 5 years. So that kind of treatment response I am getting less than 10% of our patients in clinical practice, though up to monoclonal antibodies, up to daratumumab I have been using quite rampantly in my practice, and autologous transplant has definitely been there for years. And rest of the earlier things are there in our practice. Bispecific, trispecific are still to come, but up to monoclonal antibodies, I'll say that not even 10% of patients are getting cured. So of course there will be a huge number of patients of myeloma who will require CAR T cell therapy for cure or sometimes even control of the disease. So I agree with you. So what do you expect when you do the CAR T cell therapy? Do you think a cure, or do you think this is a bridge to allogeneic transplant, or what kind of expectation is there, particularly in B-cell ALL, Dr. Garima? I'm not specifically going to Dr. Siddharth sir because you know everything. You have practiced outside also. I'll come to you for the expert opinion again, and Dr. Samir sir also. That we'll discuss later on. So, Dr. Garima, please, what do you expect?
Post CAR-T with transplant, they have better survival as compared to the one which we don't consolidate with transplant. Like there's a recent Chinese paper which has shown that they have administered both CD19 and CD22 CAR-T cell together, and there was 1 year EFS was 73%. So probably like we have to learn more and more about the CAR-T, about the immunology to improve the outcomes. And in that trial also, they do transplant the patients who have poor cytogenetics, like MLL rearrangements, or and they also have shown that if you consolidate them with transplant, so the outcomes are better.
Thank you. So Dr. Farhan, you are already in, recruiting patients for multiple myeloma, this BCMA CAR-T. So how do you counsel this patient? What do you tell them regarding the prognosis post CAR-T?
So everyone, like BALL, I will say still that it's a bridge to transplant. Lymphoma, we are looking forward for the long-term data. We are looking for the achieving a cure with in the lymphoma CAR-T trials. And myeloma, we want to get a disease-free period, so progression-free survival. So this is what we are looking. In the myeloma, the time will come then where we'll be requiring more than one CAR-T cell in the future. So we counsel the patients to have a disease-free remissions. So what is the duration? We don't know, but still if we see the trials, the results, they are very encouraging. The overall response rates are reaching 80-90% in myeloma. So till now, we are not looking for curing. We are just looking for the progression-free survival.
Thank you, Dr. Farhan. So, Dr. Pradeep, sir, your opinion. What do you expect? If suppose tomorrow you get it is just a matter of time when you will start getting CAR-T at your center also. So what do you expect? If patient comes for the second opinion, third opinion to you, and you tell them that yes, perhaps you will require CAR-T cell therapy, then how do you counsel the prognosis part of it?
We know after relapse, like in BALL, if that is refractory, the outcome of or survival is very poor, less than 5%. And lymphoma, leukemia is also a refractory or beyond treatable. So these survival is not good. So at least we can say that this is right now the one options for achieving that curable aspect. We can cure or not, that is something after more mature data. But at least right now we have a CAR, so we can give you some good quality of life and a good quantity of life. That's
Absolutely. Yeah, so I remember in almost the similar forum, Dr. Prashant Mehta from Amrita Institute was presenting his data of a few patients who underwent CAR-T in India, and it was really encouraging. So I'll tell you a little bit of my experience. Last year I was at Stanford with Dr. Dahiya. He is one of the eminent hemato-oncologists and do lots of CAR-T cell therapy at Stanford. And I saw his data, what he was presenting, and I worked with him for a few days. What I noticed that out of perhaps all the three, if I am given an option, perhaps lymphoma is one I'll pick up. If I have to pick and choose, I'll pick up CAR-T cell for lymphoma. This is what I noticed. For BALL and myeloma, yes, when there is no option, CAR-T cell is very good and it has got a good response also. I was there with Dr. Maziel a few years back at Cleveland, and lots of people from all across the world, including Canada or even European countries, were coming to him for CAR-T cell therapy. And the long-term data over there also, and subsequently, also, like just now Dr. Pradeep has said, 80 to 90% you expect over there. So that this last ASH only, I was seeing the data from Glenmark. Glenmark was presenting data of tri-specific. They have come out with tri-specific in myeloma. And patients who had received on an average of 5 to 7 different lines of therapy and underwent even transplants, the response rate was close to around 86%. So 86% with the tri-specific medicine and around 80 to 90% with CAR-T cell therapy. So perhaps, yes, this is also an option, but we perhaps need more work towards myeloma and all, something like maybe tandem CAR-T, what Chinese people are talking. Coming to Dr. Siddharth sir, so what is your take? How do you counsel? Because now you will be recruiting Indian patients very shortly at your center. How will you counseling patients who are suffering from these diseases when you are counseling them to undergo CAR-T cell therapy?
It'll be very straightforward. So the expectations obviously are huge from the patient because they're going to be spending a substantial amount of money, first of all. So that plays a very important role. Even those who are covered with panels and etc. So but it does bear a huge cost. So having that outcome of a potential cure is definitely a lucrative way to tell them that this is important. And if I have to pick and choose out of these subsets, a relapsed refractory B-ALL, Philadelphia-like biology, these patients don't have options, especially in adult settings. Those who don't have an option for allo transplant, elderly, frail patients, they definitely do benefit from these therapies. Relapsed refractory lymphomas, like you mentioned, if you have to pick and choose. These kind of populations, they do need this, and there's a very straightforward way of prognosticating them. Expect toxicities, expect some progression-free survival, and expect some OS as well. But the long-term data obviously has to be.
So the next question is also to you only, sir, because you have handled so many cases of CAR-T. Tell us a little bit about these adverse effects. We are very afraid of these adverse effects whenever we think of recruiting a patient of CAR-T cell.
So like I said, my most of the experience with me lies from the UK, training, and we had 2 products approved there. One was Yescarta, the other was Tecartus, and they were murine CAR-Ts. And the Indian CAR is a humanized CAR. So there's a huge difference in the biology of both products. So naturally, murine, being more antigenic, has high rates of all these side effects, CRS, ICANS, and the hematological toxicities. And I fairly remember that in the consent, when we were told that we had to specifically mention that the ICU admission is high. You might be able to, might be sent to the ICU for a considerable time, and you might land up in a ventilator as well. And using 4 doses of Toci and having anakinra in the back of the hand was always mandatory. So in Indian scenario, what I have gathered, meeting all Dr. Prashant Mehta's talks and everybody else's, the CRS ICANS, they are relatively low, much less as compared to the westernized data. So if I had to worry about these toxicities in Indian scenario, of course, we don't have anakinra available in the, it's not licensed yet, but Toci is licensed. So CRS still can be a problem, even though the rates are about, the grade 4 or 5 are about 10%, but they still can pose a threat. So we need to have these things. ICANS is also in a lesser range. I think virtually in the trial there was about 1% ICANS.
Yeah, hardly any. That to grade 3, almost nil.
Yeah, so might not worry about that much. So yeah, definitely.
Thank you, sir. Thank you. Next, when it comes to the monitoring, I think perhaps monitoring is almost as we monitor after chemotherapy or transplant only. But anything specific, Siddharth sir, you would like to add anything specific which is different than what we are doing while we are monitoring patient post CAR-T cell? Long term, not I'm talking about initial, those ICANS, CRS we all know, and also the hematological toxicity. But anything long term is a little different than what we do usually in monitoring the patient. Like lymphoma patient, we will follow up them with say PET CT and all. Yeah, the leukemia patient will follow them up with bone marrow, basically, to look for the MRD. Though we cannot have those, I'll say, what we are very fond of, post-allogenic transplant chimerism and all. Yeah. That may not be available right now. But I think bone marrow and MRD.
The surrogate for this is a B-cell aplasia, which works, which actually tells us that the CAR-Ts are working. And some of the institutes are doing NGS-based MRD as well, which are much deeper in a sense of picking early relapsers.
True, sir, that fight flow versus NGS will keep on going on. Tell me a little bit more about that B cell aplasia. So how do you monitor exactly? You see the B cell subpopulation or
Yes, so
immunoglobulin?
we do a flow cytometry,
okay,
and we look for the CD19 basically. So we should not have a CD19 expression following a CAR-T. So when that when we see that this response is losing, that means the effect of the CAR-T is going away eventually.
Great, great. So, Mr. So what do you think? Where is the future after all the discussion? Where is the future of CAR-T?
So, I think there are two key points. The one key point that still stays is after giving CAR-T, do we transplant or we don't transplant? So that will be one question that will still need to be sorted out. And with time, we will know better. If at all, we are able to show with CAR over a period of time that transplant is not needed, then I foresee that in the future for the poor risk ALLs, please remember in ALL the treatment is very prolonged, 3 years, and it is not easy to go through a 3-year treatment. So my feeling is just as blinatumomab has now come in first line, I will not be surprised that 5 years hence here we would actually be discussing CAR-T cell as upfront therapy for very high risk BALL, something like the MLL, hypodiploids. And that may be a one-time, and because by 5 years I'm sure the CAR-T cell production will be much more. The type of CAR-T cells may have become much better. The requirement of transplants may have gone down, and it may well become the first line treatment in very high risk ALL. That's the future that I see 5 years from now.
Absolutely, sir. Perhaps you have nailed it. So that's it from today's panel discussion. I am grateful to each one of you, all of my panelists. Thank you very much for taking active participation. Thank you. Thank you very much. Any question from the audience? Please, sir.
Initially, they used to do allo transplants for myeloma, but with dismal results. Then came the auto transplants, and I still remember my friend Tim McElwain, and the Royal Marsden group, which came up with the auto transplants. Initially 200 per meter square, and then subsequently it went down to I think it's 100 or 120 per meter square. Then came Bart Barloghi with his tandem transplants. So a lot of people didn't follow tandem transplants. I don't know what the status of that for myeloma now is. Now the question, and then after this also there was about 5-10% patients who did not respond to auto transplants, and they were put up for a mini allo transplant. Correct me if I'm wrong,
Yes,
I'm an outdated guy, but then now the CAR-T cells. My question to you is, in this whole algorithm, for myeloma, where are we with auto transplants, where are we with allo transplants, and where are we with CAR-Ts?
Agree. So, sir, Mr. Bahar Barloghi, you talked about very interesting person. I met him last in 2017 in New York, Mount Sinai, and he was still with all those things. He has a concept of another thing, what you didn't talk about, was transplant boost, stem cell boost. So he was doing this stem cell boost also. He was keeping 25 million stem cells in the cryopreservation room. And in between, whenever there was any evidence of disease relapse and all, you are doing those stem cell boost or mini autologous transplant kind of things. So he's a very interesting person. Anyway, so coming back to your question, so the routine all over the world, what I have noticed, and in our practice also, we are going with the chemotherapy followed by autologous transplant. That is in general everywhere, almost across the line. Once there is an issue with the autologous transplant, post-autologous transplant, there is a relapse, disease is bad and things like that, then there are options of all, either allogenic transplant or CAR-T. Allogenic, in our practice, in our institution all, we have done a few allogenic transplants, and including, there is one doctor who is right now working with me only. We did allogenic transplant about 10 years back, and he's healthy, alive, doing very well. And he was that time around 35, now he's 45, and doing very well, and there are a few more. So allogenic transplant at times has also given good results, there's no doubt. But allogenic in general is not being talked about because the TRM is very high in allogenic, and the results overall has not, when it is being done at a longer level, everybody undergoes allogenic transplant, the TRM compromises with the results, long-term results of the allogenic transplant. CAR-T cell therapy has come up in a big way because the treatment-related mortality is not much. We can manage with all these ICANS, CRS and all, we can easily manage over here. The number of tocilizumab we use just for corona in India, I think people in Western country would not have used till now. So we have the remedy available with us, we have the facilities available with us, and we can easily handle all those adverse effects with the CAR-T. So CAR-T cell is coming in a big wave. The only issue, I was also talking, that the result we are expecting is around 80 to 90%. And that 80 to 90%, we have many other options also, and which may be slightly cheaper also. So perhaps that is why CAR-T cell is not that big thing right now in myeloma. While in lymphoma, when I see, in Stanford, they are using, most of the patients who are in second line. Means first line chemotherapy, the moment they see that chemo is not working very well for the lymphoma patient, they will not go for autologous allogenic, they will go for CAR-T cell. And the result was very nice. Means most of the patients, I'll say 95% CR kind of things after 1 to 2 years. So that way, myeloma, there are many options now, but none of them is actually perfect, to be very frank. This is what is my opinions. Samir, anything you would like to add?
No.
Thanks.
I think you have hit the point. So in lymphomas, one of the reasons is that lymphomas which are diffuse large B-cell lymphoma, refractory or relapsing very early, practically with autologous transplant, very, very rare people will get cured. So it's practically a very bad disease if it relapses early. Only those who relapse later.
I agree, sir. I agree. Thank you, sir. Thank you very much. Thanks again. Thanks to the wonderful audience. Photograph, sir, please.
Thank you, sir. I invite Dr. Sameer Bakshi, sir, to give In the meantime, Dr. Bakshi is joining us. I invite Dr. Sanjay Roy to speak on Zytorvi, pathbreaker in NPC. Yeah.
Sir, there is a take-home message of your team. Good afternoon, everyone. In my clinical practice, it has been a rare to see nasopharyngeal carcinomas, but yes, at high volume centers, they are more common. And there is a new introduction of this drug we'll be discussing. Next. Just how to. Yeah, nasopharyngeal carcinoma burden, if we see, is more common in Southeast Asian countries, and the 5 countries which have got highest age-adjusted incidence rate is China, Indonesia, Vietnam, India, and Malaysia, respectively. And in India, if you see, the new cases are around 6,519. And cumulative risk is 0.05. In terms of mortality, mortality, the cases are reported 4,780 and risk is 0.03. So 5-year prevalence is around roughly 17,000 cases per lakh of the population. Head and neck cancer is the leading form of cancer in India. However, nasopharyngeal carcinoma is a rare cancer with crude incidence of less than 1 per lakh. The highest age-adjusted rate for NPC were found in Northeast states with Kohima district in Nagaland having an incidence of 19.4 per lakh population. Apart from the northeastern region, cases of NPC have been reported in other parts of the country, including Andhra Pradesh, Karnataka, and Tamil Nadu. As we are aware, these are related with EBV virus infection. There are endemic areas also. In terms of current standard of care of recurrent metastatic nasopharyngeal carcinoma, the treatment option is gemcitabine and cisplatin based chemotherapy, which is category 1, and for new cases which are early disease or locally advanced, either induction based chemotherapy is given followed by concurrent CTRT, or definitive CTRT is given from the beginning. In induction regimen, there are 2 protocols approved, gemcitabine and cisplatin, and TPF based regimen. So GemCis became the standard of care in recurrent nasopharyngeal carcinoma following a phase 3 trial, GEM 2011-0714 study, which was a multicentric trial, and 362 patients were enrolled in that trial. The comparative arm was 5-FU cisplatin, which was more toxic as compared to gemcitabine and cisplatin based regimen, and there was a benefit in terms of PFS, as well as there was benefit in terms of overall survival. So currently this is the standard of care. There have been recent trials of immune checkpoint inhibitors in recurrent metastatic nasopharyngeal carcinomas. There are some success in terms of median progression-free survival related to pembrolizumab and nivolumab trials, though it has been reported here a failed trial. But there is a trial I will discuss related to this drug, toripalimab, which is a Chinese manufactured drug, and largest phase 3 trial in NPC patients in terms of recurrent and metastatic disease has been done with this trial, that is Jupiter 2 trial, and recently this has been approved by FDA also, and this drug has been introduced in India also. So it's a humanized IgG4 kappa monoclonal antibody. Toripalimab is indicated in adults for treatment of nasopharyngeal carcinoma. Toripalimab is administered as an IV infusion, 240 mg per 6 ml preparation is available, and it has shown a prolonged binding capacity as well as prolonged dissociation capacity also. Toripalimab blocks the PD-L1 and L2 interaction and binds to a different epitope as compared to Nivo and Pembro. So these are affinity and dissociation studies of toripalimab, and this shows that this drug has got higher affinity than other PD-1 inhibitors and slower dissociation than other drugs. First line trial data related to Jupiter 2 was published, which was a phase 3 trial, and key eligibility criteria was primary metastatic untreated group of patients of nasopharyngeal carcinoma, and after recurrence after curative therapy and treatment, they were treatment naive. There was measurable disease with ECOG performance of 0 and 1, and age group was 18 to 75 years. The risk stratification, there were 2 groups. One was GemCis standard of care, followed by placebo maintenance. Other group, toripalimab, was added to GemCis regimen for 6 cycles, and after that maintenance was continued. Total number of patients were 289, and primary endpoint was progression-free survival. Secondary were PFS as per investigator assessment, overall response rate, DOR, DCR, overall survival and PFS at 1 year and 2 years. So by demographic, there were comparable patients in both the groups as compared to age, gender, ECOG, PS status, disease status, whether recurrent or de novo metastatic disease, and PD-L1 status also, both groups were comparable. The final result of Jupiter 2 trial has shown that as per BIRC assessment, that there was a significant benefit in progression-free survival. In placebo group, it was 8.2 months, and in the trial group, it was 21.4 months in toripalimab group. And hazard ratio was 0.52, which was very significant. And there was 48% reduction in the risk of progression or death. In subgroup analysis, all the factors they favor as according to EBV level or PD-L1 expression, all as per histology also, there was a benefit favoring toripalimab group as compared to Gemcis group. And this was overall survival analysis at 1 year, 2 year and 3 years. So all were better in terms of toripalimab group as compared to Gemcis only group. So there was 37% reduction in the mortality risk, and median overall survival was not achieved at the point of reporting. The response rate was better. It was roughly around 79% in the Gemcis versus toripalimab group as compared to trial group. There were more CR rates seen in the toripalimab group. There were lesser number of deaths in the toripalimab group, and serious side effects were lesser. It was comparable to other IO therapy along with chemotherapies. So in the phase 3 Jupiter trial, the addition of toripalimab as first-line treatment for recurrent metastatic nasopharyngeal carcinoma demonstrated superior PFS as well as overall survival benefit. Trial met its primary endpoint. Both the trial arms had manageable safety profiles, so no new safety signals were reported. These findings support the use of toripalimab plus Gemcis as the new standard of care for this population. And in NCCN also recommendation is now category 1 status. There are other data of this study was done before this. Polaris 2 trial was done as a phase 2 trial, where after first line therapy in recurrent metastatic setting, toripalimab was given as a monotherapy, and there also it has shown benefit in terms of progression free survival. So I will not go in detail of Polaris trial. Thank you very much.
Any questions?
Just we have another option also in treating NPC, and recently this drug is available in India also.
So, Raj sir. Any questions, any expert comments? I think Sameer sir will be the right person to give us expert comments on head and neck nasopharyngeal.
Personally, I don't have any experience
on this. So not on the drug in general. How do you think the placement of the drug?
It's something new which has come out after such a long time. Worth trying. So let's hope, and next year batate hain tumhara.
So let's have the real world data. Thank you, Professor Sanjay Rai sir, for this. Next, can I invite Dr. Sushant Mittal, as he's just late by 3.5 hours, for his talk on redefining the management of NSCLC with atezolizumab.
I was told at 2:50 only.
Very problem. Mail padha.
Thank you, Dr. Sumant. I'll be talking about the role of immunotherapy and especially Tecentriq in first line NSCLC. Can I have the slides, please? Anyways, so we all know that we come across lung cancer patients who do not have any biomarker. And for those category of patients, we have this immunotherapy in various combination. PD-L1 more than 50, 1 to 49, less than 1. Anti-centering has been approved in majority of the indication. Along with these data, I'll be sharing my personal experience also in all the 3 indications in which it has been approved. The first and foremost being the study in which both squamous and non-squamous lung cancer patients were included, and characterization was done on the basis of PD-L1. Patients were started on chemotherapy, and also one category of patients who were given monotherapy. So PD-L1 more than 50 monotherapy Tecentriq has shown an overall survival benefit to the tune of from 13 months up to 20 months. So 7 months absolute benefit has been there. Okay. So IMPAR 110, as I was talking, squamous and non-squamous, atezo versus chemo, 1:1 randomization, and we can see that patients with TC3 have benefited with the immunotherapy. And this is the median overall survival benefit from 13 months to about 20 months. And patients have responded beautifully, and especially for the category of patients in which they are elderly, the relatives do not want the chemotherapy or the patient is not fit for chemotherapy, they have also benefited. I have used in the patient, in such category of patients, and they did well. The side effect profile, as we all know, it's a well-tolerated drug. It does not add to the pre-existing comorbidities of the patient, and TC3 is the most beneficial category of patients who respond to this. Many a times we come across patients who have done PD-L1 on different platforms. So this study shows that irrespective of the platform, SP142, 22C3 or SP263, irrespective of the platform, the patients have benefited with atezo monotherapy. So this study was done on the same block, same patients, and they were given atezo and they responded to the drug. So if patient has come with another PD-L1 on the another platform, to that patient also we can use the drug and give the benefit to the patient. Safety profile I have discussed. So for IM110, it's a promising first-line treatment option for patient with PD-L1 high NSCLC. It's a positive study which demonstrated statistically significant and meaningful OS, especially in TC3 population, and safety profile is well tolerated. Coming to IMPAR 150, it's a non-squamous NSCLC study in which patients were given atezo with paclitaxel followed by atezo maintenance, or 4-drug therapy, atezo, paclitaxel with bevacizumab, and they have synergistic benefit of adding chemo with immunotherapy with VEGF inhibitors. The important point to be noted in this is the patients who have EGFR mutation or ALK mutation who have progressed after the targeted therapy. These patients have limited options, but when given ABCP, the 4-drug regimen, they have responded with a meaningful overall survival of 14 months to 19 months. So again, about 20 months OS survival benefit is seen, especially in those category of patients. So in EGFR positive, the benefit is up to the month, up to 30 months. So the sequential The sequence of the for the drug for these patients can be done using first line anti-EGFR. If they have progressed, then ABCP. Also, I have in my clinical experience, I have used this combination in an elderly population, that too a lady who had brain mets. She was treated with brain mets and ABCP bevacizumab was added, and she for another 18 months she did well and had a good response to this line of management. Also in liver metastatic patients, we can use this regimen and it's well tolerated drug. The addition of 4 drugs does not affect the quality of life if the patient selection is done wisely. So IMPAR 150 met both its co-primary endpoint and its first and only phase 3 chemoimmunotherapy with anti-VEGF combination to demonstrate a statistically significant and clinically meaningful improvement in PFS OS in all comers first line non-squamous metastatic NSCLC. Coming to IMPAR 130 non-squamous NSCLC phase 3 study of carbo with nab-paclitaxel, that is steroid sparing regimen with or without atezo in first line NSCLC. Again, the patients were given atezo with carbo nab-paclitaxel followed by atezo maintenance versus chemotherapy alone. So these patients were also categorized and they did well with meaningful PFS benefit of absolute of 2.5 months and an overall survival benefit with hazard ratio of 0.79. So in subgroup analysis, if we see that these majority of patients benefited who routinely we see in our OPD and they responded well. So investigator assessed PFS and OS also benefited. So it's a well tolerated regimen, and with the advent of steroid sparing regimen, even patients who are diabetic or have glaucoma or whom which we cannot give steroids, these regimen can be used easily. So IMPAR 130 was a positive phase 3 study of atezo with first line NSCLC, providing an alternative to chemoimmunotherapy regimen for patients with chemo-naive NSCLC. Significant OS benefit was added because of atezo. It also demonstrated a PFS benefit with high overall response rate, especially in EGFR ALK positive NSCLC with liver mets, supporting the use of IMPAR 150 in these patients. So thank you so much for your patient hearing.
Thank you, Dr. Sushant, for such a nice talk. Next, we'll have Dr. Rajat Bajaj, sir. He'll be speaking on breaking frontiers in first-line metastatic NSCLC. thank you, Dr. Rajat, for a wonderful session. And it is always a pleasure listening to you. Now, for the next session, may I have on stage Dr. Vineet Talwar, sir. Sir needs no introduction, and today he'll be speaking on metastatic HCC. Sir, over to you. And thank you for coming, sir.
Thank you, Dr. Suman. And the topic which I am going to talk about is transforming patient outcomes and innovative therapies in advanced unresectable hepatocellular cancer. Next slide, please. Oh, I can do it from here. That's fine. So, liver cancer is the 7th most common cancer and the 4th most frequently caused cancer-related deaths. As you can see here, there is a global incidence of about 960,000 and there is a global mortality of about 758,000. So you can see that the mortality and the incidence are almost mirroring each other, and that is the reason why it is the 4th most frequent cause of cancer-related deaths globally. Also, unfortunately, most of the times it is seen that these patients come at a very late stage. Half of them are in either the advanced stages or the loco-regional stages. And again, since half of the people are in advanced stage, the survival, the 5-year survival rate is quite dismal, meaning thereby about 25% of patients are the ones who tend to do good in these cases. So as I was saying that the incidence is almost equal to the mortality in these patients. So this is the 8th most common for cancer-related deaths as far as the data is concerned. So wherever you have the incidence matching the mortality, this is not a very, very good cancer to have, and that shows that it has a very aggressive behavior as far as the patients are concerned. The causation and association of hepatocellular cancer, you have multiple mechanisms. You find that the tumor sheds the tumor-associated antigens, and these are the ones which are picked up by the APC or the antigen-presenting cells. And there are multiple mechanisms of immune escape where you can have an overexpression of CTLA4 and PD-L1, or you can have the inhibition of the antigen presentation, as you can see here. So the risk factors and pathogenesis, this is very, very important in the sense that you have viral etiologies, the hepatitis B, hepatitis C, then you have the alcohol or the substance abuse, and of course the one which is coming up in a very big way, that is NASH, or non-alcoholic fatty liver disease, so as to say. So initially it was thought that the viral etiologies are the ones which are the most important, but now NASH is the one which is coming up and getting more preponderance over the viral etiologies and the alcoholic liver disease also. And just to substantiate that, this is the study which has been published in Hepatology International, and it shows that most common etiology of HCC was NASH, followed by viral hepatitis, and followed by alcoholic liver disease. So this is a very, very silent, creepy illness which keeps on going on, and we find that India per se, obesity is now coming up like United States. So that is showing the evidence here, and in this Indian study you find maximum is NASH, which is causing the chronic liver disease. So switching gears now, how do you manage these patients with unresectable hepatocellular carcinoma? We have a lot of classifications, but at this point of time, the best classification and which is most user-friendly is the BCLC staging. And in this, we find that in the advanced stage, it is the systemic treatment, and the unfortunate expected survival is about 2 years in these patients. Initially, the treatment was only sorafenib, and that used to be the sheet anchor. For years and years and years, it used to be sorafenib, and all of us used to be very unhappy treating these patients because the side effects were very, very bad in these patients. But now we are spoiled for choices. We have TKIs, we have a better TKI, that is lenvatinib, and now we have immuno-oncology drugs, whether it is the PD-L1 inhibitors or it is the CTLA-4 inhibitors, either alone or in combination. So this was the trial which was initially basing sorafenib as the main treatment component in HCC, in which you found that the median overall survival was about 10 months. And this was pitted against lenvatinib, the REFLECT trial, in which was a non-inferiority trial. And we found that the median overall survival was a shade better, but the side effect profile was very much better. So, to sum it, the whole practice changed from sorafenib to lenvatinib, and which has been the case now. The treatment-related adverse events were almost similar. Suffice to say that in lenvatinib they were much less, the grade 3 events, as compared to sorafenib. Then came the immune checkpoint inhibitors and the anti-VEGF inhibitors, in which this was the key trial, that is the IMbrave 150 trial, in which there was a combination of atezolizumab and bevacizumab, that is IO plus VEGF, which was pitted against the current standard, which was sorafenib. And this was a 2:1 randomization, and the key endpoints were the overall survival, and the secondary endpoints were the quality of indices in this patient. And it was given till unacceptable toxicity or loss of clinical benefit. And you find that there was a sustained overall survival benefit over the current standard, which was sorafenib. And as you can see here, the overall survival, which was a dismal 10 months with sorafenib and about 11.5 months with lenvatinib, that jumped to about 19 months as far as the atezo-bev arm was concerned, and that made it the current standard of treatment as of now. It had its own share of side effects, and along with that, there was a subset analysis, or rather I'll say a post-hoc analysis, which showed that this fared a little better in patients who had viral etiology as compared to the non-viral etiology, as you can see here. So this is the viral etiology. HBV and HCV patients, they did better than the NASH group. So this was a thought here, but again, it was a post-hoc analysis or a subset analysis. This was not the primary endpoint of the study. It had its own share of side effects: hypertension, proteinuria, diarrheas. They were basically with the usage of VEGF inhibitors. And of course, the IO had its own similar side effects, but nothing was out of proportion in these patients. Now, the problem with the atezo-bev is that you can use it only in Child-Pugh A patients. That was the registration trial. So what happens when you have Child-Pugh B patients or a mix of these patients? Another thing is that when you have any bleeding in these patients, which can happen in patients of HCC where you have bleeding diathesis, or you have got grade 3 varices, or you've got ulcerations in those varices, then probably there are relative contraindications for VEGF. Then in that case, this is another trial, that is the dual checkpoint inhibition, which was a combination of a CTLA-4 and a PD-L1 inhibitor, which enhanced the synergistic anti-tumor activity. And here you can see the CTLA-4, it blocks the CTLA-4 receptors and allows T cell activation. And along with that, the durvalumab, it blocks the PD-L1 and it reverses the T cell exhaustion. So both of them are synergistic as far as the mechanism of action is concerned. And this was seen in the proof of concept. This was a phase 2 study, study 22, in which we had one arm which had a combination of both, and two other arms which were the CTLA-4 and the PD-L1 separate, that is durvalumab and the tremelimumab, which were separate. And this was seen in the first line hepatocellular carcinomas. It was a positive study, which you see that there was an improvement in the overall survival, and this was translated into a phase 3 study. This was the Himalaya trial. So here again the schema was the arm A was combination of both, arm B was the PD-L1 durvalumab, and arm C was sorafenib, that is the standard against which this was compared. The primary endpoint in this was the overall survival, and the secondary endpoints were again the progression-free survival and the quality of life and the toxicity profile of this combination. So this was initially a 1:1:1:1 randomization, but subsequently only 3 arms were taken forward in these patients. And again, I would like to see, if you see, it is Child-Pugh A patients only. So this was the STRIDE regimen, which has become very famous, and in which you give only 1 cycle of tremelimumab, and after that durvalumab is continued for the further courses. And these are the demographics and baselines, and you can see almost 40% of patients were non-viral, and 60% of the patients were having hepatitis B or hepatitis C. And there you can see the Child-Pugh A patients were 99% of patients, and and PD-L1 positivity was about in 40% of patients. And in this also the AFP more than 400 was about 40% in almost 35% in almost all the 3 arms. And they were well matched for the ECOG performance status. And they had a subsequent second-line anti-cancer therapies in about 35 to 40% of patients, amongst which most were the TKIs. So here you could see that it demonstrated a statistically significant improvement in the median overall survival, where you can see the OS was about 17 months against 13.8 months, which was with sorafenib. And there the question was again whether there is an improvement in the non-viral etiology as compared to the viral etiology. So the question which was posed in atezo-bev, where the immuno-oncology drugs work better in the viral etiology, that was thwarted here. Here you can see that the result is almost equivocal, whether you see the hepatitis B virus or we see the NASH. So still this question is not answered, whether the immuno-oncology drugs favor the viral etiology or not. And if you go for the tumor responses, you find that the overall response rate was about 20% in these patients, and median duration of response was more than 22 months. This was against sorafenib, which was about just 18 months. And it was well tolerated, and the side effects were in line with the immuno-oncology drugs in the other trials. There was nothing new which came out. Suffice to say that about 25% of patients had grade 3 adverse events. And the most common events were rash, pruritus, diarrhea. This could be eschewed to the immuno-oncology drugs, and also the hypothyroidism and fatigue, which can occur in patients who are given the IO drugs. There were treatment-related hepatic or hemorrhagic SMQ events. SMQ is the standardized med query events which are there, and that were almost equal when you compare the STRIDE regimen, that is 1 cycle of tremelimumab and durvalumab versus sorafenib. And this was incorporated in the NCCN guidelines, where you have level 1 evidence of giving the combination of IO plus IO, that is tremelimumab and durvalumab, along with the atezo-bev. So the patients who have bleeding or bleeding diathesis or grade 3 varices or ulcerations which have bleeding, these are the patients which can be subjected to combination of IO and IO. And patients also who are not in a very, very fit condition, they are the ones again they can benefit. So to conclude, HCC is one of the topmost cancers affecting the Indians, and I've shown you the Indian study in which the incidence is almost equal to mortality, so it is a very bad cancer to have. And immunotherapy combinations have shown better anti-tumor activity, Atezo-Bev was the new standard of care after lenvatinib and sorafenib, but STRIDE regimen also has shown an improved overall survival versus sorafenib. And this seems to occur amongst all the populations, whether it is viral, non-viral, alcoholic, and the discontinuation rates were also low. So it represents a potential new treatment option for patients with unresectable HCC. So I thank you for the patient hearing.
Any questions? Sir, please.
So instead of using one modality, using combination of modalities like SRS, radiofrequency ablation, and immunotherapy, in Emerald trial, I was a part of that, the results are much better. Though the trial intention was to make a locally advanced liver cancer operable, but the results seems to be better if we use combination of these things in a single go than using them individually.
Yeah, we were also part of the Emerald trial, and that basically dealt with the loco-regionally advanced cancers. What we are talking here is the metastatic. So here the issue was whether you should give TKIs only, whether you should give IO plus VEGF, or you should give IO plus IO. So finances is the biggest prognostic indicator. So if you don't have finances, you give TKIs. If you have finances and you are fit and you don't have any bleeding diathesis, then you give Atezo-Bev. If you have any one of those problems, then you give IO plus IO. Thank you.
Thank you, sir. Now, next, for the next panel discussion on GI cancers, can I call upon the moderator, Dr. Sumit Goyal, sir? Sir.
Good evening, everyone. Good afternoon, everyone. Still good afternoon. So, thank you, Dr. Sumant, for giving us this opportunity to interact. So, inviting my panelists. So, we will be just talking about the recent updates which has happened in GI cancer over the last year. Basically, it's a huge topic, and we won't be able to justice to this. So, probably we will be talking about upper GI cancers only. So my panelists, we have Dr. Darshit Shah, medical oncologist, Dr. Sameer Gupta, Dr. Kajal Shah, Dr. Amit Saklani, and Dr. Raghuram K. We have 2 surgical oncologists and the rest are medical oncologists. Okay, so we all know multimodality treatment is very important, be it any cancer. But it is important, very important in upper GI cancers. We know we have at our discretion so many different modalities now. So it is getting better for the patient, but it is like really sometimes we are in soup or dilemma what to do. So any one of you can answer. Why do you think multimodality is required in upper GI cancers? Just a general statement.
Yeah, definitely. Multimodality treatment required for diagnosis. We require radiologist for imaging. Then we need endoscopy like
Yes.
gastrophysician. Then after with oncopathologist for biopsy reports. And then for treatment we require oncosurgeon, radiation oncologist and
Yeah.
medical oncologist.
So agree that we need a robust multimodality board. The basic idea is to deliver the maximum benefit to the patient and at the same time to prevent ourselves from being like in a medical legal area, we need to be very safe nowadays. Again, this is an area where we need all the 3 modalities. So at times it is very difficult to take a concrete decision what we should be going and what should be doing and how to do it. because it will involve upper GI cancer, esophagus and esophagus gastric junctions. They will involve radiation, they will involve chemotherapy, and with that advent of or incorporation of immunotherapy in the recent protocols, so it is becoming very difficult to move forward. So basically the idea is to maximize treatment and the benefit. At the same time, we need to de-escalate whenever required. So we need to be very careful and choose our patients very wisely. Ultimately, it is the patient who will choose about quality of life and the preferences that we have. So we will be talking very briefly about Checkmate 577 and ESOPEC trial, which were presented this year at ASCO and ASMO respectively. So this is just a scenario to set you going. So 51-year-old male, fit, smoker, had progressive dysphagia, lost 15 kg in 3 months. So endoscopy showed ulceroproliferative growth at 30 centimeters from incisors. Scope was not negotiable. Biopsy was squamous cell, and PET scan showed localized disease. And there were some ill-defined fat planes with mediastinal pleura and ill-defined fat planes with descending thoracic aorta, which were less than 90 degree, likely mitotic. So your thoughts on this? So surgical team.
First, we have to ensure the nutrition route for the patient.
Very, very important and the pertinent point. So nutrition.
NG or a NJ, first of all, because stent placement makes surgery very difficult. So
okay, once the nutrition is taken care of, patient is able to eat, has dysphagia, but can take liquids.
Then after assessing the ECOG status of the patient,
PS1.
So then we have to think about chemoradiotherapy.
Chemoradiotherapy.
So I think, like ma'am mentioned, that generally we end up discussing such a case in a MDT, and generally these patients, they go for a chemoradiotherapy with that cross protocol with paclitaxel.
Okay.
And then assess after radiation, 6 weeks after radiation is completed.
So any other test that you would like to do at this point of time? It's a localized disease.
Maybe advice for bronchoscopy to know the airway infiltration.
Maybe?
Bronchoscopy.
Bronchoscopy was normal. So patient did not have that features. Basically to the medical oncologist, because the NCC and the guidelines say to incorporate molecular testing at the baseline. So are we doing it? Like not routinely. And suppose this was not squamous cell, suppose this was adenocarcinoma, then in such HER2 new in adjuvant setting? Localized you're still not doing, but we technically we can do HER2 new and MMR status in adenocarcinomas in localized cancer.
Generally we do in metastatic setting. In locally disease
Still we are not doing it because NCC has incorporated in treatment protocol the MMR status. If it is deficient, what to be done next? So how will you proceed? That we discussed nutritional status. We will look at how do we treat them. It depends. So the most important and the pertinent point which was already made is the nutritional status, which is very important in today's discussion. Because we know these patients, they are usually have dysphagia, they have lost weight, they are nutritionally compromised, and we are going to talk about either the cross protocol or the triplet regimes. So are these patients fit enough to receive the triplet? And in your practice, how many patients, how many such patients they require RILES-2 placement or some form of...
Since most of the patients present with dysphagia, we generally offer the patient that you should undergo, because even when you're starting the patient on radiation, they will develop some mucositis, and putting a RILES-2 becomes a challenge at that point. Generally, we push the patient.
So how many, like out of 100, roughly, just a rough
70-75%.
70-75% patient require RILES-2 placement.
So coming from a government setup, patients present more emaciated, more advanced disease. So definitely that number may be higher, not less.
Okay.
Yeah, sir, around 80% patient requires RILES-2 placement, and we counsel for initial placement only, sir.
Yeah, very true. A lot of patients are nutritionally challenged, and they require some of like RILES-2 or something to feed them, which is important in our treatment planning. I think that is the one most important factor. So how many of such patients, whosoever is diagnosed with esophageal cancers or esophagus gastric junction tumors, they go for multimodality? In your setup, always, no, or sometimes? It depends if it has come to the surgeon, we will operate, then we'll send or no.
Sir, we
In
usually
our
discuss.
institute, there is a big government yojana. So in government yojana, we do tumor ward discussion in every patient.
Sorry, ma'am.
In our institute, we do tumor board discussion for every patient, new patient.
Okay. So multimodality is done for all the patients. So there's a request for 2 more panelists to come up on the stage and please join us. Dr. Jeevan Ram Vishnoi and Dr. Munjal Pandey. So we know, as per the recent guidelines, the treatment for locally advanced esophageal cancer is basically the combined modality treatment. It has become the standard of care for non-metastatic, except for very early stage diseases. So I think all of us will agree combined modality is the way forward.
In a point that patients, because of poor ECOG or quite malnourished, certain percentage of our patients are not able to withstand neoadjuvant CRT.
Okay.
So it's just neoadjuvant chemo for them.
Okay. So that is a very important practical point. We do get to see we cannot treat each and every patient as per the guidelines. So sometimes we do have to deviate. We know we do get to see such patients who are not fit for, so we start with either weekly chemotherapy alone. But how many of us see, what is the percentage of such patients in practice?
I think around 10-15% definitely. We had a trial by our surgical colleague at AIMS. He was doing 2 NACT followed by CTRT and comparing to CTRT.
Okay.
It was a non-inferiority trial, and so based on that, in some of the patients, we are incorporating that also. So it gives us more confidence that, okay, you can do that.
Okay. Yeah, it depends upon the region what are the public perception and beliefs are, how the patients they perceive treatment as, and what are the infrastructure and the logistic that is available to them also makes a difference. So again, the treatment is changing. So the paradigm is changing depending upon 2 things. One is the location of the tumor and other is the histology. Suppose it was an adenocarcinoma, whether you will change your protocol to cross versus float?
Float, yes.
Float.
Definitely float.
So suppose it was squamous cell at G junction, which is unlikely to happen, but it has happened sometime, a lower esophageal end. So whether then your treatment will change?
Then cross.
There we'll use cross only. Even for adeno, if it is not G junction, it is
thoracic esophageal adenocarcinoma.
So there I'll use cross only, sir.
Cross.
Not float.
So any differences in opinion?
At our center also, so if it is be it like middle 1/3 or lower 1/3 esophagus, we will use cross protocol and we see a very good number of pathological complete response.
That is true. That is why that was the standard of care, but we are moving forward. So if we look at the NCCN guidelines, so there again the same thing. So both the options are there. Either we can give preoperative chemoradiation or definitive chemoradiation as far as the squamous cell histology is concerned.
We prefer float.
Yeah. So if we look at the adenocarcinomas, so there we have the perioperative chemotherapy option also there. And again, MMR, so here they are trying to incorporate the MMR status. Whether we need to treat them differently will depend upon the data that we will get in the coming times. So if we'll keep this to the squamous cell at this point of time. So we all agree, preoperative chemoradiation versus definitive chemoradiation, either 2 are the options. So again, so we have these studies, basically cross study was there, which was published way back in 2012. Then we had New Age's Top Gear ISOPEC. Of these 2 were positive, 2 were negative. So roughly how many patients in practice go for definitive CTRT or chemoradiation followed by surgery?
At our center, like cervical and upper 1/3 esophageal cancer will go for definitive chemoradiation, but remaining almost all patients, they will be for like preoperative chemoradiation followed by surgery.
So we are talking about thoracic and G junction only.
Okay, so in that case, only if it is like unresectable, there is like a loss of plane or infiltrate into the aorta, carina or bronchus, then we'll go for.
So majority agree that, yes Darshit.
So sir, definitely like cervical there is no option of surgery.
Yes.
In thoracic I would say around 70-75% patient will be giving with NSCLC. followed by surgery. But when the disease is locally advanced, then we have to approach by radical CT-RT, sir.
So we all agree that the trend is the majority at this point of time will go towards surgery, which is the practice, and we don't say that we will deny you the surgery. And because, why this question? Because it is important at the baseline, when we discuss with the patient, when we tell them, they feel once the chemoradiation is done, the treatment is over, they go back home and they miss on the opportunity to take the further treatment. So at this point of time, we need to ensure the initial stages that even if you achieve CR, the surgery is required. So that is the important point we should tell.
The point is to assess CR is quite difficult because just
Correct.
the mucosal biopsies don't give you the complete picture.
Very true. So that is a difficult scenario, but we take clinical, radiological, and all the parameters into consideration.
And I think reason might be that because nowadays, because of minimally invasive, at least thoracic part, so morbidity and mortality of esophageal cancer surgery has reduced dramatically. So that's why nowadays esophageal surgery, even we are doing in the very elderly patients, so safely.
Okay. So this patient was taken up. Yes, sir. Please, sir.
Isn't this bit changing now in terms of the data that is coming out?
Yes, sir.
Rather than subjecting them for chemoradiation, what about what would be the role of the things like targeted or immunotherapy along with chemotherapy?
Yes, sir has asked a very good and important pertinent point here. So in the era of advent and precision medicine, so is there a role for these therapies targeted or?
Yes, sir. So when the patient have undergone surgery, when the patient is
that will come to now pre-operative.
Pre-operative, I mean.
With this case that you
even we don't have very conclusive data for targeted if you are asking about HER2 and all. We still don't have enough data to extrapolate the data of rectal cancer MSI high patients to esophagus yet, but yes, it might come up in future, particularly for very small subset of patients who are MSI high.
Sir, one more thing, we do use cetuximab, sir, when patient is ineligible for chemotherapy. Sometimes, sir, we have used cetuximab with RT.
That is extrapolation, basically. At this point of time, the data is not there, but the trials are going on. Definitely in recent era, we are likely to see such patients, such treatment
Like
options.
we had for lung, initially the data for adjuvant atezo came, then just pre-operative came, then now we have a peri-operative. So I have a feeling that probably in 2-3 years time, it will be a peri-operative immuno.
So that is the whole idea, because the NCC and the guidelines, they have started incorporating biomarker testing at the baseline, probably to incorporate and modify treatment in the coming years.
Encouraging results of checkmate 577 nivolumab.
Yes,
even without the biomarkers being assessed, there is data now coming in, and after what the gentleman just talked about, the RAMI, robotic assisted minimally invasive esophagectomy, or the combined method from top and bottom, I think it is going almost, we are there where neoadjuvant chemo, immuno or chemo targeted therapy, reassessment at the end of 3 cycles, and then going for definitive chemoradiation.
Yes, that is the discussion, sir.
And a maintenance therapy there.
Correct, sir. That's what we are discussing, sir. So the patient was taken up for chemoradiation, completed cross protocol. There was partial response. What next? I agree. Everyone agreed that surgery. Majority, 70% of the patients, they said they were able to. So this was the data which came from the Dutch protocol, which was the cross phase. So this basically improved median survival by 22 months. It improved from 24 to 49.4 months. So this was the game changer, and it changed the paradigm of treatment, and it improved the resection rates. So PCR was achieved in 29% of overall and 49% of common cell group, and 5-year OS increased from 33 to 47%. So based on this, the surgery was incorporated, and this changed the paradigm at that point of time. So this patient underwent surgery. Post-surgery, this patient had a residual tumor present. So the question now is, what next? Shall we put him on follow-up or any other options that we will advise this patient? That's what sir is also asking.
We are giving adjuvant nivolumab for such patients based on the data.
So the checkmate 577 comes into play. So checkmate 577 basically post chemoradiation, if there is a residual disease post surgery, then the role of adjuvant nivolumab is there. So basically high risk, I'll skip this. So it was a randomization 2-to-1, nivolumab versus placebo. for a year. It was continued, and results, it was a well-balanced study. So important point to note, whether you will be checking or segregating patient based on PD-L1 status for receiving adjuvant nivolumab?
No, sir.
No. So in this study, basically the PDL status was not required. It was just the patient who have residual disease, they will be eligible for receiving the nivolumab. So again, this patient had both squamous cell and adenocarcinoma patients. So this had both patients who had PD-L1 expression less than 1 and more than 1. So again, the same thing comes into question, the nutritional status. So post-treatment, post-surgery, the patient usually is not fit enough to receive the subsequent treatments, so nivolumab. So how long can we wait? So in this study, the cutoff was 16 weeks. 16 weeks means close to 4 months. So there was a subset analysis also which showed less than 10 weeks and more than 10 weeks. So advantage was there in the patients who had received it after 10 weeks. So basically, probably it may have, the micrometastasis might have appeared, which gave them the protection of additional of nivolumab or recovery of the counts. So clearly the curves are separating, showing the benefit of adjuvant nivolumab. First is in the intent to treat overall population. Second is differences in terms of squamous versus the adenohistology. Definitely benefit seems to be much more in the squamous cell histology as compared to the adeno group. So adjuvant nivolumab, we all agree, yes? Yes to all. Disagree? No disagreement. We would like to give as far as possible. So, but in our situation, our world, our part of the world, so any challenges, limitations, barriers to giving such treatments? Cost. But cost again now has become like it is with the now the availability of PAP programs is there, which brings us down to comfortable range. So apart from that, any other barrier, any limitations, the patient.
PAP program is available for Pembro. Nivolumab is.
Yeah, Nivo is there. Yeah, but apart from financial, other challenges like perception of the patient's behavior, like coming to the hospital, recurrent visit to the hospital, are those the barriers?
Yes, sir, that is definitely there, at least the visits. So generally I tend to prefer the monthly dose, although in trial they had initiated with 2 weekly, then switched to monthly.
So we all agree that we will tend to give nivolumab as adjuvant. Next year. Even cheaper, yes, sir. So this question we will skip. So again, it is again about the same thing. The scenario 2, basically I have changed it to adenocarcinoma, coming to ESOPAC. So ESOPAC is what? So it was FLOT versus cross surgery. The FLOT only contained, so what are the patients you would like to put in this group of patients, like into the ESOPAC study, the FLOT study, perioperative chemotherapy arm, rather than cross protocol arm? Which
we saw that PAP-CR reports for adenohistology was lesser. Those are probably the subset of patients.
See again, because clearly in this set of the patients, the ESOPAC is clearly superior in terms of PFS and OS. PFS and OS in terms of in the intent to treat patients. So do we need to change our practice? Do we need to look at our patients from a newer perspective in adenocarcinoma of the esophagus or in the GE junction patients as of today? So FLOT, we know the only challenge that comes is the nutritional status, which we can address by Riles tube or by other modalities. So clearly in adenocarcinoma, esophagus or GE junction is clear. So perioperative chemotherapy versus chemoradiation, again the challenges, if there are any. Any surgical apprehensions? No surgical apprehensions.
To tolerate FLOT quite well actually. Despite the prolonged infusion of 24 hours, the patients seem to tolerate it quite well.
Yeah, actually initially we all were very apprehensive with the triplet, with the FLOT, but somehow we have achieved our learning curve probably. The patients that tolerate it quite well now, and we are able to manage them quite well. So maybe, sir, in coming days, we are hoping so. Probably, sir.
And now with 18.2 zolbetuximab.
Zolbetuximab is
I'm
available.
sure, because these are practice-changing
Medicine.
data which was presented now at the last ASCO.
Correct,
That's
sir.
what I'm saying.
So in the metastatic setting, definitely they have made their way, sir. In the adjuvant and the neoadjuvant platform, they will, I think with passage of time, they will probably make their inroads there. So again, this will not go. The cross gear, top gear was a negative study. So basically, I'll stop here. So oncology is a rapidly changing field, we all agree. Newer modalities add to treatment advantage and outcomes, and multimodality treatment is the best way forward. With this, I thank you all for the patience listening, and thank you all the panels for being such a. Any other comment if you have to make, please feel free to ask. Any questions from the audience? With this, thank you very much. Thank you.
Thank you, sir. With the complexities in GI cancers, I think Sumit sir has given us a very good head start today for the next year. For the next talk, may I invite Dr. Vineet Talwar sir again. Sir will be speaking on PICC lines, choosing the right VAD. And also, sir will give us a few lines as a concluding remark on the GI cancer symposium.
Thank you again, Dr. Suman. And this is a talk on the venous access devices which we use in our daily practice and which we have been using for long. And I would just discuss the global guidelines, and we'll share our experience at RGCI. So these are the main challenges which all of us face day in and day out in cancer patients, whether it is the delivery of the therapeutics, or it is the nutrition, or it is the fluids, blood and blood products, testing, all of them come under the same gamut. So for that, you require a good vascular access device. If you don't have, then probably this is what you see, which fortunately nowadays we don't have because of the advent of the VADs or the vascular access device. So basically, the central vascular access devices are two. One is external catheters, and second is the implantable ports, which all of us know. And the external catheters can be non-cuffed, tunneled, or it can be a Hickman's that is cuffed and tunneled. Device type by insertion site, one is peripherally inserted like a PICC line or a Cowfix, or centrally inserted like a Hickman or a Portacath, whichever the situation might be. So how to choose? You have to see the prescribed treatment and therapy, anticipated duration of therapy, the vascular characteristics, the fluid or the medium which has to be infused, patient variables, that is age, comorbidities, history of IV therapy, preference of VAD location, and the ability and resources to take care of the device. So all these are there, but amongst them the most important is the duration and of course the prescribed treatment and therapy. And that is why you see that in the INS, that is Infusion Nursing Society, here if the duration is more than 1 week, then we tend to use the PICC line or the other non-tunneled CVADs. If the duration is more than 4 weeks, then probably we go for the ports. And it can be vice versa in these cases. Plus, wherever you have an irritant or a vesicant drug where you find that there might be a problem and there might be a vesication of these drugs and ulceration of the skin, then in those situations also you can use the CVADs in this. The intended lifespan, of course, is about 1 month in short peripheral IVs. And if it is more than 30 days, that is 1 month, then probably you can use the ports or the PICC line. And these are the PICC lines where you see this is the external side, the exit side, and you have the shuttle here and the cap with the stat lock. Typical uses, you have multiple IV agents therapies, you have irritants, vesicants. So there again you can use this, and also where you have the infusate osmolality of more than 600. So there also you can use the PICC lines. Nowadays we have triple chambers which are defined as the ones which can be used with a central venous access or a peripheral access where you have peri attached to the triple chambers. There also probably you can use the PICC lines. It has its own advantages. It has to be done by trained nurses. There has to be a team who can take care of the insertion care and of course maintenance, which is more important than insertion. It doesn't hamper mobility of hand. Most of the times whenever you have a long infusion, sometimes like a Folfox infusion where it is for 48 hours, in that condition you can use these PICC lines. It has a low infection rate of less than about 10%. If it is kept nicely and maintained nicely, then it can go on for about 6 to 9 months and can be removed very easily in case of infection or complications. But where you have the advantages, you have the disadvantages. It is always visible outside, and there is a risk of pulling out, especially in small children. It needs regular care and weekly dressing and flushing. You cannot swim with the PICC line, and since it is a small bore catheter, then high volume infusions cannot be given, and it is difficult, and there may be sampling difficulties in these patients. If you don't use a PICC line, then probably you can get an extravasation like this, which can be very, very unfortunate for the patient and of course for the physician who's treating these patients. Complications: phlebitis, local site infection, catheter block, catheter leak, tip migration, pain and swelling during infusion. So all these things can be there in these patients. How do you treat them? You give them antibiotics, medicine to dissolve clots, drain abscesses, and removal of the device can be there when there is no improvement in about 40 to 72 hours of treatment, or if the infection is by Pseudomonas or Candida, or sometimes if a reinfection takes place. So if there is a thrombosis, how do you treat it? You give medication to dissolve the clots with Heplock, mechanical clot remover, blood thinners, and sometimes it may resolve. You might not give any treatment on its own. There are prevention protocols, and you have to flush with 10 cc of saline. Adding heparin is optional now because most of these drugs can be taken care of with 10 cc saline. Proper frequency: you should do it at least once a week in PICC lines and at least once a month in the ports. And low dose blood thinners may help in certain situations, but not always. So we had our own experience in RGCI, and one of the ways to identify was to help to reduce CLABSI. Now CLABSI is the central line associated bloodstream infection, and this was done by bundling, which we now use frequently in our hospital. And this bundling was instituted by the Institute for Healthcare Improvement, that is IHI, and there is a small set of evidence-based interventions which can help in a defined patient population care. So what is this bundling? It is nothing but simple things like hand hygiene, use of maximum barrier precautions, chlorhexidine for skin asepsis, optimal insertion site, and daily review of line if necessary. So if you form all this, then definitely you can lead to decrease in the problems which occur in these situations. And we have our own data to quantify that, and you find that CLABSI, that is the central line associated infections, were about 1.57%, and if you see it with the historical cohort, you see it is 1.5 in 1.1 in Mayo Clinic, and we have 1.5. Other complications which are there, that is catheter blockage, leakage, fever, swelling, they were there and they were well managed because we have our own set of nurses who put in the catheters and who maintain the catheters and who keep on supervising in these patients. So I think I'll stop here. I thank you for your patient hearing. Thank you.
So So in fact, we are thankful to your staff that all our nurses are getting trained in PICC line in Delhi NCR. So next up, in the fag end of the sessions, can I have a very dear friend and colleague, Dr. Rajat Chanana. He'll be speaking on pembrolizumab in the management of advanced CRC. Over to you, Rajat.
So thank you so much. So I'll be discussing regarding the role of pembrolizumab in management of MSI high or deficient MMR advanced colorectal cancer. Slides are not moving. Okay, I'll use this. So we know that it is a common term that is used for cancer of colon and the rectosigmoid junction and rectum. It is the third most common cancer, fourth most common cause of cancer-related death, and the probability of suffering from colorectal cancer has been about 4 to 5%. So the CRC cases, they are at a rise, around 20% increase in India over the last decade. You can see it has increased to 6.9 per 100,000 persons, and HNPCC contributes to 10 to 15% prevalence in India, which is higher than the Western population. So the etiology is diverse. There are certain genes, mutations in the specific genes that is associated with colorectal cancer. On the basis of origin, it is classified as sporadic, which is around 70%. Second is inherited, that is around 5%, and familial, which is around 25%. So molecular testing has become a mandate for CRC management. So patients should be tested for KRAS, NRAS, BRAF, microsatellite instability, and HER2 testing. So what are the risk factors? There are certain risk factors which are linked to familial factors and genetics, IBDs, associated colonic polyps, diabetes mellitus, and there is some controversial role of prior cholecystectomy. Lifestyle factors, we know that dietary patterns like increased red meat and processed meat, diet low in fibers and fruits and vegetables. If the patient has lack of physical inactivity, overweight, cigarette smoking, alcohol, they are all linked to risk factor for CRC. So this is the NCCN guidelines for colon and rectal cancer. So I'll skip this. So this is the general management. So for early stage T1 node negative or T1 to T2 node negative, we can offer for very early stage option of endoscopic mucosal dissection, and in case of surgical candidate we can offer surgery also. Transabdominal resection is an option. For T3 N0 low risk also surgery depending on the histopath, surveillance or adjuvant treatment is required. There is a role of immunotherapy in deficient MMR or MSI high patients in locally advanced T3 or more node negative rectal or colon cancer. So this is just a brief overview of the NCCN guidelines management. So the clinical presentation, we all know it depends. There are a number of symptoms. Rectal bleeding is the most common symptom. Patient may present with abdominal mass, abdominal pain, change in bowel habits, weight loss. Patient may present with anemia. Then based on the site of distant mets, patient may have different symptoms. So the diagnostic aspects obviously remains a good history and physical examination followed by various investigations that are required. Usually colonoscopy and sigmoidoscopy is the first investigation. Then based on that subsequent imaging is done. So the role of microsatellite instability in colorectal cancer. So it is a short tandem repeat DNA sequences of 1 to tetra base pairs distributed throughout the human genome, particularly prone to replication errors that are normally repaired by the mismatch repair system. And mismatch repair system, it's a very highly conserved cellular process. Many proteins are also involved which help in the identification and repair of the mismatched bases. And deficient MMR results in a strong mutator phenotype called MSI. It is featured by widespread length polymorphisms of microsatellite sequences due to DNA polymerase slippage. So it is one of the major carcinogenic pathways of CRC. It is a molecular hallmark of hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. It is detected in 15% of sporadic colorectal cancers. So the presence of MSI serves as an important screening tool for Lynch syndrome. It is a prognostic marker for patient outcome. It is also a predictive marker for response to chemo and also immunotherapy. So there are certain clinico-pathological features. Most of the patients present with stage 2, 15% present with stage 2. It is characterized by mucinous features, tumor infiltrating lymphocytes, and they are commonly located in the right side. It has a poor differentiation with a medullary growth pattern, and patients with Lynch syndrome often present at an age of less than 50 years. So this is the molecular mechanisms of patients of MSI high. So it needs to have two distinct molecular pathways that contribute to the inactivation of MMR genes, HIT1 and HIT2 that we know. DNA methylation, also referred as CpG island methylator phenotype, that is CIMP, it occurs in 20% of CRCs and results in a non-familial form of MSI. So there are certain intrinsic characteristics of patients of MSI high cancer cells that makes them prone to immunotherapy. That is the high tumor burden. There is presence of increased PD-L1 and CTLA-4 expression. So there are certain factors, because we know that all patients do not respond to immunotherapy. Only 40 to 50% does. So there is something called as cold tumor, or also called as immune excluded tumors. So that is a feature of TGF-beta enriched tumor microenvironment, where there are abundant immunosuppressive myeloid cells and fibroid cells. So MSI or deficient MMR status has been associated with various CRC characteristics. As discussed, it is present on the right side. It usually presents with a larger size and a higher T stage, and distant mets may be present in around 15% of the, around 5% of the patients. So there are different pathomorphological characteristics. In terms of pathway, JAK-STAT immune evasion is one of the pathways, CIMP is one of the pathway. It is more aggressive disease with the expansile growth pattern and poor tumor differentiation, and it can also be associated with other markers, especially BRAF V600E. And in terms of immunological characteristics, it has high TIL levels and immune filtrate, whereas as compared to MSS stable, it is associated with different pathways as described in the slide, like the WNT beta catenin, TGF beta, and the integrin beta 3. It has low TMB, it has low TIL level, it has high T regulatory infiltration. And we have one Indian data of 300 odd patients, which has shown the incidence of as high up to 13%. And in patients with colorectal adenocarcinoma, mucinous adenocarcinomas were common among patients with deficient MMR CRC. So screening is important, and it is a mandate for all colorectal cancer. So there are three primary methods: PCR, IHC, and the last one is NGS. So NGS is the best out of the three. Next generation sequencing has the ability to interrogate thousands of microsatellite loci compared with just 5 to 7 loci that are detected by PCR. So it all depends on the institutional practice. I think most of the institute initially does the IHC, which is used to identify, which is used to indicate the presence or absence of functional MMR system. So the clinical significance of MSI is that there is a rationale for the use of immune checkpoint inhibitors in patients of MSI high colorectal cancer, because it selectively displays high-level upregulated expression of multiple immune checkpoint, and because of the blockade of the immunoregulatory mechanisms PD-1 and PD-L1 and CTLA, these immunotherapy molecules, they are found to be responsive in patients of MSI high. So coming to the evolution of CRC management, so we do know that chemotherapy remained the standard of treatment till very long. As of now, we do have options of targeted therapy, and from 2017, I think onwards, we have option of pembrolizumab and other immunotherapy in patients of MSI high colorectal cancer. So coming to the role of immunotherapy in microsatellite instability metastatic colorectal cancer. So these are the action mechanisms of immune checkpoint inhibitors. So PD-L1 binds to PD-1 and leads to inhibition of T cell killing of tumor cells. And the blocking of the PD-L1 or PD-1 allows the T cell killing of the tumor cells. So PD-1, that is nivolumab and pembrolizumab, and the PD-L1 inhibitors, they are used in the MSI high subgroup. And it allows the cytotoxic T lymphocytes to exert their anti-tumor effect, mainly in tumor with a high neoantigen burden. So now we do have guidelines to suggest in locally advanced also MSI high, we can use neoadjuvant immunotherapy, and probably in some patients we can avoid surgery if they achieve a complete clinical response with a stringent surveillance. So the unmet need is that we know that some of the patients won't respond to the immunotherapy, only 40 to 50% would respond, and the reason for resistance is that suboptimal neoantigen preparation and presentation, and the intrinsic T cell deficit such as the epigenetic modification, and alternative inhibitory T cells signal CTLA4 and LAG-G. So we know that pembrolizumab is a frontline FDA-approved drug for patients with metastatic for CRC with MSI high. So this is the Keynote 177 study where the inclusion criteria was patients with unresectable metastatic CRC with MSI high. They were randomized to receive pembro versus treatment of physician choice. So you can see that the PFS was 16.5 months as compared to 8.2 months, almost double. The overall response rate was 43.8% versus 33.1%. The OS data was not matured. And pembrolizumab also had lower grade 3 adverse event. So around 11% of the patients, they were able to achieve complete remission with pembro. So, the total overall response was around 43.8%. And the treatment-related adverse events also favored pembro. It was around 22% versus 66%. So these are the adverse events. I think we are all aware of the possible adverse event. It favored the pembro profile. So the 5-year follow-up of the Keynote 77 also favored pembro as compared to chemotherapy. 54.8% OS rates versus 44.2 with a hazard ratio of 0.3, and the benefit was seen across all the subgroups, even in hepatic and pulmonary mets, even in patients of BRAF, KRAS, wild type or mutant. So the PFS was doubled, 16.5 versus 8.2. The 2-year PFS was also 75. Was around 85% versus 33%. As discussed, the adverse event favored the only pembro arm as compared to chemotherapy. So the 5-year study states that the median OS was 77.5 months with the pembro and 36.7 months with the chemo arm. The 5-year OS rate was 54.8% versus 44.2%. PFS rate was 34 versus 7.6. The median duration of response was around 75.4 months with pembro. So the conclusion is that addition of the use of pembro in MSI high patients led to significantly longer PFS, led to significantly longer OS with lesser grade 3 toxicity, and it is the first IO that has been approved with 40% reduction in the risk of death or disease versus standard of care and doubling of PFS. So thank you.
Thank you, Rajat. It was a very nicely explained lecture. Next, can I have for a talk Dr. Bharat Chauhan, a very dear friend. He is practicing medical oncologist in Mumbai. He'll be taking us through the recent changes in the GU cancers in 2024. So, Bharat, is it loaded or? So can we have Ankur in the meantime? Yes. Ankur. So while he's loading his talk, I'll request Dr. Ankur Vashne to speak on role of IO and its sequencing strategies in management of HNSCC.
Thank you, sir. And whatever I'm going to discuss, we already knew. And I'm just reinforcing the facts with the more evidences. So I'm going to discuss the role of immuno-oncology drugs and its sequencing strategy in the management of head and neck squamous cell cancer. Slides. Okay. So definitely this is known to all of us. Definitely head and neck lung cancer is the second most common cancer in India owing to our tobacco chewing habits. And what is the importance that why we still focuses on it is the increasing incidence. What we got in 2020, we have expect a rapid rise in 2025 as per the data. So we see increase in all the cancers, including tongue, mouth, hypopharynx, and larynx, and these are expected to increase in both male and females, the significant number. So that is why, and still, our only 27% patients are having a localized disease, 68% are having a locally advanced disease, which have increased chances of relapse, and approximately 5% present to us at baseline METs. So this is the extent, and we always see patients of head and neck cancer in advanced stages only. And types of treatment, definitely surgery, radiotherapy, but maximum patients comes in the multimodality category where they need all of the three. So coming to the discussion of overall survival with multiple treatment regimes, and we have this data of extreme trial which was published earlier, and this has shown a median OS benefit with the combination of targeted therapy, with this was cetuximab, with platinum and with 5FU, with the increased overall survival just marginally. But what now NCCN guidelines includes this is pembrolizumab plus platinum based chemotherapy as category 1 recommendation, followed by nivolumab or pembrolizumab for any other category, and the cetuximab based chemotherapy combinations are used in further subsequent lines. So this is based on this data which we will study. This is the Keynote 40048 study, where first line pembrolizumab was studied in the treatment of patients with recurrent metastatic head and neck squamous cell cancers. And moving forward, so these were the patients who were randomized to receive either, these were the treatment naive patients who were randomized to receive either pembrolizumab monotherapy or pembrolizumab plus chemotherapy or the extreme regime. And what the primary endpoint was there, they have a risk stratification on the basis of PDL1, and the endpoint was overall survival and PFS. In the secondary endpoints, there was the risk stratification accounting to PDL1 percentage, and PFS and ORR were studied as per CPS more than 20, CPS more than 1, and in total populations. So approximately 882 patients were randomized, and in there 300 patients were receiving pembrolizumab monotherapy. 276 patients were treated with a combination of pembrolizumab plus chemotherapy, and 287 were patients receiving the extreme regime, that is cetuximab plus chemotherapy. Median follow-up was approximately 13 months in these arms, and we see the median age group was quite comparable. It was 62. Majority of these patients were males, and definitely 80% were either current or former smoker. If we see the PDL1%, approximately 22% of these patient population were having a PDL score of more than 50. Approximately 40% were having a CPS of more than 20, and approximately 85% were having a CPS score more than 1. So coming to the analysis of pembrolizumab monotherapy with this cetuximab regime, and we see in patient population who were having a CPS more than 20, the median OS that reported with the use of pembrolizumab arm was 3.4 months, and at 24 months we see approximately 14% of patients with the use of pembrolizumab with chemotherapy was surviving, as compared to the 4.8% with the use of extreme regime. In CPS population greater than 1, there was a slight benefit in the cetuximab cohort, with the, but at 24 months we had a data approximately 11.2% were patients were surviving with the use of pembrolizumab with chemotherapy, and only 5.4 in the cetuximab plus chemotherapy arm. So coming to the data of further, we see the OS benefit at 4 years. Approximately 15% of patients with the use of pembrolizumab plus chemotherapy arm was surviving, as compared to the 6% patient with the use of cetuximab plus chemotherapy. So in PDL expression more than 20, there comes a significant benefit, where at 4 years, after 4 years, approximately 21% of the patients with pembrolizumab were still surviving, as compared to the extreme regime. And this benefit was still shown in PDL with CPS more than 1. 16.7 patients were surviving, as compared to the 5.9% patients. Coming to duration of response, the median duration of response achieved with the use of immunotherapy was approximately 23.4 months, and with the use of extreme regime, it was 4.5 months. If we comes to duration of response as per PDL1 stratification, then in PDL1 CPS more than 20, median duration of response was 23.4 months. With extreme regime, it was 5.2 months. If we go in PDL1 CPS more than 1, then median duration of response was 24.8 months, and extreme regime, it was 4.5 months. The major adverse event, if we look at, then any grade adverse event reported with the use of pembrolizumab was reported in 58% of patient population, compared to 96% of patient population in the extreme regime. And grade 3-5 adverse event were 16% in the pembrolizumab arm and 69% in the cetuximab arm, and adverse event leading to death were 1% in the pembro arm, and death in the extreme arm was 2.8%. And the most common side effects were fatigue, rash, appetite. Moving forward, so we have the separate data with the pembrolizumab with chemotherapy arm, and definitely there are better OS and PFS rates, as we can see in these chart, and as expected, PD-L1 greater than 20 population showed a more benefit in PFS and OS as compared to the PD-L1 greater than 1, but this is quite sustained. And if we compare that overall population, then still overall response rate in the pembro plus chemo arm is quite better as compared to the PD-L1 in extreme regime, and median duration of response with the use of immunotherapy is quite better as compared to the targeted therapy. So, and the response is quite similar if PD-L1 expression is there. So coming to the side effects, the side effects are quite tolerated. So definitely long-term follow-up confirmed a statistically significant improvement in overall survival with the use of pembrolizumab versus extreme, irrespective of the PD-L1 expression in the patients. Duration of response with pembrolizumab or chemotherapy remained longer than the extreme regime, and safety analysis also added more benefit of combination of pembrolizumab either alone or with chemotherapy as compared to the targeted therapy. So definitely if we start them early, a better significant PFS and OS rates are being reported. And this is the subsequent line therapy. Keytruda versus monotherapy versus extreme had a better OS rate. Keytruda monotherapy versus extreme, a better PFS2 rates, and data supports Keytruda monotherapy as a new first-line standard of care for relapse and metastatic HNCC, which expresses PD-L1. Thank you. नहीं है.
Thank you, Ankur. Thank you for taking us through this, navigating us through the sequencing in head and neck cancers. Now, can I invite my very dear friend, Dr. Bharat Chauhan from Mumbai, to take us through the GU cancers. And in the meantime, can I also request Dr. Rakesh Chopra, sir, to please come on stage because he'll be summating this topic, and Dr. Rath, sir, for the last words in the conference. Thank you. This is last session.
Thank you, Suman, for giving me this opportunity. And at the outset, I must thank all the organizers and the Mice Ideas team. Dr. Samir, please on the dais. So this talk is made by Dr. Vikas. Unfortunately, he's not be able to make it. So on his behalf, I am presenting this. So basically, it was supposed to be a panel discussion. But now, at the end of the day, so we thought of, Suman suggested that we'll make it a small talk, which is being, these slides are being given to me by Dr. Vikas Talreja. So let's begin. So this is what we were supposed to discuss in a panel discussion, that initial therapy in muscle invasive bladder cancer. So we have now so many therapies like neoadjuvant cisplatin-based combination with radical cystectomy. We have NSCLC now followed by CTRT. So basically, variety of therapies are there. We have to choose our patient best, whether we can preserve the bladder in certain subgroup of patients, like with the bladder preservation protocol, whether there is a role of any adjuvant immunotherapy with the advent of newer treatments. So this is what, if we give neoadjuvant chemotherapy, if we see the ctDNA positive rates go down to 62%. If it was at the baseline is 62%, then it's go down to 37%. So basically, there is a definite role of neoadjuvant chemotherapy in a muscle invasive bladder cancer. So now we have a newer treatment landscape for non-metastatic urothelial cancer, like initially we were using intravesical BCG. Now we have immunotherapies, Keytruda, intravesical gemcitabine, and newer we have got this durvalumab. And then after good response with NSCLC, we can always think of radical cystectomy. So these are the variety of trials of chemoradiation which we know, RTOG, 85, 88, 89. So many trials have shown that the CR rates to the tune of 60 to 70% with the OS of 3 to 5 years. This has been proven in muscle invasive bladder cancer. So it's a phase 3 trial, BC2001 trial of RT, in which 2 arms, one was given 5 FUs RT plus other arm was RT. Both the, if we see the chemo RT and the radiotherapy arm, both the comparable, and if we see the OS in the CT RT arm was better as compared to the RT arm. That shows that there is a definite role of CT RT in this group of subset of patients. So Niagara trial, Durva plus neoadjuvant adding immunotherapy in a era in which in this group of patients, again significant benefit of Durva, adding Durva, be it EFS or pathological complete response rate or OS in intention to treat analysis, has shown that there is significant benefit of adding Durva in this subset of patients. Again, checkmate trials 274, Neo versus placebo. It has also shown good benefit. We'll come to the curves now. If we see in Nivo, the curves are really separating in those who are having good PD-L1 expression, as we see in other cancers. Basically, the immunotherapy also working well in this subset of patients. As the curves tend to separate later, as we see in other immunotherapy, early on they are close together, and the later on as the treatment goes, the deeper response sets in and the curve separates. Ambassador trial, adjuvant Pembro versus observation in MIUC patients. Again, if you see the curves in this, that it has also shown that the in DFS it has shown a clear-cut benefit, but if you see the OS data, the curves are almost similar. So the benefit may be outweighing in longer term, longer follow-up in OS. But in EFS and PFS, there is definite benefit of giving adjuvant Pembro. So ESMO guidelines, if we see treatment naive, locally advanced or metastatic urothelial cancer, we always used to divide cis eligible or cis carbo eligible. Then we have now a variety of options with Nevo plus chemotherapy. Now we have Pembro also, Atizo, then maintenance Avelumab, then newer drug called Enfortumab vedotin, which is not available at the moment but shown promising results in these patients. So treatment landscape, if you see December, this is what we have discussed. The only part is we have to also think about HER2 positivity in these patients. It has shown good benefit that trastuzumab deruxtecan, checkmate 901, Neo plus Gemcis versus Gemcis in metastatic urothelial cancers. If we add immuno with over and above chemotherapy, let's see the response. And if we see again the same, once you add immunotherapy in these patients, the curves separate. Initially they are close together, later on they separate and show good benefit, be it PFS or OS, both the curves are showing decent benefit, and there is a definite role of giving Nivo over and above chemotherapy. Response rates, you see 58% versus 43, CRs are higher, PRs are also higher, and good quality of life. First line we have got Enfortumab plus Pembro versus CT for locally advanced and metastatic cancers, which we have discussed a few slides back. Again, if we add, but the toxicity increases if you see the curves are really separable. The PFS versus both the PFS, OS, even the PFS is far apart, and OS also, definite benefit over and above the chemotherapy. So 301 overall response rate, this we'll skip this. 301 we have discussed. So this drug again withdrawn, not shown much benefit. Destiny trial for this bladder cancers, FDA approval, Destiny trial, yeah. Again, trastuzumab deruxtecan has shown benefit in this group of patients and a good PFS and OS. So across all tumor types, this is, we'll skip. Drop to, what are the key questions for treatment after EVP? This will skip the panel discussion. And this is, will come to the now Hercules trial for the penile cancer, pembro plus platinum-based CT in advanced penile cancers. If we see, if we add pembro over and above chemotherapy, let's see the response rate as well as these benefits. CR1, PR only 12, stable disease 7, progression 11. So overall lower bounds of 95% clearance for confirmed overall purpose. This has also shown some benefit in penile cancers. So 31 patients with measurable disease at baseline versus more than one post-assessment. 75% experienced tumor shrinkage of any degree. But after a median follow-up of 24 months, median PFS 5.4, median OS 9.6. Not very convincing. Thank you. Sort of a very run-through slides. But thanks a lot, Sumant and the Mice Ideas team for giving me this opportunity. Thanks, and thanks Vikas for sharing the slides. Thank you.
I think urothelial cancers have been one cancer where one of the first uses of immunotherapy was proven, like BCG, still using it. And now with the improved immuno-oncology regimens, things have become better. We have been using BCG for a long time.
I've been requested to summarize GU oncology in 5 minutes. Now that is quite a task. इसको कैसे रन करते हैं? या इसको ये वाला जाएगा ना सर, ये वाला इससे आगे इससे जा रहा है, इससे जा रहा है, इससे आगे ठीक है. Okay, I'm going to cover three topics, that is bladder cancer, prostate cancer, and renal cancer. Please forgive me if I overshoot my 5 minutes, but I think this would summarize quite a bit. So the objective is highlight the transformative advancements in urinary bladder, renal cell carcinoma, and prostate cancer, including prostatectomy. I had requested Dr. Patel to talk on the surgical aspects. I had given him some slides. I don't know whether he's here or not. And the focus is on practice-changing medications, key procedural and therapeutic updates, and clinical trial data. Now coming to the urinary bladder transformative therapies, immunotherapy has obviously revolutionized treatment. First-line therapy approved for platinum ineligible patients. Examples are the atezo and the durvalumab. Second-line therapy is superior to chemotherapy in the metastatic setting. Example, pembrolizumab. And maintenance therapy, the IO agents maintain responses post-platinum chemotherapy. Now, this slide has been given to me by Dr. Sona Pavde, an old friend. Now, when you come to the treatment, the cisplatinum eligible, the first-line therapy is EV and pembrolizumab, or GEM-CIS and Nivo, and GEM-CIS followed by avelumab as per the Javelin trial. The second-line therapy in this setting is post-EV pembro, it's GEM platinum, dafitinib, that is for the FGFR3 mutation or fusions positive patients, or TDXD for the HER2 IHC3+. Post GC and Nivo, that's the Javelin, you have the dafitinib for the FGFR mutation fusions, or EV. You notice I've struck a red line through the secukinumab, Govitcan, because that indication has been withdrawn, and so now that is no longer in use in this kind of setting. The TDXD is for the HER2 IHC3+. Now, post PD-1 inhibitor, you have GEMS and platinum. You have EV for cis ineligible, dafitinib for the FGFR mutation fusions, and TDX for that. Post platinum, you have pembro or nivo or avelumab, EV for the cis ineligible, and TDX2 for the HER2 positive. For the cisplatin ineligible, you have EV plus pembro or gem carbo followed by avelumab. For the platinum ineligible, chemo ineligible, pembro is the treatment of choice. So this is the in the first line, second line, and for the late salvage, you have EV, TDXD for the HER2, and you have dafitinib, taxane, or vinflunine for that group of patients. This summarizes the metastatic urothelial cancer therapy as of in December 2024. So the keynote 045, pembro versus chemo in second line, OS is 10.3 months versus 7.4 with a hazard ratio of 0.73. The IMvigor 211, atezo in platinum refractory settings, where the median overall survival is 11.1 months. So this is the scheme for the first-line therapy of metastatic urothelial cancers. You have an advanced urothelial carcinoma. If a clinical trial is available, use it. If it's not available, in the cis eligible or ineligible visceral metastases and a fit patients, EV pembro. If it's a cis eligible lymph node only metastases and or liver dysfunction, poorly controlled diabetes, GC nivo. If it's a cisplatin ineligible, any site of metastases, a frail, vulnerable patients, gem carbo followed by avelumab. And if it's platinum ineligible, then pembro. So this is a very nice cartoon which shows you the proposed scheme for a first-line therapy for metastatic urothelial cancer. In the adjuvant setting, IO agents are approved. Evidence of disease-free survival improvements, trials, IMvigor 010, atezo in high-risk post-surgery patients, and key benefits are reduced recurrence rates in the muscle-invasive bladder cancer. Now coming to we switch gears to renal cell carcinoma. You know all this, but I'll just run through. Initially, we used to use MVAC, but you all know that it's a very toxic regimen. Then we went on to 2007 when we used Sutent. And we actually from India are responsible for the current dosing of Sutent, because at that time the dosing was much higher, and we found that lower doses, I think it's 50 milligram a day. Am I right? Or are we using 25 now? No answers? Everybody sleeping? Okay, so we've started reducing the dose of Sutent because we found that it was quite toxic. 2010, everolimus for second-line therapy. 2015, immunotherapy entered. Nivo approved for second line. 2018, double IO combinations, Nivo plus IPI versus sunitinib. And the hazard ratio for the overall survival was 0.66%, with an overall response rate of 42% versus 29%. Then came the IO with the TKI combination 2019 as first-line standard, pembro plus axitinib. 221 approval of Nivo plus cabozantinib. The key benefits were synergistic mechanisms which enhanced the efficacy and improved progression-free survival and OS survival across various risk strategies. So the take-home messages are first line, EV plus pembro, all comers, GC plus Nivo, cis eligible, Javelin bladder, 100 paradigms, gem cis, gem platinum, followed by maintenance AVI. Adjuvant therapy, durvalumab improves EFS and OS the Niagara trial. Nivo approved Pembro pending approval. Emerging therapies, TDX, HER2, IHC3+, of course the new ADCs, dual EGFR plus HER3. Intravesical therapies, TAR-200, TAR-210. The key innovations are tumor-informed ctDNA for MRD detection. The challenges are prior peri-op PD-1 or PDL1. Inhibition impact is unclear, and the trials are crucial for advancing treatments. The NEJM 2018, Nivo plus IPI versus sunitinib in RCC, OS not reached versus 26.6 months with a hazard ratio of 0.66. Clear study, lenvatinib plus pembro versus sunitinib. The PFS was 23.9 versus 9.2 months with a hazard ratio of 0.39. The adjuvant therapy breakthrough in RCC, pembrolizumab approved in 21. Adjuvant setting, DFS benefits for intermediate and high-risk RCC. Failure of TKIs, no significant benefit in the adjuvant setting. So, in systemic therapy of clear cell RCC, first-line systemic therapies, if is divided into favorable and intermediate or poor. For the intermediate and poor, the IO plus IO, that is Nivo plus IPI, intermediate risk, poor risk only. For the favorable, IO plus TKI, Pembro plus axitinib, AVI plus axitinib, immature OS data. Nivo plus cabozantinib, and Pembro plus lenvatinib. You also have TKI alone for a select group of patients only, that is sunitinib or pazopanib for the favorable group, and cabozantinib for the intermediate and poor group. For subsequent therapies, IO-based Nivo, if no prior IO, IO-based combinations in specific circumstances. TKI alone, cabozantinib, axitinib, tivozanib, or pazopanib, sunitinib, sorafenib. mTOR inhibitors, everolimus, TKI plus mTOR, lenvatinib plus everolimus, or HIF2 alpha 1 in a certain group of patients. I think this summarizes the systemic therapies for renal cell carcinomas. Now coming to the prostate cancer, landmark trials, the Chartered and the Stampede, early systemic therapy for metastatic CSPC, benefits of docetaxel with a hazard ratio for OS improvement of 0.61, abiraterone hazard ratio for OS improvement 0.63. The take-home messages for kidney cancer, sorry, I think I've got my slides mixed up a little bit, but anyway. First line, VEGF plus IO or IO plus IO combinations based on IMDC risk grouping. Refractory setting, reintroduction of PD-1 or PDL1 inhibitor with a VEGF inhibitor shows no benefit. Emerging therapies, belzutifan improves outcomes in advanced clear cell RCC post-VEGF or PD-1. Combination therapies, example, len-pembro plus belzutifan are under investigation. The biomarkers and trials, their predictive biomarkers are emerging, but not clinically validated. Phase 2 trials for non-clear cell RCC, example PD-1 or PDL1, and chromophobe RCC. The challenges are the trials critical as current therapies fail to cure advanced cancers. Prostatectomy in prostate cancer, advancements are robotic surgery, high precision. I'm not competent to talk about these things, but anyway, higher precision, reduced morbidity, enhanced recovery protocols implemented, and post-prostatectomy adjuvant therapies like abiraterone, IO, etc. So the systemic therapy for prostate cancer in 2023, it's a little old, For the local therapy, non-metastatic CSPC, abiraterone or enzalutamide, or non-metastatic CRPC, apalutamide, enzalutamide, or darolutamide. That is the androgen deprivation therapy, ADT. This is for the non-metastatic group, the castrate-sensitive CSPC. For the metastatic CSPC, you have docetaxel, abiraterone, apalutamide, enzalutamide, docetaxel with abiraterone, docetaxel with daro, and XRT for oligometastatic disease. First-line metastatic CRPC, Ciplucil-T, abiraterone, enzalutamide, docetaxel, radium-223, abiraterone plus olaparib if this BRCA1 or 2 positive, abiraterone plus niraparib if BRCA1 or 2 positive, enzalutamide plus talazoparib has HRR, the lutetium PSMA plus NHA, second NHA, and XRT for oligometastatic disease. Now, if you have a refractory MCR PC, cabazitaxel, olaparib if HRR, rucaparib if BRCA1 or 2, pembro if MMR deficient and TMB high, and lutetium PSMA. This constitutes the metastatic castrate-resistant prostate cancer. So coming to the comparative data or summary, in urinary bladder, IO, example pembro, the PFS benefit is significant, OS benefit is significant. In RCC, IO plus IO or IO plus TKI, hazard ratio 0.39 to 0.77, and in the PFS benefit and the OS benefit, hazard ratio is 0.66. In the prostate cancer, abiraterone docetaxel, it's significant. The hazard ratio is 0.61 to 0.63. So in urinary bladder cancer, IO is now standard in multiple settings. In RCC, in the adjuvant setting, integrated into high-risk cases. In prostate cancer setting, early systemic therapy reshapes the high-risk management. Now, just a word about this. This is the advanced prostate cancer is not one disease. There are many genomic subtypes. The key druggable genotypes are mismatch repair defective, that is PD1 or PDL1. There's the CDK12 allelic alterations, that is PD1 or PDL1 probably. The BRCA is biallelic loss, that is PARP1 or platinum. The PALB2 biallelic loss, PARP1 or platinum. Other key PARP1 sensitizing DNA repair gene allelic loss, including ATMs. The PTEN loss, PI3K or AKT blockade. And for AR mutations, third generation AR blockers. So as you can see from here, there are these various pathways that get into advanced prostate cancer, and therefore it is not just one disease, but it's a multitude of diseases. Sorry. Oops, sorry. So intra-patient heterogeneity and resistance. It's recognized by Gleason in his score, now an incontrovertible fact. Explains mixed responses on serial scans to differentiate. You know, I don't know if any of you have noticed this, but sometimes your PSAs are normal, but the PSMA scan does not corroborate with that. This is what it is. This intra-patient heterogeneity and genomic instability is driven by the AR blockade, with tumor cells switching from the luminal to a basal, EMT, senescent phenotype to survive, probably reversible. This often, but not always, involves the RBI TP53 loss, is implicated with endocrine therapy resistance, and is described arguably incorrectly as neuroendocrine change, but perhaps is best called transformed disease. There are many new therapeutic strategies being pursued. First is the selective tumor cell kill remains the holy grail, targeting the AR gene splicing AR splice variant generation and signaling, cell signaling inhibitions, that's the AKT, JAK, STAT, FGFR, RAF, MEK, WNT, Notch, and CDK4/6, mixed signaling inhibition with bipolar androgen therapy, targeting inhibitors of apoptosis, the MCL1, BCL-XL, BCL2, and BIRCS-C5, eradication of the senescent or the EMT tumor cells by senolytics, novel synthetic lethal strategies with RB1 loss, ATM loss, or genomic instability, targeting tumor cell metabolic dependencies, example glutamine metabolism, reversing the epigenetic remodeling of the prostate cancer transcriptome by EZH2I or LSD1I, and then blocking the microbiota generation of androgenic and other metabolites. So a lot of research is going on currently, and the rational therapeutic combinations likely to be clinically important to change the care or transform the care. The targeting of tumor cell surface antigens. Antigens need to be primarily expressed on the tumor cells. The radionuclides, immunoconjugates, radioimmunoconjugates, B7H3, TROP2, HER3, DLL3, CD46, HER3, all these, etc., are the various targeting tumor cell surface antigens. There's novel immunotherapy strategies like multi-specific antibody constructs, that's the BiTEs, the CAR-T cells, preferably multi-agent targeting dial-off switches, the alpha-delta T-cell anti-tumor activation, CAR-T cell constructs or activators. There's no requirement for antigen presentation by MHC complex in this group. Immune checkpoint inhibition, that is novel checkpoints combinations, and reversing the T-cell exhaustion, example adenosine axis and TGF-beta signaling. The targeting tumor cell antigens need to be primarily expressed in tumor cells. I think this is a duplicate, if I'm not mistaken. Let me just go on. So the conclusion takeaways are, immunotherapy has transformed uro-oncology. Systemic chemotherapy now is an integral to high-risk management. Next steps are incorporate evidence into practice and focus on patient selection and personalized therapy. And I thank you for your attention.
So thank you, Sumant, for a wonderful day. And Dr. Chopra brought out a beautiful synopsis of the whole thing. And it was a wonderful day, good day of learning. Being a surgeon, let me leave you with a few thoughts, because we didn't talk a lot about surgery today. Naturally so, because there were less of us. But I think basically what has changed in surgery is de-escalation. Whether it is the breast, de-escalation in the axilla. First we began with de-escalation in the primary organ, breast, and organ conservation we have been following for the last 30 years. But now de-escalation in the surgery, which means even for larger cancers, enough randomized controlled trials have proven that you need to omit, for instance, things like axillary surgery, things that left you with a lower quality of life. So you became more conscious of quality of life. Similarly, robotics has entered full throttle. And it's just getting better. There's absolutely no scope of denying the entry of robotics into the field of oncology or surgery as a whole. So RAMI, TORS for that matter. We didn't talk about the TORS when we talk about the head and neck. Helps you beautifully, helps you in difficult situations, salvage surgeries, because you see a lot more, and in situations where you can not do any better. The third thing, it is all about biomarkers and companion diagnostics and minimal residual disease, because that's the way it is going. Histology is becoming less important. Another small thing, although we've ignored it for too long, but we've come back to it, which is tumor microenvironment, stroma, and the differentiations thereof. So altering the tumor environment, which means simply TILs, tumor infiltrating lymphocytes, they have started conveying more of a message. So These are the things that have sort of come in, and they're coming out with the results of the trials that you keep, going for now. So things have changed, and it's good to keep track of them and incorporate them. And I think all research has to be translational. Unless the effects of research are favorably enjoyed by the patients, finally, it really doesn't make a lot of sense. So thank you very much.
Besides the improvements in treatment which we have discussed this morning, doing lesser surgery, more aggressive immunotherapies, lesser chemotherapy, lesser toxic chemotherapies, and better radiotherapy techniques are happening, and that is what has translated into better survival. And what has been done, particularly in our country also, is a lot in the preventive aspects. We have prevented a lot of tobacco-related and cervical cancers. 15 years back, cervical cancer was number 1, it is now number 2. Second thing is very important, that the early diagnosis is getting better and better. And this meeting has been a wonderful meeting, and all of us who have attended, including the postgraduates, have learned a lot. And in this meeting, 150 participants have attended physically, and there are 450 who have attended online. So that's a great thing which has happened. And if you see the quality of presentations and the take-home messages have been very, very useful and crisp. Of course, it's very difficult to do everything in a short time, but it has been a wonderful meeting. Thank you very much.
Russia invented a cancer vaccine, whatever that means. You can tell me.
I would request Rajeshi and Sumati to send these presentations out to the in the community, to the oncologists. Huh? It is wonderful, because I think the quality of presentations have improved tremendously, and there's a lot of science behind all these presentations, and I think this would be very useful to people in their day-to-day practices to be able to incorporate some of this, or at least study that so that they can see the good from the useless and try to incorporate it in their day-to-day. And I thank Sumaji and Rajeshi for this inviting us. It's been a long day for me. I haven't sat in a meeting for this long in a long time, and I came at 9, and this is the last session.
What is the problem?
Thank you so much. Should invite us to Jodhpur. It's a lovely city.